Good morning. I am Dr. Manish on behalf of Department of Anesthesia. Welcome you all to this academic feast. We have tried our best to cover as many aspects as per requirement of your exams. So each session is divided into 3 or more topics, and whole day is divided into 2 main events. So after one event you have quiz, and in the evening you have quiz. So quiz will comprise of 20 questions, and in the end, after 5 quizzes, the main winner will be felicitated. Okay, and keep yourself hydrated and energetic. There is ample amount of water, tea, and food for you. So please enjoy and have. Please gain knowledge from our speakers. Okay, and the schedule will be tight. Actually, we have many lectures, 60 lectures, and each lecture is about 20 minutes. So in between lectures, you have very less time to go here and there to ask the questions. So it will be a tight session uh, because we have only 3 days and we have to cover many topics. So now we will start our PG assembly. This is our first PG assembly. Okay, please start.
A very good morning to everyone. I, Dr. Akanshita Tiwari, would now like to begin our first session by calling upon our respected chairpersons, Professor M.P. Khan Sir, Professor, Department of Anaesthesiology and Critical Care, KGMU. His area of interests are transplant surgery and head of biomedical waste management. Next, I would like to call upon Professor Ajay Chaudhary Sir, Professor, Department of Anaesthesiology and Critical Care, KGMU. His area of interest is pain management. Kindly come to the stage, sir. Thank you, sir.
Hello. Hello. So, without wasting any more time, I will call upon the first speaker, Dr. Manish, who is the assistant professor in our department. He is PDCC Neuro and Critical Care Anesthesia. So, I think it will be better to start at time rather than wait for the other contestants.
Good morning, everyone. Myself, Dr. Manish Kumar Singh, Assistant Professor, KGMU, Lucknow. And topic that I'm going to discuss with you is pre-op check and safety features of the anesthesia workstation. Let's see the brief history. The first anesthesia workstation, anesthesia machine was developed in 1917 by H.E.G. Boyle. And after that, there was several modification and added safety features that's now we have the modern anesthesia workstation. And this is the pre-operative check. Basically, before giving anesthesia in the we have to check the anesthesia workstation in the morning, and there are the fixed step of check. So first you have to connect the power supply, next gas supply, then after you have to check the functionality of the valve, and after that you have to start workstation. There is a diagnostic run, then after calibrate flow sensor, oxygen sensor, and system leak and compliance test. So with the help of this short video, we can see the pre-operative check.
The daily checkout procedure to ensure that your Fabius GS Premium is up and running. In your instructions for use, you will find a detailed description of each and every step we are going to go through. First, connect all central gas supply hoses and the power cable. In this case, we will only use oxygen for gas supply. To check that all medical gas connections are connected properly, verify that the central gas supply pressure is within an acceptable range. To check the filling level of each gas cylinder, you simply may have to open the cylinder and check the pressure. On an anesthesia machine equipped with pin index connectors, you can read out the cylinder pressure gauges below the vaporizers. Open and close every single fresh gas control valve to ensure that gas is flowing. You may also want to check the correct functionality of your oxygen flush. Let's have a look at the breathing bag to test if it's properly connected and works. Switch on your Fabius GS Premium and wait for the system diagnostics to be carried out automatically. Next, we perform the necessary calibrations and tests. Calibrating the Fabius GS Premium sensors is really easy. To calibrate the flow sensor, press the Calibrate Flow Sensor key and follow the instructions given on the screen. Close all fresh gas control valves. The breathing system is called COSY, short for Compact Breathing System. Remove the expiratory hose from the COSY and press the rotary knob to start the flow sensor calibration. After the calibration is finished, reconnect the expiratory hose onto the COSY. Additionally, make sure to calibrate your oxygen sensor every morning. To do so, simply select Calibrate Oxygen Sensor. Remove the oxygen sensor for 2 minutes and press the rotary knob to confirm. After the test, reinsert the oxygen sensor onto the breathing system. Now that we have calibrated both sensors, we are going to perform the leakage and compliance test. Therefore, press the respective key and follow the instructions on the screen. Close all fresh gas control valves. Secure the Y-piece on the park position on the breathing bag port and seal the sample line connector, if applicable. Switch the APL valve to manual and set a pressure between 40 and 50 hectopascal. Then press the oxygen flush to build up a pressure between 15 and 30 hectopascal. When the test is completed, the results are shown on the screen. Press the rotary knob to return to the standby screen. On the standby screen, you can see the result of the last system test, as well as the last leakage and compliance test results. Switch on the power supply of the optional COSY heater.
The video source of this video is the YouTube, okay. And then now we have to go for safety feature of anesthesia workstation. As the functionality of the anesthesia work increases, this also lead to the increased chances of mishappening. So the time to time there is a add-on safety features by the manufacturers. So we can divide the safety feature of the workstation according to the different part of the workstation. And the safety features in gas supply, flow meter, vaporizer, fresh gas delivery, scavenging system, and the monitoring. And the functionality of a workstation can divide into the two parts, that is pneumatic system and the electric system. The part of pneumatic system is high pressure system, intermediate pressure system, and the low pressure system. In high pressure system we have cylinder and yoke assembly. And cylinders and yoke assembly, and the safety features in cylinder and yoke assembly are cylinder basically are color coded, like blue for nitrous, and black and white solder for oxygen, and gray and white solder for air. And also there is a symbol mentioned on the yoke assembly and also on cylinder. And the next is the pin index system. Pin index system is basically a part of yoke assembly. Here we have pins which are 4 mm in diameter, 6 mm long, and are placed as an arc on the circumference of circle, which goes to the radius of 9/16 inch. Basically ये जो है एक yoke के पे आपके arrangement होता है 9/16 के radius में 1, 2, 3, 7, 4, 5, 6 के, और ये arrangement basically ensure करता है कि आपका wrong attachment ना हो. तो पिंस जो होती हैं यॉक पे होते हैं और कॉरेस्पॉन्डिंग होल्स जो होते हैं आपके वो होते हैं सिलेंडर पे. As we see in this picture, cylinder have corresponding holes and the yoke assembly have pin. Next is the cylinder pressure indicator. These are also color coded, blue for nitrous and white for oxygen. Next is pressure regulator. providing a constant low pressure suitable for the machine from the variable high pressure cylinder, क्योंकि प्रेशर जो होते हैं सिलेंडर्स में वेरिएबल होते हैं, नाइट्रस का अलग होता है, ऑक्सीजन का अलग होता है, तो एक क्योंकि जो सिलेंडर जुड़ा होता है हाई प्रेशर सिस्टम का पार्ट है, तो हमको उसको एटलीस्ट एक मीडियम इंटरमीडिएट प्रेशर सिस्टम का पार्ट कन्वर्ट करना पड़ता है। तो सिलेंडर जो प्रोवाइड करता है इंटरमीडिएट सिस्टम प्रेशर सिस्टम में प्रोवाइड करता है 45 psi, और जो पाइपलाइन सिस्टम आता है उसका होता है 55 psi। तो ये ऐसा इसलिए डिफरेंस इसलिए रखते हैं कि अगर सिलेंडर प्रेशर अगर ज़्यादा होगा तो वो ऑटोमेटिकली खुद डिलीवर करने लगेगा। तो इसलिए क्योंकि सिलेंडर आपका क्या है, एक तरह का रिजर्वायर है, हम नहीं चाहते कि जब जरूरत हो तब उसको यूज करें, इसलिए क्या है बेसिकली वो तब उसका इसका प्रेशर रिलेटिवली कम होता है। ये 45 psi पे वर्क करता है और वो 55 psi वर्क करता है। Now intermediate pressure system. The part of intermediate pressure system is the pipeline inlet connection. The safety feature in pipeline inlet connection are the non-interchangeable screw thread, diameter index safety system, and Schrader probe, hose pipe, machine end. Okay, this is the in the first picture we can see that the Schrader probe. This corresponds to the diameter index system of the pendant. बेसिकली ये डायमीटर स्पेसिफिक होता है फॉर पर्टिकुलर गैस के लिए, और ये उसी से करस्पॉन्ड करेगा, उसी में अटैचमेंट होगा प्रॉपर्ली इसका। दिस इज द मशीन एंड ऑफ द गैस पाइपलाइन, एंड यू कैन सी दैट हियर दैट द पाइपलाइन इज आल्सो कलर कोडेड, ब्लू फॉर नाइट्रस, व्हाइट फॉर ऑक्सीजन एंड ब्लैक एंड व्हाइट फॉर एयर। एंड हियर यू कैन सी दैट द अरेंजमेंट ऑफ नट्स एंड प्रोब्स. Nuts is not specific, is same for all gases, but the probe is have different lengths. So अगर probe आपका properly insert नहीं होगा तो nut tight ही नहीं होगा, ये एक तरह का safety mechanism है. Next part of intermediate pressure system are pipeline pressure indicator and second stage pressure regulator, auxiliary gas outlet, oxygen flush, flow control valve, and oxygen failure device. Pipeline pressure indicator. Here we can see that the pipeline pressure indicators are also color coded. Nitrous blue color and air black and white and oxygen white color. And यहाँ पे एक proper satisfactory working zone भी mention है green color से. तो before आप work station start कर रहे हो तो आप please mention कि उसमें आपका जो working zone पे आपके pressure होने चाहिए. नेक्स्ट इज ऑक्सिलरी गैस आउटलेट. आप देखा होगा कभी कभी साइड में कुछ वर्क स्टेशन में साइड में दिया होता है ऑक्सिलरी गैस आउटलेट. इसका फायदा ये बेसिकली ये अगर मशीन ऑन नहीं है तो भी ये वर्क करता है, ठीक है इसको, और इसमें मैक्सिमम फ्लो 10 लीटर तक है एंड सप्लाई ऑफ ऑक्सीजन मतलब इसमें नहीं डिपेंड नहीं है कि मशीन ऑन हो ऑफ हो. तो फायदा ये है कि अगर इन केस अगर सपोज दैट कि इन दिस पिक्चर वी हैव द नाइट्रस, एयर, ऑक्सीजन एंड द फ्लोमीटर, डायरेक्शन इस तरफ है, ठीक है. अगर एक्सीडेंटल अगर ये सिचुएशन रिवर्स कर देते हैं, ऑक्सीजन को इधर कर देते हैं, नाइट्रस को इधर कर देते हैं, और एनेस्थीसिया आप दे रहे हो किसी पेशेंट को, नाइट्रस भी चल रही है, ऑक्सीजन भी चल रही है, और सपोज दैट कि अगर यहाँ कोई ब्रेकेज है एयर में तो उसमें होगा क्या, ऑक्सीजन जो टोटल हम दे रहे थे एटलीस्ट सपोज दैट कि हम 2 लीटर दे रहे थे तो टोटल 2 लीटर में जाके उससे कुछ लीक आउट हो जाएगा आपका इधर साइड इस जो ब्रेकेज है. तो उससे क्या होगा, अगर ऑक्सीजन यहाँ नाइट्रस यहाँ पे है तो टोटल जो मिक्सचर जाएगा वो बेसिकली क्या होगा आपका जो जाएगा नाइट्रस का जाएगा. तो ये एक तरह का हाइपोक्सिया क्रिएट कर सकता है. तो इसके लिए हम क्या करते हैं कि ऑक्सीजन को हमेशा डाउन स्ट्रीम रखते हैं. एंड द बैकग्राउंड इज रेडियो फ्लोरोसेंट so that you can see in ambient light. Control knob, again control knob have a specific feature for oxygen that it is largest and protruded and have special tactile features. And tubes are which are which measure flow we have different length and diameter, and tube are leak proof and also have anti-static coating to prevent the bobbin from sticking. Hypoxia prevention device, and some manufacturer made the minimum mandatory oxygen flow that the machine minimum preset oxygen flow रखता है that lies between the 50 to 250 ml per minute. Actually जैसे ही आप क्या करते हो मास्टर स्विच स्टार्ट करते हो एक मिनिमम फ्लो 50 to 250 लीटर का स्टार्ट हो जाता है, And in DETEX OMEDA, we have the minimum oxygen ratio, that is the link 25 proportionating system. As the name suggests, link and 25. This is the link between nitrous and oxygen, and that ensures the minimum 25% of oxygen. Actually, this system is work on that when ये nitrous and oxygen independently work कर रहे हैं, but when the ratio of nitrous and oxygen goes more than 3:1, तो वो ensure करता है कि at least 25% of oxygen जरूर जाए. In Drager, we have sensitive oxygen ratio controller. A register generates back pressure on control diaphragm in proportion to the oxygen and nitrous oxide. SORC guarantee a minimum FI of 21%. And also we have oxygen ratio monitor controller. And safety feature in vaporizer. So vaporizer, basically the dials are color coded. And push button release, there is a push button on the dial. You cannot start the vaporizer without pushing this button. And there is an interlock mechanism in between the vaporizer. You can start only one vaporizer at a time. And separate transport setting for transport. And the special filling system, that is the keyed filling or funnel filling. You can see that the color coding of the vaporizer, purple for the isoflurane and blue for the desflurane. And corresponding color coding is also present on the bottles. And this is the button is a push button. And this is the transport system. Basically, अगर आप उसको ट्रांसपोर्ट पे डायल को नहीं लाते हैं तो वो अनलॉक ही नहीं होगा, आप अनमाउंट नहीं कर पाएंगे, यू कैनॉट अनमाउंट इट. Next is scavenging system. Basically, the fresh gas outlet has a specific diameter, 15 and 22. This is universal. And in scavenging system, we have the diameter of 30 mm, so that this lead to the मतलब इंटरकनेक्शन ना हो जाए इन केस, तो इसलिए इसको 30 mm का डायमीटर होता है बेसिकली. एंड लास्ट वी हैव द सेफ्टी फीचर इन मॉनिटर. मतलब अपार्ट फ्रॉम सारे सेफ्टी फीचर के बाद भी अगर आप डिलीवर कर रहे हैं गैस तो वो कितना % है उसमें, ये एनालाइज करेंगे आप इससे ऑक्सीजन एनालाइजर से. तो उसके डिफरेंट टाइप होते हैं. मोस्ट कॉमन जो होता है गैल्वेनिक सेल टाइप होता है, अदर आर पैरामैग्नेटिक, पोलरोग्राफिक. एंड द गैस वॉल्यूम मॉनिटरिंग डन बाय द स्पायरोमीटर and airway pressure monitoring by the flow transducer. You can see this in this picture, the flow graphs and the pressure and volume. You can also see that in this picture the oxygen sensor fail. So यहाँ पे आपका ऑक्सीजन सेंसर फेल है, वो FiO2 का परसेंटेज नहीं बता रहा है. अच्छा, अब लास्टली कुछ क्वेश्चंस मैं डिस्कस करना चाहूँगा. जैसे यहाँ फ्लोमीटर है, बेसिकली एक आगे भी फ्लोमीटर था जिसमें क्या था कि यहाँ पे इलेक्ट्रॉनिक फ्लोमीटर है, ये सोलेनॉइड वाल्व पे बेस्ड होता है बेसिकली, तो यहाँ नंबर डिस्प्ले होते हैं. अच्छा, उसके बगल में एक फ्लो ट्यूब लगी हुई है, उसका पर्पस कोई बता सकता है? बेसिकली अगर आप नंबर पे डायल पे हैं तो आप बता नहीं सकते, हो सकता है वो वहां पे शो कर रहा हो 6 लीटर और हो सकता है वो डिलीवर कर रहा है 2 लीटर. तो उसको चेक करने के लिए एक साइड में दिया हुआ है एडिशनल फीचर कि ये आप चेक कर लो कि कितना आ रहा है फ्लो उसमें. और कुछ जगह यहाँ सेफ्टी फीचर्स के लिए एक्चुअली वाल्व चेक वाल्व होते हैं. बेसिकली फर्स्ट चेक वाल्व होता है सिलेंडर और या असेंबली के बीच, ठीक है, सो दैट द बैक फ्लो ना हो. अगर आप सिलेंडर चेंज कर रहे हो तो उसी समय बैक फ्लो ना हो. That is all. कुछ कोई क्वेश्चन पूछना किसी को?
ठीक है, I think our day starts with the machine, and so it is here also. I think if you have any questions, we can always take it after the quiz or at the end of the day, because the schedule is very tight. And we have been warned by Dr. Manish that we have to flow with the time. Okay? Thank you, Dr. Manish.
Okay, thank you, sir.
Good morning to all. Second speaker in this morning session, Dr. B.K. Rao. Before inviting Dr. B.K. Rao, I will like to introduce him to audience. Dr. B.K. Rao is a professor, Department of Anaesthesiology, Azamgarh Medical College, and 15 publications in various journals. Dr. B.K. Rao. And the topic is a central oxygen supply pipeline and cylinder. Okay.
Good morning to all of you. Myself is Dr. Biren Kumar Rao, Professor in Anesthesiology in Government Medical College, Azamgarh. With permission of Chair Professor Khan and Dr. Chaudhary and Dr. Aparna Shukla and Dr. Manish Singh, I am presented here for discussion on the topic central oxygen pipeline cylinders. The oxygen central pipeline supply include oxygen, nitrous oxide, air and suction. I will tell about in brief what is oxygen. Oxygen was discovered by Seeley in 1733, and but credit goes to Joseph Priestley, who also discovered the nitrous oxide in 1734. Although oxygen was discovered by Seeley, but credit goes on to Priestley because Priestley published this work before Seeley. So, next gas is nitrous oxide, and third is suction and air. Central oxygen supply during anesthesiology is confined by two ways: non-liquefied compressed gas and liquefied compressed gas. Non-liquefied compressed gas in form of oxygen cylinder and liquefied compressed gas in form of liquid medical oxygen. Liquid medical oxygen is more beneficial in account of it is cheaper, but basic difference between liquid medical oxygen and oxygen cylinder that in liquid medical oxygen it can be stored and usually need no transfer. But this figure shows manifolded cylinder. In this cylinder there are two manifold A and B shown by arrow. These manifold are usually made up of 4 to 8 cylinder in each and connected by a common manifold, and after that this is the pipeline common pipeline and again the vertical pipeline. So there is pressure reducing valve because oxygen cylinder having pressure of 2000 psi and nitrous oxide is 745 or roughly 750 psi, but pipeline pressure is 55 to 60 psi. So pressure reducing valve decreases cylinder pressure to pipeline pressure, means 2000 psi to 50 psi. This shows the liquid medical oxygen tank usually come in 20,000 liters, and behind the liquid medical oxygen, there are vaporizer, 2 vaporizers. जो पीछे है छोटा सा वो vaporizer. This act as thermostat because critical temperature of oxygen is minus 119 degrees centigrade, and at this temperature gas is preserved in liquid state. When gone into vaporizer or thermostat, their temperature becomes increased. So liquid oxygen come into gaseous form. Now we are coming on pipe distribution system. Usually central pipelines are made up of mainly copper. Oxygen pipeline have diameter of 0.5 inches, and other gas, nitrous oxide and other gases have diameter of 0.375 inches in outer diameter. These pipelines are color coded. Dr. Manish has especially mentioned that pipeline and give the picture of same. So pipes are further categorized into 3 main categories. Main pipeline, from which pipes are connecting to source, to riser or branches are there both. And riser means अगर इस छत से दूसरी मंजिल पे जाना है तो जो पाइप ऊपर जाएगी, that is known as riser. And branch are lateral pipelines, are those after giving second floor it gone into individual room or operation room, then you know branch line. This picture show commonly manifolded headed by 5 cylinders on each side, the common manifold, a pressure reducing valve, and then gone to pipeline system. This is the color coding of pipelines. Pipeline pressure gauge. Pipeline pressure gauge, central pipeline having pressure of 55 to 60 psi. They are installed in between the pipeline, and this pressure gauge should be labeled correctly and color coded. Readable from standing position means ऐसा नहीं बहुत ऊंचा रहेगा आपको दिखे ही ना, ये कहना है ना. This figure show when pipeline gone into operation theater or post anesthesia PACU, post anesthesia care unit or intensive care unit. This figure show the pendant. ऊपर आपका सीलिंग नंबर सीलिंग है, उसके बाद रोटेटिंग आर्म, इट रोटेट अप टू 340 डिग्री. देन थर्ड है आपका जो लेंथ ऑफ ट्यूबिंग, जो पेंडेंट लटका हुआ होता है, और उसके बाद आर्म लेंथ है. और इसके अलावा ये दीज है पावर सॉकेट ऑफ 6 पीसेस, एंड ईच पेंडेंट आइडियली शुड हैव ऑक्सीजन आउटलेट फॉर टू वैक्यूम टू नाइट्रस ऑक्साइड. आपके यहाँ लगा होगा, आप तो यू आर वेल नोन अबाउट दिस. नाउ diameter index safety system. So first of all I want to say that different index safety systems are American Standard Safety System ASSS, second is DISS means Diameter Index Safety System, and third is Pipeline PISS, Pipeline Index Safety System. Diameter American ASSS, American Standard Safety System are used for those areas which having pressure of more than 200 psi, and diameter index safety system is used where pressure is less than 200 psi, and pin index safety system is used where pressure is usually less than 50 to 60 psi. So diameter index is better discussed by Dr. Manish, and it is, I want to say that it is specific for each gas attachment, and it has pin, small pin and large pin. Small pin BB made with BB and CC. This is structure of diameter index safety system. Pipeline testing. अब सपोज पाइपलाइन है आपका वर्किंग एरिया पर पहुंच गया है, तो पाइपलाइन की टेस्टिंग कैसे होती है? तो पाइपलाइन आर प्रेशराइज्ड बाय ड्राई एयर और नाइट्रोजन 150 psi. अगर पाइपलाइन लग गई है तो उसमें 50 to 60 psi तक होता है, तो उसको टेस्ट कैसे करते हैं कि आप 150 psi तक उसमें प्रेशराइज्ड नाइट्रोजन देते हैं, अब each joint and connection should be checked and labeled. After that, after the correction of each joint, again pipeline system are fixed, are pressurized for 60 psi or 20% of normal. नॉर्मल अगर 50 है तो उसका 20% 60 psi फिर 24 आवर तक रखते हैं. अगर 24 आवर तक रखते हैं, अगर कोई लीक नहीं डिटेक्ट होती है, देन इट इज नोन दैट पाइपलाइन आर ओके. Safety features of pipeline. Pipelines are usually color coded and direction of gas flow should be labeled as 20 feet and pressure alarm should be activated. No cross connection, as at the common outlet gas is tested with the gas analyzer better. This is the color coding of pipelines. Now pipeline has gone into anesthesia workstation. Yes. अब पाइपलाइन से आपका डायमीटर हाउस पे चले गए, हाउस से आपका हाउस और पाइपलाइन जहाँ कनेक्ट होती है वहाँ पर क्या लगता है, डायमीटर इंडेक्स सेफ्टी सिस्टम, जो आपका हाउस या पेंडेंट से अटैच होता है और वहाँ पर लगाएगा डायमीटर इंडेक्स सेफ्टी सिस्टम. अब वहाँ से अगर पाइपलाइन आ गई सिलेंडर पे या एनेस्थीसिया मशीन पे आ गया जहाँ पे सिलेंडर लगा हुआ है, वहाँ पर जो लगेगा वहाँ पर पिन इंडेक्स सेफ्टी सिस्टम होगा. मीन्स yoke assembly, it is placed on yoke assembly and there are two pins 4 mm and 6 mm and numbered in 1 to 6, out of which number 7 position is also added in between 3 and 4, and this number 7 is usually thicker than normal 4 mm and 6 mm inches, and this 7 is used for Entonox cylinders. So in simpler way you can say or you can memorize the pin index safety system for different gases. Formula AON 15, 20, 25, 15, 15, 25, 35, एयर का 15, ऑक्सीजन का 25 और नाइट्रस का 35 और ट्रिपल सी साइक्लोप्रोपेन का 36 और CO2 का अगर CO2 का लेस देन 7.5% है तो 26 होगा, और अगर मोर देन 7.5 है तो ये आपका 16 हो जाएगा. नाइट्रोजन का आपका 14 होता है, एयर का 15 होता है और एंटोनॉक्स का 7 होता है. ठीक. नाउ वी आर कमिंग ऑन सिलेंडर. तो सिलेंडर में आपकी क्या होती हैं, कंप्रेस्ड गैस है, आपका नॉन लिक्विफाइड कंप्रेस्ड गैस है और लिक्विफाइड कंप्रेस्ड गैस है. लिक्विफाइड कंप्रेस्ड गैस एग्जांपल है उनका आपका नाइट्रस ऑक्साइड एंड CO2. Cylinder are made up of molybdenum steel. Cylinders are made up of molybdenum steel. If chromium added in 0.8 to 1.1%, if chromium added in 0.8 to 1.1%, then weight of cylinder becomes decreased, durability becomes increased, and thickness is also become decreased. This is the part of cylinder. Body and aluminum cylinders are used in MRI because aluminum are this is the different valve, packed valve and diaphragmatic valve. आपके बहुत उसका वो नहीं है इसलिए आगे बढ़ रहे हैं. Pressure relief devices. Pressure relief devices, if cylinder pressure is more than their actual pressure, means अगर आपका ऑक्सीजन सिलेंडर है 2000 psi है और आपका नाइट्रस है 750 psi है और उससे एटलीस्ट 1.5 टाइम्स ज़्यादा हो रहा है, वैसे then pressure relief valve becomes activated. These valves are rupture disc type, fusible flux type, and combination of both are pressure relief valve. Fusible means fuse हो गया, means it is made for temperature above the temperature it valve become melt. This is the type, diameter and weight of empty cylinder. So, smallest available cylinder is AA and largest is H type cylinder are commonly used in, and commonly used cylinder in anesthesia machine are E. Anesthesia is E and H. E attached to anesthesia machine used as emergency purposes, and H used for common manifold or oxygen tank bank. commonly used cylinder in pressure, तो आपका जो ई टाइप का सिलेंडर होता है उसका कंटेंट कितना 660 लीटर होता है ऑक्सीजन का, और नाइट्रस ऑक्साइड का 1590 लीटर होता है, एंड एस टाइप में करीब करीब 7000 होता है ml होता है, एंड उसका जो है प्रेशर अप्रोक्सीमेट 2000 psi. व्हेन प्रेशर बिकम्स इंक्रीज, सपोज अगर प्रेशर 2000 psi है उसको बढ़ा के हमने 2200 कर दिया तो सिलेंडर की कैपेसिटी आपका 7000 से 8000 लीटर तक हो जाती है ना. नाउ फिलिंग रेशियो. फिलिंग रेशियो इज आल्सो कॉल्ड फिलिंग डेंसिटी. इट इज डिफाइंड एज परसेंटेज weight of gas in cylinder, percentage weight of gas in cylinder to water content at 60 degree Fahrenheit. So, normal value of filling ratio is nitrous oxide के लिए 68 and liquid oxygen in liquid state के लिए 68. But अगर गैस फॉर्म में नाइट्रस है then it can accommodate up to 90% of the filling density, because जो लिक्विड फॉर्म होता है उनका टेम्परेचर कम होता है तो मोर गैस कैन बी अप्लाइड. सो फिलिंग रेशियो ऑफ लिक्विड नाइट्रोजन लिक्विड नाइट्रस ऑक्साइड इज अप टू 90%. एंड एडवांटेज ऑफ फिलिंग रेशियो, इट प्रिवेंट ओवर फिलिंग ऑफ सिलेंडर्स. नाउ सेफ्टी फीचर्स इन सिलेंडर. डॉक्टर मनीष हैज वेल told about safety features in cylinder. Best out of these, best is label of cylinder. Out of this color coding, pin index safety system, and other is best is label of cylinder, that what gas is contained in it. This is the labels all. The color coding already have been told by Dr. Manish. We have discussed the safety, second safety system is pin index safety system in detail previously, and testing of cylinder. Each cylinder should be tested at least 5 years with maximum permissible time is 10 years, and test date should be mentioned. Each cylinder must be checked for visual or external and internal and visual check for corrosion. One thing is here, service pressure. Service pressure is the pressure, maximum pressure at which cylinder may be filled at 70 degree Fahrenheit or 21.1 degree centigrade. So, test for cylinder is hydrostatic या hydraulic होता है, उसे गलत लिख गया थोड़ा सा, hydraulic test. Hydraulic test used for thickness and durability of cylinder. In hydraulic test, cylinder are placed in water container, both cylinder and container filled with water level, and water level in cylinder is recorded when atmospheric pressure met to with water in cylinder up to इनकी 33,000 psi or 1.6 टाइम ऑफ सर्विस प्रेशर. मीन्स नॉर्मल सिलेंडर का प्रेशर 2000 है तो 1.5 गुना कर लेते हैं, 3000 हो गया वो, है ना. तो वाटर लेवल इन कंटेनर इज मेजर्ड. इफ वाटर लेवल आर सेम इन सिलेंडर एज वेल एज देयर कंटेनर देन नॉर्मल सिलेंडर. अब वाटर लेवल अगर बढ़ गया मीन्स सिलेंडर स्ट्रेच हो गया, दैट इज नो मोर नो. सो दैट्स वाई इन दिस वे इट इज नो लॉन्गर यूज्ड. अदर टेस्ट आर टेंसाइल फ्लैटनिंग एंड बेंड टेस्ट. हाँ, वार्डन्स प्रेशर गाज हमने इसलिए यहाँ पे रखा है, दिस स्लाइड इज प्लेस्ड रॉन्गली हियर बिकॉज आई वांट टू से दैट इन केसेज ऑफ gaseous mixture border pressure show sustained decrease in pressure as compared to liquid state. because अगर ऑक्सीजन सिलेंडर है तो अगर उसका प्रेशर कम होगा तो बॉर्डर प्रेशर कम होगा तो सिलेंडर उतना खाली होता जाएगा. बट दिस डज नॉट होल्ड ट्रू इन केसेस ऑफ नाइट्रस ऑक्साइड, बिकॉज अगर टेम्परेचर सेम है तो इवन स्मॉल अमाउंट ऑफ लिक्विड नाइट्रस ऑक्साइड evaporating and maintain pressure until it is half full, अगर 660 लीटर का आपका सॉरी 660 लीटर का मान लीजिए नाइट्रस ऑक्सीजन 600 लीटर का ऑक्सीजन सिलेंडर है और 300 तक आ गया, तब भी प्रेशर उतना ही दिखाएगा. सो वेट quantity of cylinder of nitrous oxide is better measured by air weight. Air weight means weight in empty cylinder. So ऑक्सीजन का जो प्रेशर नापते हैं, क्वांटिटी नापते हैं, वो बॉर्डन्स प्रेशर गैस से नापते हैं और नाइट्रस का वेट ऑफ सिलेंडर से नापते हैं. ठीक है. कलर कोडिंग आपको डॉक्टर मनीष बता ही चुके हैं. नाउ वन थिंग, ड्यूरेशन ऑफ फ्लो ऑफ गैस इन ए सिलेंडर. ड्यूरेशन ऑफ फ्लो इन ड्यूरेशन सिलेंडर ड्यूरेशन इन मिनट. तो सिलेंडर प्रेशर इन PSIG मल्टीप्लाइड बाय कन्वर्जन फैक्टर डिवाइडेड बाय फ्लो इन लीटर पर मिनट. अगर सिलेंडर साइज D का है तो उसका कन्वर्जन फैक्टर 0.16 है, E का है 0.28 है, H है तो 3.14. सपोज अगर ऑक्सीजन E टाइप का सिलेंडर है और उसमें 1000 PSI मार्क शो कर रहा है, तो कितनी गैस होगी? तो 1000 मल्टीप्लाइड बाई 0.28 तो आपका हो जाएगा 280 लीटर. और हमने अलाउ कर रखा है कि उसको 5 लीटर पे देना है या 4 लीटर पे देना है. तो अगर 4 लीटर पे देना है तो 280/4 तो कितना का 70 मिनट. तो सिलेंडर आपका 70 मिनट में खाली हो जाएगा. दिस इज फॉर गैसियस स्टेज. नाउ वी आर कमिंग ऑन लिक्विड स्टेट. तो बिफोर गोइंग टू लिक्विड स्टेट there are two conversion factors should be noted, that 1 liter of liquid weight is 2.5 pounds or 1.1 kg and 1 liter of liquid oxygen liberate 860. Some books had given 840 liters. So roughly you should know 850 liter. So amount of gas in liquid reservoir is liquid volume into gas volume. इससे ज़्यादा नहीं समझ में आएगा, सीधे आ जाते हैं इस पर. जैसे एग्जाम्पल ये है कि पोर्टेबल लिक्विड ऑक्सीजन कंटेनिंग 3 पाउंड्स ऑफ लिक्विड ऑक्सीजन एंड पेशेंट रिसीविंग, बस 2 मिनट लेंगे सर, बस खाली 2 मिनट हो गया है लगभग. पोर्टेबल लिक्विड ऑक्सीजन 3 पाउंड ऑफ लिक्विड ऑक्सीजन एंड पेशेंट रिसीविंग 3 लीटर पर मिनट पे. तो गैस रिमेनिंग कितनी होगी? 1 लीटर में 1 लीटर में 860 है, तो 3 लीटर का है 3 मल्टीप्लाई बाई 860. अब एक यूनिट में 2.5 पाउंड्स होता है, तो रफली करीब 1032 लीटर आ जाएगा ऑक्सीजन. और उसको 3 लीटर से डिवाइड कर देंगे तो करीब 344 मिनट आपका ऑक्सीजन आ जाएगा. तो बाय दिस फार्मूला यू कैन कैलकुलेट द लिक्विड ऑक्सीजन एंड ड्यूरेशन ऑफ सिलेंडर दैट विल लास्ट फॉर थेरेपी. प्योरिटी ऑफ गैस सिलेंडर, you should know that all gases are 90% pure. All gases are 99% pure except nitrous oxide, which is 97% pure. So impurity of nitrous oxide cylinder contain nitrogen, nitric oxide and NH3 and NO2. So impurity of nitrous oxide can be tested by a starch iodide paper test. In starch iodide paper test, moist and air paper is exposed to gas with 25% oxygen for 10 minutes. If turned blue, means impurity more than 300 part per million. And normal OT temperature, normal OT की प्योरिटी होती है less than 25 part per million होती है. Storage of cylinder, it can be stored in a rack or tethered with chain or portable cylinder card for transport. This is the rule for safety use of cylinder. And conclusion. Now we are going to conclude my lecture. Pipelines pressure are 55 millimeter PSI. Pipelines are color coded. Index safety system connection are ASSS more than 200 PSI. DISS for less than 200 and PISS for 55 हो गया. ऑक्सीजन सिलेंडर है, तो बेस्ट मेथड इज आइडेंटिफाइंग content of cylinder is label, and E type have oxygen cylinder have 655 liter of oxygen. Take home message from this lecture that before administering anesthesia, it is mandatory to check central oxygen, nitrous oxide supply, pipeline, cylinder, suction and anesthesia per workstation as per SA guideline. With this wording, I am stop my word. Thank you.
Thank you, Dr. B.K. Rao, for such an informative talk and cover all the aspects of the this topic. Thank you.
I would like to request Dr. Ajay Chaudhary sir to kindly felicitate Dr. B.K. Rao sir.
So most of us became doctors to escape basic physics and maths, but you see after taking anesthesia, there is no escape from some sort of physics and maths. So next speaker is Dr. Neel Kamal Mishra, assistant professor, a very energetic and always obliging person, and he will deal with circuits and so you see that these topics may seem very dry to you, but many a times these become the stumbling block in Viva. If the examiner deviates over these things, so many a time we are at a loss for words because these are very dry and absolutely theoretical type of things. But unfortunately, we have to deal with these. So please pay attention.
Pointer. Good morning to all of you. My topic is breathing circuit. I have been allotted only 20 minutes, so I will stress only on the important points and topics. So what is the breathing system by definition? So by definition, breathing system is the assembly of the component which connect the breathing airway of the patient to the anesthesia machine, and it creates an artificial environment from and to which patient can breathe. That is the definition, you know all. What is the requirement? That means what we should look for before selecting a breathing circuit for our patient. So on the left side, these are the essential criteria. That means these criteria should be present in the breathing circuit. So what is the essential criteria? First, the breathing circuit should deliver anesthetic gas at same concentration as we have set on the anesthesia machine. Second, it should deliver the anesthetic gas in shortest possible time and with least resistant with minimum dead space, and effectively should eliminate the CO2. And these are on the left side, these are the desirable criteria. This may be or may not be present. What are the desirable criteria? The breathing circuit should use the anesthetic gas in the economic way. It should conserve the heat and humidity. It should have light weight, and it should prevent the OT pollution, and it should also be effective for the spontaneous and the controlled ventilation. So these are the important points. Component you all know: phase gas, phase gas, reservoir bag, expiratory port, CO2 absorber. You all know all this. What is the reservoir bag? So reservoir bag is mainly it is made up of the antistatic plastic or the rubber, and the normal volume of the reservoir bag is 0.5 liter to 6 liter, but we commonly use 2 liter reservoir bag. The reservoir bag are in ellipsoid in shape. Why they are ellipsoid in shape? So that you can hold in one hand and can ventilate the patient. Why it is called reservoir bag? It called reservoir bag because it allowed the accumulation of the expired gas in a reservoir bag, so that it can be used in the next respiration and inspiration. So it allows us for the more economical use of the anesthetic gas. And the important point is last point. It is most dispensable part or most compliance part of the breathing circuit. That means if there is increase in the pressure inside the breathing circuit, then this will act as an absorber of the pressure. So it prevents from the barotrauma. APL valve or head brink valve, you know all. But what is the function of APL valve? APL valve prevent the generation of maximum pressure in the breathing circuit during the manual ventilation or the spontaneous ventilation, and it exhausts the excess gas which are present in the circuit. So the important point is APL valve prevent the maximum generation of the pressure inside the breathing circuit. What are the component? You know all. What is the component? Pin, disc, and the spring. Or this valve is a one-way valve. It allows the expelling the gas, but it does not allow the entry of the gas.
and the minimum pressure which required to open up this valve during the spontaneous inspiration is 0.5 to 1 centimeter of water, or less than 1 centimeter of water. So this is the most confusing part of this breathing system. I will discuss a little bit more. First of all, in 1951, MAC-1 has classified the breathing system. There are many types of classification and they are more confusing. So first you understand what is the difference between open, semi-open, semi-closed, okay? सबसे पहले मैक-1 1950 में उन्होंने इसको क्लासिफाई किया ओपन और सेमी क्लोज एंड क्लोज डिपेंडिंग ऑन द अमाउंट ऑफ री-ब्रीथिंग. After that, Drip et al. Had classified the breathing system into 5 classes. Insufflation, open drop method, semi-open, semi-closed, and closed. So semi-open and semi-closed, there are itself confusing terms. Semi-open, semi-closed. So what is the difference between open, semi-open, semi-closed, and closed? So depending upon the presence or absence of the breathing circuit, reservoir bag, and rebreathing. If there in open circuit there is no rebreathing reservoir bag and there is no rebreathing. In semi-open there is presence of the reservoir bag, but there is no rebreathing. In semi-closed there is presence of the reservoir bag, but there is partial rebreathing. And in closed there is presence of the reservoir bag and there is complete rebreathing. Understand? Open, semi-open, semi-closed, closed. Example, semi-open example is nasal cannula or open draft system. In semi-open, it's normally what we are using, Mapelson, D, E, F. And in semi-closed system, example of semi-closed system is circle system. What we use in the commonly. But example of the closed system is, what is the example of closed system is? Circle system, what we are not using commonly. Because it requires the minimum flow. That is the total flow should be the equivalent to metabolic flow. So we don't use it routinely. We use routinely semi-closed system, that is the circle system, in which total flow should be less than the minute ventilation. Next classification, Conway classified the breathing system into 2 parts: breathing system with CO2 absorber, breathing system without CO2 absorber. So breathing system without CO2 absorber, they have been again classified into unidirectional and bidirectional. Unidirectional example, non-rebreathing valve like Rubin valve. And bidirectional flow example like afferent reservoir system and efferent reservoir system. Afferent reservoir, what is the afferent reservoir system? The part of breathing circuit which carries the gas from the machine to patient, that is called afferent limb. If reservoir bag present in this limb, this is called as the afferent reservoir system. The part of the breathing system who carry away from patient to atmosphere, this is called afferent limb. And if reservoir bag present in this system, then this is called the efferent reservoir system. Example are Mapelson D, E, and F, and efferent reservoir example is A, B, C, and LAC system. Next classification is breathing system with CO2 absorption. They have been again classified into unidirectional, that is the example of circle system what we commonly used, and bidirectional flow, to and fro, we don't use nowadays. And final classification is the Mapelson, who classified the breathing system into 6 classes. These are also called as Mapelson alphabets. So these are the 5 classification of the 6 classification of the Mapelson circuit. Mapelson A, B, C, D, E, F. In this system, you have to take into account the position of the fresh gas flow, reservoir bag, and the apial valve. These are the 3 important points which we have to keep in your mind. In Mapelson A, the reservoir bag and fresh gas is present toward the patient end, and the apial valve is present toward the machine end, and apial valve is present toward the patient end. Mapelson A is just opposite to the D, if you can see, with respect to presence of the fresh gas and the apial valve. You can see in Mapelson A, fresh gas present toward the machine end, but in D system, fresh gas present toward the machine end. And apial valve present to the patient end, but in D system it is present toward the machine end. So A and D both are opposite to each other. And in B system, there is presence of the only B and C, they are same except there is presence of the corrugated tube in the B system. E and F are same except there is presence of the bag in the F system. Okay. सो दिस इज इंपॉर्टेंट पॉइंट बिकॉज थ्योरी में भी आप लोग को ये पूछते हैं कि मैपेल्सन का पूरा क्लासिफिकेशन बताइए और उसका कैसे कैसे डायग्राम होता है। ये डायग्राम आप ऐसे याद कर सकते हैं कि जो ए होता है वो डी का अपोजिट होता है, एपीएल वॉल्व जो है पेशेंट के करीब है, लेकिन आपका डी में एपीएल वॉल्व आपका पेशेंट से दूर है। फ्रेश गैस जो है वो आपका मशीन की तरफ है, लेकिन डी में फ्रेश गैस पेशेंट की तरफ है, तो आप ऐसे देख सकते हैं। और ई और एफ दोनों बराबर है, सिर्फ एफ में आपका एक बैग लगा हुआ है, बी और सी बराबर है, सिर्फ बी में कोरुगेटेड ट्यूब है, तो ऐसे आप देख सकते हैं। मैपेल्सन ए ये थोड़ा सा हम लोग को पढ़ना है, क्योंकि अभी कभी कभी आपको पूछते हैं, जो पुराने एग्जामिनर आते हैं वो मैगल सिस्टम के बारे में पूछते हैं, मैपेल्सन ए का कैसे आपका फंक्शनल होता है, कैसे उसका फंक्शनल एनालिसिस होता है, जिसको हम लोग भी पढ़ते हैं। तो अगर हम मैपेल्सन ए यूज करते हैं, मैगल सिस्टम को यूज करते हैं, तो वो स्पॉन्टेनियस ब्रीदिंग में कैसे वो काम करता है। तो जो पहला वाला आपका ए डायग्राम है, उसमें जब वो इंस्पिरेशन को शो कर रहा है, जब पेशेंट इंस्पायर करता है, तो पेशेंट जब इंस्पायर करता है तो वो इनहेल करता है फ्रेश गैस को, फ्रेश गैस आ रहा है, फ्रेश गैस फ्लो से आ रहा है, और जो गैसेस हमारे कोरुगेटेड ट्यूब या फिर हमारे रिजर्वायर बैग में प्रेजेंट है। ठीक है, पहला स्लाइड इंस्पिरेशन का है। जो बी सिस्टम है वो जो पेशेंट एक्सपायर कर रहा है, तो जब एक्सपायर करता है तो जो पहला गैस आता है, ये जो बीच में आपका ये वाला पॉइंट बीच वाला, जो फर्स्ट गैस एक्सिल होता है वो होता है गैस फ्रॉम डेड स्पेस से आता है। तो जो डेड स्पेस से गैस आता है उसमें आपका CO2 नहीं होता है। उसके बाद का जो पार्ट है जो कंप्लीटली ब्लैक, वो एल्वेओलर गैस है, जो किसमें कि CO2 होता है। तो जब एक्सपायर करता है पेशेंट, तो जो डेड स्पेस से गैस आ रहा है वो फ्रेश गैस को फ्लो करता है, बैक साइड में उसको पुश करता है टू फिल अप द रिजर्वायर बैग। तो जो आपका फ्रेश गैस आएगा वो आपके रिजर्वायर बैग को फुल करेगा। जब रिजर्वायर बैग आपका फुल अप हो जाएगा तो प्रेशर सर्किट में आपका बढ़ेगा, बढ़ने से जो सी वाला पार्ट है वो आपका, उसमें एपीएल वाल्व ओपन हो जाएगा। एपीएल वाल्व ओपन होने से जो एपीएल वाल्व के पास का जो गैस है, दैट इज एल्वेओलर गैस, जो CO2 में आपका रिच होता है, वो आपका वेंट आउट हो जाएगा। फिर उसके बाद जो नेक्स्ट इंस्पिरेशन होगा उसमें हमारा फ्रेश गैस और डेड स्पेस गैस, जिसमें कि CO2 कंप्लीटली कम होता है, वो इंस्पायर होगा। ये समझ में आया सबको? इसका यही है कि आपको ये देखना है कि इसमें सबसे इंपॉर्टेंट पॉइंट ये है कि हमारा एपीएल वाल्व पेशेंट के पास में है, और जो एल्वेओलर गैस है वो भी कहाँ पेशेंट से निकल रहा है, तो वो काफी करीब है। तो स्पॉन्टेनियस में जब हमारा प्रेशर, एटमॉस्फेरिक प्रेशर ज्यादा हो जाता है, तो एपीएल वाल्व खुल जाता है और एल्वेओलर गैस आपका एक्सेल हो जाता है। सेम हमारा कंटिन्यूअस में भी होगा, कंट्रोल वेंटिलेशन में भी होगा। सेम मैकेनिज्म है, कंट्रोल वेंटिलेशन में भी होगा। पेशेंट जब इंस्पायर करेगा तो हमारा फ्रेश गैस से इंस्पायर करेगा, जो कि मशीन से आ रहा है, और जो गैसेस हमारे कोरुगेटेड ट्यूब या रिजर्वायर बैग में है उससे वो इंस्पायर करेगा। लेकिन जब एक्सपायर करेगा तो यहाँ पर हमारा कंट्रोल वेंटिलेशन के समय हम लोग एपीएल वाल्व को क्या करते हैं, पार्टली क्लोज कर देते हैं, ताकि हमको इंटरमिटेंट पॉजिटिव प्रेशर देने में आसानी हो ना। तो अगर जब हम पार्टली क्लोज कर देते हैं, तो जब पेशेंट हमारा एक्सपायर करेगा तो उसमें क्या होगा कि जब हमारा एल्वेओलर गैस है और डेड स्पेस गैस है, इतना सफिशिएंट प्रेशर नहीं बना पाएगा कि एपीएल वाल्व को ओपन कर दे। तो जो एल्वेओलर गैस है वो टुवर्ड्स हमारा रिजर्वायर बैग की तरफ जाएगा और डेड स्पेस भी जाएगा। फिर हम जब वेंटिलेट करेंगे पेशेंट को, तो एल्वेओलर गैस क्या है, सबसे पास में है पेशेंट के, तो पेशेंट के अंदर एंटर करेगा। तो इससे क्या होगा, आपका रीब्रीथिंग ज्यादा होगा इसमें कंट्रोल वेंटिलेशन में। इसलिए बोलते हैं कि जो हमारा मैपेल्सन ए है वो स्पॉन्टेनियस के लिए बेटर होता है और कंट्रोल के लिए अच्छा नहीं होता है, क्योंकि इसमें रीब्रीथिंग ज्यादा है। अगर आपको रीब्रीथिंग प्रिवेंट करना है तो आपको फ्लो हाई देना पड़ेगा, 2 to 3 टाइम्स ऑफ द मिनट वेंटिलेशन। लेकिन अगर आपको स्पॉन्टेनियस पर है तो आपको सिर्फ मिनट वेंटिलेशन के इक्वली देना है फ्रेश गैस, तो उससे आपका रीब्रीथिंग नहीं होगा। मैपेल्सन बी वो ये दोनों जो मैपेल्सन और सी और बी होते हैं, दे आर नॉट इफेक्टिव फॉर द स्पॉन्टेनियस और द कंट्रोल वेंटिलेशन। और इसमें आपका चूंकि देख रहे हैं फ्रेश गैस फ्लो जो होता है वो एपीएल वाल्व के पास में है, जिससे फ्रेश गैस फ्लो का काफी लॉस होता है। इसलिए दोनों ही इसमें फ्रेश गैस का वेस्टेज हो रहा है, और दे आर नॉट एफिशिएंट फॉर द स्पॉन्टेनियस एंड कंट्रोल वेंटिलेशन, इसलिए हम इसको यूज नहीं करते नाउडेज। मैपेल्सन सी फिर भी आप यूज कर सकते हैं, क्योंकि ये थोड़ा छोटा होता है, लाइट वेट होता है, स्मॉल होता है, तो इसको हम अम्बू बैग की तरह यूज कर सकते हैं। इमरजेंसी में या पेशेंट को ट्रांसपोर्ट करना होता है या इमरजेंसी में इसको कभी कभी यूज कर सकते हैं आप। मैपेल्सन सी सर्किट। फिर आपका होता है इफरेंट रिजर्वायर सिस्टम, जो भी हमने आपको पहले बताया था कि व्हाट इज द इफरेंट रिजर्वायर सिस्टम। उसमें आपके 3 आते हैं, मैपेल्सन डी, ई, एफ। ये जो तीनों हैं मैपेल्सन डी, ई, एफ, वो मॉडिफिकेशन आईआरटीपीस के, मींस इन तीनों में आपका एक आईआरटीपीस मिलेगा। जैसे ये वाला आप देख सकते हैं स्लाइड में, ये स्लाइड जो नीचे वाला है इसमें है टी-पीस है, नीचे में जो टी-पीस मिला है, जब एरो है एयर का ही वाला एरो, ये तीनों पार्ट यहां पर आपका टी-पीस मिल रहा है ना, डी, ई, एफ। इसलिए इसको हम लोग बोलते हैं इफरेंट रिजर्वायर में, इसमें आईआरटीपीस का बड़ा इंपॉर्टेंस है। तो IRTPs के बारे में हमें थोड़ा जानना है कि IRTPs होता क्या है। IRTPs इट वाज डेवलप्ड बाय द फिलिप्स आयर इन 1937। IRTPs जो होता है वो आपका 10 सेंटीमीटर 5 सेंटीमीटर लेंथ होता है। इसमें 2 पोर्ट होते हैं, इनलेट पोर्ट, आउटलेट पोर्ट एंड एक साइड पोर्ट होता है जो आप देख रहे हैं। जो इनलेट पोर्ट होता है जो पेशेंट की तरफ जा रहा है, वो जो बच्चे होते हैं पीडियाट्रिक पेशेंट में हम लोग 10 मिलीमीटर का लेते हैं और एडल्ट में 15 मिलीमीटर का लेते हैं। इसमें कोई वॉल्व नहीं लगा होता है, इसलिए पेशेंट को रेजिस्टेंट नहीं फील होगा एट द टाइम ऑफ एक्सपीरेशन, और ये जो वॉल्यूम इसका कम है इसलिए इसका डेड स्पेस भी कम होगा। तो आगे ये आपको हम जितना भी पढ़ेंगे DEF उस सब में IRTPs यूज हुआ होगा, इसलिए इसके बारे में थोड़ा जानना है। कभी कोई क्वेश्चन भी आता है। अब ये मैपेल्सन डी सर्किट जिसे लिखा हुआ है कि इट इज डिस्क्राइब्ड एज IRTPs, बस आपका उसमें एक एक्सपायरेटरी लिम जोड़ दिया गया आपका आउटलेट में, तो ये भी एक तरह से IRTPs ही है। अब इसमें क्या होता है कि हमारा जो फ्रेश गैस है वो टुवर्ड्स द पेशेंट एंड होता है, और इट इज मोस्ट एफिशिएंट फॉर द कंट्रोल वेंटिलेशन। मोस्ट कॉमनली हम लोग बेन सर्किट यूज करते हैं, तो बेन सर्किट के बारे में थोड़ा सा अच्छे से आपको पढ़ना है। तो बेन सर्किट वाज डेवलप्ड बाय इंट्रोड्यूस्ड बाय द बेन एंड स्पोरेल इन 1972। बेन सर्किट इज इट्स मॉडिफिकेशन ऑफ द मैपेल्सन डी सर्किट्स। तो व्हाट इज द एडवांटेज ऑफ बाय डूइंग द मॉडिफिकेशन? मॉडिफिकेशन से आपको एडवांटेज क्या हुआ है, कोई बताएगा? मॉडिफिकेशन से जो एडवांटेज ये है कि आपका जो बल्क है वो हमारे सर्किट का वो कम हो गया है, क्योंकि जो ट्यूब बाहर थी वो अब अंदर से जा रही है। और दूसरा ये है कि इसमें एक काउंटर करंट मैकेनिज्म हुआ जिससे हीट और हमारा ह्यूमिडिटी कंजर्व रहा, ये इसका एडवांटेज है। पूछते हैं कि मैपेल्सन बेन सर्किट इज मॉडिफिकेशन ऑफ द मैपेल्सन डी, तो व्हाट इज द एडवांटेज? तो एडवांटेज ये है कि अगर आप मैपेल्सन डी में देखेंगे तो जो हमारा इनर ट्यूब होता है वो बाहर होता है, जो फ्रेश गैस को ले आता है, लेकिन बेन सर्किट में इसको हमने अंदर कर दिया है, तो जो बल्क है वो कम हो गया है। और काउंटर करंट मैकेनिज्म से, क्योंकि वो जो फ्रेश गैस के चारों तरफ एक्सपायर्ड गैस जाता है, जिसके कारण से उसका हीट और ह्यूमिडिटी वो प्रिजर्व रहता है। बाकी बेन सर्किट आल्सो एक्ट इन सेम वे एज द टीपीस। इसमें भी आपका ये टीपीस की तरह ही काम करता है, जिसमें कि हमारा एक्सपायरेटरी लिम आउटलेट में एक एक्सपायरेटरी लिम लगा हुआ है। अब इसके स्पेसिफिकेशन क्या क्या है, इंपॉर्टेंट पॉइंट क्या है? लेंथ सब आपको पता है 1.8 मीटर होता है। डायमीटर, आउटर डायमीटर जो होता है वो 22 मिलीमीटर, इनर डायमीटर 7 मिलीमीटर, रेजिस्टेंस जो होता है लेस देन 0.7 सेंटीमीटर ऑफ वाटर। एंड डेड स्पेस, इसमें एक इंपॉर्टेंट पॉइंट है कि जो डेड स्पेस होता है वो आपका आउटर ट्यूब होता है अप टू एपीएल वॉल तक। जो आउटर ट्यूब है जिससे हमारा एक्सपायर्ड गैस निकल रहा है अप टू एपीएल वॉल तक, वो पूरा डेड स्पेस होता है। फिर उसके बाद आपका जो एपीएल वॉल, एक्सपायरेटरी वॉल को एपीएल वॉल बोलते हैं। इसमें अगर आपको स्पॉन्टेनियस के लिए रखना है तो आपको कितना होना चाहिए फ्लो? 300 ml पर kg पर मिनट। अगर कंट्रोल के लिए रखना है तो 100 to 150 ml पर kg पर मिनट होना चाहिए। अब इसका फंक्शनल एनालिसिस देखते हैं जो हमारा बेन सर्किट है। बेन सर्किट को अगर हम कभी भी स्पॉन्टेनियस के लिए यूज कर रहे हैं तो वी शुड फिल द बेन सर्किट विथ फ्रेश गैस, तब उसको पेशेंट को हम अटैच करते हैं। तो इसमें जो पेशेंट जब इंस्पायर कर रहा है तो इंस्पायर कर रहा है फ्रेश गैस फ्रॉम द मशीन एंड द गैसेस व्हिच आर प्रेजेंट इन द कोरुगेटेड ट्यूब एंड द रिजर्वायर बैग। फिर पेशेंट जब एक्सपायर करता है, इन सेकेंड स्लाइड में जब एक्सपायर करता है तो एट टाइम ऑफ एक्सपिरेशन फ्रेश गैस कंटिन्यू टू फ्लो इनटू द सिस्टम। फ्रेश गैस हमेशा सिस्टम में फ्लो हो रहा है, तो जो फ्रेश गैस फ्लो हो रहा है वो एक्सपायर्ड गैस को पीछे की तरफ पुश करता है, किधर? टुवर्ड्स द रिजर्वायर बैग की तरफ पुश करता है। जो फ्रेश गैस क्योंकि कंटिन्यू अपना चलता रहता है उसमें, तो जो फ्रेश गैस होता है वो एक्सपायर्ड गैस जो डेड स्पेस से आ रही है, एल्वेओलर गैस से आ रही है, वो उसको टुवर्ड्स रिजर्वायर बैग की तरफ पुश करता है। तो जब रिजर्वायर बैग फुल हो जाता है, जो कि मिक्सचर ऑफ डेड स्पेस, एल्वेओलर गैस एंड फ्रेश गैस से, तो सिस्टम में प्रेशर बढ़ता है तो एपीएल वॉल्व ओपन होता है। एपीएल वॉल्व ओपन होने से जो हमारा कंटेंट होता है रिजर्वायर बैग का वो एक्सपेल्ड आउट होता है। लेकिन इसमें क्या है कि आपका जो एल्वेओलर गैस है वो अभी भी टुवर्ड्स पेशेंट एंड पर है, क्योंकि वो लास्ट में निकलता है। जो डेड स्पेस होता है वो पहले निकलता है, तो पहले निकलने से वो रिजर्वायर बैग की तरफ जाएगा, और जो एल्वेओलर गैस है वो बाद में निकलता है, वो तो मोर क्लोजर टू पेशेंट रहेगा। जब पेशेंट इंस्पायर करेगा तो पहला गैस कौन सा अंदर जाएगा? एल्वेओलर जाएगा, तो CO2 रिटेंशन उसमें होगा। तो इसलिए ये सिस्टम स्पॉन्टेनियस के लिए बढ़िया नहीं है। अब हम लोग आते हैं कंट्रोल वाले में। कंट्रोल में भी सेम है, देखो स्पॉन्टेनियस और कंट्रोल में दोनों में सेम है, बस ये है कि हम कंट्रोल में एपीएल वाल्व को क्लोज करके प्रेशर बढ़ा दे रहे हैं। प्रेशर बढ़ाने से क्या हो रहा है कि जो हमारा एल्वेओलर गैस इस वाले में, यहां पर जो हमारा पेशेंट यहां से एक्सपायर कर रहा है ना, तो यहां से जो हमारा एल्वेओलर गैस होगा, अगर हम प्रेशर क्लोज कर देंगे तो गैस लीक नहीं होगी, तो एल्वेओलर गैस टुवर्ड्स द रिजर्वायर बैग की तरफ मूव करेगा ना। और अगर हमारा वहां से प्रेशर, अगर आपने इसको खोल दिया, अगर यहां पर प्रेशर नहीं लगा है, तो तो ये जो हमारा एक्सपायर्ड गैस है जो डेड स्पेस का वो यहाँ आएगा, तो ये ओपन हो जाएगा, तो फिर ये पेशेंट एल्वेओलर गैस को इंस्पायर करेगा। लेकिन हम कंट्रोल वेंटिलेशन में क्या कर रहे हैं, एपीएल वाल्व को क्लोज कर दिए हैं, तो जो हमारा एल्वेओलर गैस है वो क्या होगा, टुवर्ड्स रिजर्वायर बैग की तरफ मूव करेगा। तो जब हम बैग को कंप्रेस करेंगे फॉर कंट्रोल वेंटिलेशन, तो चूंकि जो एल्वेओलर गैस है वो पेशेंट से अब दूर की तरफ चला गया है, टुवर्ड्स बैग की तरफ है, तो वो एक्सपायर्ड आउट हो जाएगा ना, और फिर पेशेंट जब नेक्स्ट इंस्पायर करेगा तो फ्रेश गैस करेगा एंड सम ऑफ द डेड स्पेस गैस और एल्वेओलर गैस। तो कंट्रोल वेंटिलेशन में भी पेशेंट एल्वेओलर गैस को इंस्पायर करता है, क्योंकि ऐसा नहीं है कि इसमें 100% फ्रेश गैस ही जाता है, लेकिन अमाउंट क्या होता है, कम होता है एज कंपेयर टू स्पॉन्टेनियस से। ये है। फिर इसका एडवांटेज क्या है बेन सर्किट का, पता है आप लोगों को कि इसको हम लोग पीडियाट्रिक एडल्ट में भी यूज कर सकते हैं और कंट्रोल और स्पॉन्टेनियस वेंटिलेशन में भी यूज कर सकते हैं, इसलिए इसको यूनिवर्सल सर्किट भी बोलते हैं। इसका लाइट वेट होता है, इसी कारण से ये पुल मिनिमम पुल देता है एंडोट्रेकियल ट्यूब पर। इट हेल्प्स फॉर द ट्रांसपोर्ट ऑफ द पेशेंट फ्रॉम वन प्लेस टू अदर प्लेस विदाउट रिस्क ऑफ डिसकनेक्शन। उसके बाद इसका लेंथ ज़्यादा होता है, तो सर्जिकल फील्ड या सिटी स्कैन जो जहाँ होता है तो उससे हम दूर हो सकते हैं। इसमें मिनिमल डेड स्पेस होता है, मिनिमम आपका रेजिस्टेंट होता है, ऑटोमेटिक वार्मिंग होती है जैसे कोएक्सियल सिस्टम है, जैसे मैंने आपको बताया। तो ये इसके एडवांटेजेस हैं। जितने भी मेपेल्सन सर्किट है उसका डिसएडवांटेज ये है कि इनको हाई फ्लो चाहिए होता है। हाई फ्लो से क्या होगा, आपका एनेस्थेटिक गैस का कंजम्पशन ज़्यादा होगा और ऑक्सीजन का कंजम्पशन ज़्यादा होगा। तो पहला इसका डिसएडवांटेज है कि हाई गैस फ्लो रिक्वायरमेंट है। दूसरा इंपॉर्टेंट जो इसका डिसएडवांटेज है कि जो इनर ट्यूब है जिस फ्रेश गैस को कैरी कर रही है, अगर वो डिस्कनेक्ट हो गई या किंक हो गई तो हमको पता नहीं चलेगा। अगर वो डिस्कनेक्ट या किंक हो गई तो जो होल आउटर ट्यूब है वो एज ए डेड स्पेस की तरह काम करेगा। हाँ, उसका वॉल्यूम जो होता है वो आपका 400 के आसपास होता है। तो उससे कारण से क्या होगा, हाइपरकार्बिया होगा, एसिडोसिस होगी। और ये जो हाइपरकार्बिया एसिडोसिस होती है वो हाइपर वेंटिलेशन को रिस्पॉन्स नहीं करती है, क्योंकि वो पूरा स्पेस ही डेड स्पेस है, वो कैसे निकल पाएगा वो। तो इसीलिए आपको ये देखना है कि इनर ट्यूब हमारा इंटैक्ट हो, उसमें कोई किंकिंग या डिस्कनेक्शन ना हो। और तीसरा लास्ट पॉइंट है कि अगर हमारा आउटर ट्यूब वो ब्लॉक हो गया किसी तरह से, तो पेशेंट तो एक्सपायर करता है आउटर ट्यूब में, आउटर ट्यूब में तो एक्सपायर करता है, इनर ट्यूब तो फ्रेश गैस ले जाती है, तो बैरोट्रामा होगा पेशेंट को। ये समझ में आ रहा है ना कि जब बेन सर्किट करते हैं तो एक्सपायर करता है आउटर ट्यूब में, पता है ना ये। तो अगर वो ब्लॉक हो गया तो पेशेंट को बैरोट्रामा होगा, प्रेशर ज्यादा बढ़ जाएगा। फिर ये होते हैं, अब कुछ टेस्ट हैं जो पैथिक्स टेस्ट होता है और एक फोक्स क्रैम्पटन टेस्ट है। ये जो पैथिक्स टेस्ट है ये आपको बेन सर्किट का जो इनर ट्यूब है उसकी इंटीग्रिटी को टेस्ट करता है। ये टेस्ट कैसे करते हैं सबको पता है। कैसे करते हैं टेस्ट कि सबसे पहले आपको जो पेशेंट इनको क्लोज करना है, एपीएल वाल्व को क्लोज करना है और पूरे सर्किट को ऑक्सीजन से फ्लश करना है। तो जब हमारा बैग इन्फ्लेट हो जाएगा तब हम पेशेंट इनको को ओपन करेंगे। ओपन करेंगे तो अगर हमारा इनर ट्यूब इंटैक्ट है तो उससे गैस फ्लो होगा, जिससे कारण से उसके चारों तरफ वेंचुरी इफेक्ट होगा, तो जिससे हमारा जो बैग है वो डिफ्लेट होगा। तो इसका मतलब ये है कि हमारा इनर ट्यूब इंटैक्ट है। अगर हमारा बैग डिफ्लेट नहीं हुआ तो इसका मतलब वो इनर ट्यूब हमारा कहीं से कहीं ने लीक कर रहा है। जैसे नेक्स्ट स्लाइड में आप देख सकते हैं, जो उधर वाला स्लाइड है इनर ट्यूब इंटैक्ट है तो उससे लीक कर रहा है, तो वेंचुरी इफेक्ट हो रहा है तो वो डिफ्लेट हो गया। लेकिन इधर वाले में डैमेज है तो वो हमारा इन्फ्लेटेड ही रहा। फिर एक टेस्ट होता है फ्रॉक्स क्रैम्पटन स्मिथ टेस्ट। ये भी होता है, ये आपका इनर ट्यूब को ही चेक करने के लिए होता है। इसमें भी हम लोग क्या करते हैं कि पेशेंट इनको क्लोज कर देते हैं और जो एपीएल वाल्व को भी क्लोज कर देते हैं। हम लोग ऑक्सीजन फ्लो को लो फ्लो पर रखते हैं। फिर उसके बाद हम लोग जो आपका पेशेंट इंड है उसको हम एम्पुल से या फिर फिंगर से उसको डिप करते हैं, ऑक्लूड करते रिलीज करते हैं। ऑक्लूड रिलीज करने पर हमारा जो बॉबिन्स होगा, अगर इनर ट्यूब इंटैक्ट है तो ये प्रेशर हमारा बैक ट्रांसफर होगा, तो बॉबिन्स हमारा ऊपर नीचे जाएगा। तो ये भी एक मेथड होता है आपको इनर ट्यूब को चेक करने का। बाकी इसके अलावा एक होता है एपीएल वाल्व मेथड भी होता है। एपीएल वाल्व की फंक्शनलिटी को चेक करने के लिए आपको क्या करना है कि एपीएल वाल्व को क्लोज करना है, पेशेंट इंड को भी कंप्रेस करना है और पूरे सर्किट को फ्लश करना है। अगर हमारा एपीएल वाल्व इंटैक्ट है तो हमारा जो बैग है वो इन्फ्लेटेड रहेगा। फिर जब आप एपीएल वाल्व को खोलेंगे तो हमारा बैग क्या हुआ, डिफ्लेट हो जाएगा। अगर एपीएल वाल्व हमारा सही है तो फिर एक और टेस्ट होता है कि आउटर ट्यूब को कैसे चेक करेंगे। इनर ट्यूब को तो आपने चेक कर लिया, आउटर ट्यूब को कैसे चेक करेंगे। तो आउटर ट्यूब को चेक करने के लिए क्या करना है कि आप अपने हाथ में स्पिरिट लगा लीजिए। हाँ, स्पिरिट लगाने के बाद आप जो आउटर ट्यूब है उसको अपने हाथ से थोड़ा सा स्वाइप करिए, ठीक है, और सिस्टम को उसी समय फ्लश करिए। अगर आउटर ट्यूब में लीक होगा तो गैस लीक करेगा, वो आपके हाथ में टच होगा तो आपको थोड़ा सा ठंडा लगेगी, चिलनेस लगेगी। तो इससे आप कह सकते हैं कि हमारे आउटर ट्यूब में कहीं ना कहीं लीक है। तो इनर ट्यूब का हो गया, आउटर ट्यूब का हो गया और एपीएल वाल्व का हो गया, ये आपको पता होना चाहिए। मैं पैसा नहीं वही मेपेल्सन ई और मेपेल्सन एफ दोनों बराबर ही है, ये भी आयरिश टीपीस का मॉडिफिकेशन है। इसमें एक इंपॉर्टेंट पॉइंट ये है कि जो आपका रिजर्वायर या एक्सपैरिटी जो लिम्ब है उसका जो वॉल्यूम होना चाहिए वो पेशेंट के टाइडल वॉल्यूम से थोड़ा ज़्यादा होना चाहिए, बहुत ज़्यादा भी नहीं होना चाहिए, बहुत कम भी नहीं होना चाहिए। अगर बहुत ज़्यादा होगा तो क्या होगा, रीब्रीदिंग होगी, क्योंकि जो पेशेंट एक्सपायर करेगा वो उसी में रह जाएगा, फिर जो इंस्पायर करेगा तो उससे वापस ले लेगा। अब बहुत छोटा होगा तो क्या होगा, जब पेशेंट इंस्पायर करेगा तो एयर डायल्यूशन होगा, वो डायल्यूशन एयर को लेकर के फिर पेशेंट का अगर हम एनेस्थेसिया से अगर उसको एनेस्थेटाइज कर रहे हैं तो जल्दी वो एनेस्थेटाइज नहीं हो पाएगा। तो इसीलिए इसका जो वॉल्यूम होना चाहिए बहुत ज़्यादा भी नहीं होना चाहिए, बहुत कम भी नहीं होना चाहिए, हाँ टाइडल वॉल्यूम से थोड़ा ज़्यादा होना चाहिए। मेपेल्सन एफ ये भी हमारा आईआरटीपीस का, इसको जैक्सन रिज मॉडिफिकेशन हम आईआरटीपीस बोलते हैं, क्योंकि मैंने आपको पहले बता दिया, यहाँ भी देखो टीपीसी लगा हुआ है ना, तो ये आपको पता होना चाहिए। जैक्सन रिज ने क्या किया था, इसमें एक बैग लगा दिया था। ये बैग जो होता है, अगर आप मेपेल्सन ई में 2 एंडेड बैग लगा देते हैं जो दोनों तरफ से खुला होगा तो हो जाएगा मेपेल्सन एफ हो जाएगा। जो हमारा गैस एक्सपेल करता है डूरिंग एक्सपिरेशन, वो हमारा टेल ऑफ बैग से करता है, सबको पता है। अब अगर हमको किसी को पॉजिटिव प्रेशर वेंटिलेशन देना है तो जो टेल होता है उसको हम फिंगर और थंब में क्लोज करके स्क्वीज करके दे सकते हैं इसमें। अब इसका जो स्पॉन्टेनियस, इसका जो मैकेनिज्म होता है सेम होता है जैसे हमारा बेन सर्किट का होता है। अगर फंक्शनल एनालिसिस देखेंगे हम मेपेल्सन एफ का, तो जैसे हमारा बेन सर्किट का होता है या डी का होता है उसी तरह से इसका भी होता है, इसलिए इसको मैं इतना डिटेल में नहीं गया हूं। इसके पॉइंट्स क्या क्या है इसमें, इसमें सबसे इंपॉर्टेंट जो पॉइंट है, एक तो प्लास्टिक एंगल, आप सबको पता है प्लास्टिक एंगल माउंट होता है, प्लास्टिक का टी पीस होता है, फिर आपका कोरुगेटेड ट्यूब रिजर्वायर बैग एंड 1 सेंटीमीटर लंबा आपका वो होता है पीवीसी ट्यूब होती है। देखिए इसमें लिखा हुआ लास्ट में एक्सपैरिटी लिम्ब शुड बी मोर देन टाइडल वॉल्यूम ऑफ पेशेंट। तो वही मैंने आपको जो बताया कि अगर बहुत छोटा है बहुत बड़ा है तो दोनों दिक्कत है, बहुत बड़ा है तो रीब्रीदिंग होगी, बहुत छोटा है तो एयर डायल्यूशन होगा। एक लास्ट पॉइंट इसमें लिखा हुआ है कि अगर हमको इसमें एचएमई फिल्टर यूज नहीं करना है, अगर हम मेपेल्सन ई और एफ यू दोनों यूज कर रहे हैं तो, क्योंकि अगर पेशेंट स्पॉन्टेनियसली ब्रीथ कर रहा है तो मेपेल्सन जो एचएमई फिल्टर होगा वो रेजिस्टेंट क्रिएट करेगा, तो जो फ्रेश गैस आ रही है वो पेशेंट के अंदर न जाकर किस में चली जाएगी, एक्सपैरिटी लिम्ब में जाएगी, तो वेस्टिंग ऑफ द गैस होगा। समझ में आया चीज कि अगर आप एचएमई फिल्टर यूज कर रहे हैं जो स्पॉन्टेनियसली बच्चा ब्रीथ कर रहा है मेपेल्सन ई और एफ में, तो उसमें न जाकर के हमारा जाएगा एक्सपैरिटी लिम्ब में जाएगा। और अगर आप हम इंड्यूस करेंगे तो बच्चा जल्दी इंड्यूस भी नहीं होगा, क्योंकि रेजिस्टेंस से पूरा जो गैस आएगी वो चली जाएगी आपके एक्सपैरिटी लिम्ब में, इसलिए हमको कभी एचएमई फिल्टर नहीं यूज करना है। एडवांटेज डिसएडवांटेज सेम है जैसे मैंने आपको प्रीवियसली बताया है। बाकी एडवांटेज आप ओवरऑल जो हमारे मेपेल्सन सर्किट है उनका यही होता है कि लाइट वेट होते हैं, इनएक्सपेंसिव होते हैं, कोएक्सियल सिस्टम में आपका हीट और ह्यूमिडिटी कंजर्व रहता है, रैपिड चेंज होता है इन स्पैटिक गैस व्हेन वी आर चेंजिंग इनटू द फ्रेश गैस, और इनका जो कंप्रेशन और कंप्लायंस वॉल्यूम लॉस होता है वो कम होता है। डिसएडवांटेज मैंने आपको पहले बताया कि सब में इनको हाई फ्लो चाहिए होता है फ्रेश गैस, इसलिए डिसएडवांटेज है। CO2 का जो एलिमिनेशन होता है वो फ्रेश गैस फ्लो पर डिपेंड करता है, तो अगर फ्रेश गैस फ्लो हमारा कम है तो CO2 का एलिमिनेशन नहीं हो पाएगा। तो ये इनका डिसएडवांटेज है। अगर हम ABC में देखें तो हमारा जो APL वॉल्व होता है टुवर्ड्स पेशेंट के एंड होता है, तो हमारा जो यूजर होते हैं उनके लिए इनएक्सेसिबल होता है, ये भी इसका डिसएडवांटेज है। और कोएक्सियल सिस्टम के अलावा जितने भी सिस्टम होते हैं मेपेल्सन, उसमें हीट और ह्यूमिडिटी प्रिजर्व करने का कोई तरीका नहीं होता है। ये 4-5 पॉइंट है, आपको पता होना चाहिए। सर्किल सिस्टम बहुत बड़ा टॉपिक है, लेकिन मैंने सिर्फ इस पर स्ट्रेस दिया जो इंपॉर्टेंट पॉइंट है जो आपको पता होना चाहिए। इसका जो सर्किल सिस्टम का रूल, सर्किल सिस्टम में जितने भी पार्ट है उसको आप किसी तरह से अरेंज कर सकते हैं। ये आपका जो डायग्राम है, ये कोई कंपल्सरी नहीं है कि फ्रेश गैस को ही रखो, आप कहीं भी रख सकते हो, ऐसा कोई रूल नहीं है। लेकिन चूंकि ऑप्टिमम यूज के लिए हमारे ऑब्जेक्टिव क्या है सर्किल सिस्टम की, ये है कि मैक्सिमम इंक्लूजन ऑफ फ्रेश गैस इन इंस्पायर्ड गैस एंड मैक्सिमम वेंटिंग ऑफ एल्वेयर गैस, ये तो हमारा ऑब्जेक्टिव है कि हमारा जो एल्वेयर गैस वो बाहर निकले। दूसरा क्या, मिनिमम कंजप्शन ऑफ द एब्जॉर्बेंट एंड लो रेजिस्टेंट एंड मिनिमम डेड स्पेस एंड मिनिमम एब्जॉर्बेंट डिसेक्शन एंड मिनिमम पुल ऑल द ट्रेकियल ट्यूब, ये हमारे ऑब्जेक्टिव है सर्किल सिस्टम को यूज करने का। ये समझ में आ रहा है सबको कि सर्किल सिस्टम को यूज करने, अब ये ऑब्जेक्टिव हमारे कैसे हमको मिलेंगे, तो उसके लिए हमने एक ईगर ने एक रूल दिया है वो 3 कि आपको होना ही चाहिए, मैंडेटरी है। पहला रूल ये है कि आपका जो यूनिडायरेक्शनल वॉल्व होना चाहिए बिटवीन पेशेंट एंड रिजर्वायर बैग इन बोथ एक्सपैरिटी और इंस्पैरिटी लिम्ब में एक यूनिडायरेक्शनल वॉल्व होना चाहिए पहला। दूसरा ये है कि हमारा जो फ्रेश गैस का इनलेट है वो कभी भी पेशेंट और एक्सपैरिटी वॉल्व के बीच में नहीं होना चाहिए। और तीसरा इंपॉर्टेंट पॉइंट है कि जो हमारा एपीएल वॉल्व है कभी भी इंस्पैरिटी वॉल्व और पेशेंट के बीच में नहीं होना चाहिए, जैसे ये बता रहे हैं। ये सर्किल सिस्टम का है, तो इसमें ये बताया रूल पहला ये है कि हमारा जो भी वॉल्व होना चाहिए दोनों एक्सपैरिटी लिम्ब में है ना, वॉल्व तो है इंस्पैरिटी वॉल्व। दूसरा इंपॉर्टेंट पॉइंट था कि जो हमारा इनलेट होना चाहिए वो हमारा एक्सपायरिटी और पेशेंट के बीच में नहीं होना चाहिए, तो नहीं है। और तीसरा ये इंपॉर्टेंट पॉइंट था कि एपीएल वॉल जो है वो इंस्पायरिटी वॉल और पेशेंट के बीच में नहीं होना चाहिए, तो इसमें नहीं है, ये आपका फॉलो होना चाहिए। तो ये सर्किल सिस्टम के पार्ट कंपोनेंट जो अभी मैं स्किप कर गया हूँ, ये कंपोनेंट आपको पता है, फ्रेश गैस इनलेट, इंस्पायरिटी लिम्ब, इंस्पायरिटी वॉल, फिर वाई पीस, एक्सपायरिटी लिम्ब, फिर आपका एक्सपायरिटी वॉल, फिर एपीएल वॉल, फिर आपका रिजर्वायर वायर बैग, फिर आपका CO2 एब्जॉर्बर, ये इसके कंपोनेंट हैं। अब हमने जो ऑब्जेक्टिव अपना रखा है कि हम क्यों यूज कर रहे हैं सर्किल सिस्टम, वो हमको कैसे मतलब ऑप्टेन करेंगे इसको, तो उसको हमको ऑप्टिमाइज करना है सर्किल सिस्टम के अरेंजमेंट को। जैसे हमने आपको बताया कि सर्किल सिस्टम को ऐसा नहीं कि आप कैसे भी रख सकते हैं, लेकिन उसमें कुछ ऑप्टिमाइजेशन ये है कि फ्रेश गैस फ्लो, जो फ्रेश गैस फ्लो है हमेशा इंस्पायरिटी वॉल और जो CO2 एब्जॉर्बर है उसके बीच में होना चाहिए। दैट मीन्स अप स्ट्रीम टू इंस्पायरिटी वॉल एंड डाउन स्ट्रीम टू एब्जॉर्बर, CO2 एब्जॉर्बर। ये आप देखिए यहाँ पर, ये है ना जो हमारा इनलेट है, अप स्ट्रीम टू डाउन स्ट्रीम टू CO2 एब्जॉर्बर एंड अप स्ट्रीम टू इंस्पायरिटी वॉल। अगर हम फ्रेश गैस को अगर यहाँ ना रख करके मान लीजिए आप हम इंस्पायरिटी जो वॉल है उसके नीचे रखते हैं, तो उससे क्या लॉस होगा कि पेशेंट जब एक्सपायर करेगा उसमें तुम्हारा गैस फ्लो करता रहेगा, तो जो फ्रेश गैस है पेशेंट एक्सपिरेशन के समय वो लॉस होगा, वो फालतू का हमारा वेस्टेज होगा। एक तो इसका डिसएडवांटेज ये है। दूसरा है, अगर मान लीजिए हम फ्रेश गैस इनलेट को अगर रिजर्वायर CO2 एब्जॉर्बर के नीचे रखें, अभी तो ऊपर रखे ना, मतलब डाउन स्ट्रीम है ना, अगर हम अप स्ट्रीम रख दें तो हमारा जो CO2 जो वो O2 है वो जब रिजर्वायर से पास करेगा तो वो ह्यूमिडिफाइड तो हो जाएगा, लेकिन आपका पीछे में आपका एपीएल वॉल्व उससे लॉस भी होगा। समझ में आ रहा चीज? अगर फ्रेश गैस को हम यहां रखते हैं मान लीजिए यहां पर, हाँ, अगर उसके नीचे रखेंगे तो यहां पर हमारा एपीएल वॉल्व है, तो फ्रेश गैस क्या होगा, एपीएल वॉल्व से वेंट आउट होता रहेगा ना, और हमारा जो इससे अगर हम इनलेट को अगर हम CO2 एब्जॉर्बर से भेजेंगे जाएगा वो, तो कुछ हमारा जो डस्ट है CO2 एब्जॉर्बर को भी हमारे इंस्पायरिटी लिम्ब में चले जाएंगे। तो ये इसका डिसएडवांटेज है कि आपको जो रखना है इन दोनों के बीच में रखना है, इंस्पायरिटी वॉल और CO2 एब्जॉर्बर के बीच में रखना है। तीसरा इंपॉर्टेंट पॉइंट क्या है कि हम जब भी एपीएल वॉल को रखेंगे, एपीएल वॉल को हमेशा हम कहाँ रखेंगे, एक्सपायरिटी लिम्ब में रखेंगे, हाँ, बिफोर द CO2 एब्जॉर्बर। अगर हम CO2 एब्जॉर्बर के बिफोर रख रहे हैं एपीएल वॉल को, तो ये हेल्प करेगा, जो भी हमारा एल्वेओलर गैस है उसको वेंट आउट करने में हेल्प करेगा। अगर हमारा जो एल्वेओलर गैस है उसमें CO2 होता है, अगर CO2 एब्जॉर्बर के बिफोर ही इसको हम वेंट आउट कर दे रहे हैं तो हमारा CO2 एब्जॉर्बर का कंजम्पशन क्या होगा, कम होगा। तो ये जो अरेंजमेंट है वो हमारा CO2 एब्जॉर्बर को प्रोटेक्ट करेगा। लास्ट पॉइंट है आपका यूनिडायरेक्शनल आपका वॉल्व होना चाहिए। यूनिडायरेक्शनल वॉल्व जैसे मैंने आपको पहले बताया कि इन दोनों के पेशेंट के क्लोज होना चाहिए टू प्रिवेंट द ब्लैक फ्लो इनटू द इंस्पायरिटी सिस्टम। ये देखिए दोनों बराबर में हैं ये। बाकी आपका एक रिजर्वायर बैग है, रिजर्वायर बैग भी आपका जो होना चाहिए वो एक्सपायरिटी लिम्ब में ही होना चाहिए, सो दैट आप जब पेशेंट एक्सपायरिटी, ये देखिए इसमें है आपका रिजर्वायर बैग जो है वो आपका एक्सपायरिटी लिम्ब में ही है, क्योंकि इसमें भी आपका जब एक्सपायर गैस आएगा वो आपका वेंट आउट हो जाएगा एपीएल वॉल्व से। ये इंपॉर्टेंट चीज है ये। तो ऑप्टिमाइजेशन आपको चाहिए पूरा। ये 4 पॉइंट हैं, आपको पता होना चाहिए। और एडवांटेज क्या है जो मैंने आपको पहले बताया कि रिड्यूस द कंजप्शन ऑफ एनेस्थेटिक गैस, रिड्यूस द कॉस्ट, रिड्यूस द एनवायरमेंटल पोल्यूशन एंड टेम्परेचर ऑफ द, मेंटेन द टेम्परेचर एंड ह्यूमिडिटी ऑफ द इंस्पायर्ड गैस। ये इसके एडवांटेज हैं सर्किल सिस्टम के। डिसएडवांटेज क्या है कि सर्किल सिस्टम कंपोज्ड ऑफ मेनी पार्ट से बना होता है, जिसके कारण से उसको इनकरेक्टली अरेंज हो सकता है, माल फंक्शन हो सकता है, डिस्कनेक्शन या लीक हो सकता है। बड़ा साइज होता है तो पोर्टेबिलिटी कम है, कंप्लायंस इसका ज्यादा होता है, और देयर इज प्रोटेक्शन ऑफ कार्बन मोनोऑक्साइड एंड द कंपाउंड ए। ये इसके डिसएडवांटेजेस हैं। तो इतना ही है आपको, क्योंकि ये थोड़ा बड़ा टॉपिक है तो मैंने इंपॉर्टेंट पॉइंट को ही लिया हुआ है, बस इतना ही था।
I request Professor MP Khan sir to felicitate Dr. NK Mishra sir. I now request Dr. Aparna Shukla ma'am to present a token of gratitude to our respected chairperson, Professor MP Khan sir.
अभी जा रहा हूँ पकड़ इसको, तो वो आए खुद ही आएगा.
And a token of gratitude to our respected chairperson, Professor Ajay Chaudhary, sir. Thank you, sir. Thank you, ma'am. Moving on, I would like to call the chairperson for our next lecture, Professor Dinesh Singh, sir, Professor, Department of Anaesthesiology and Critical Care, KGMU. He has a total experience of more than 25 years, and his interest lies in cardiac anesthesia and critical care anesthesia. Our next chairperson, Dr. Satish Verma, sir, Additional Professor, Department of Anaesthesiology and Critical Care, KGMU. He is an IRC CPR instructor with special interest in pediatric anesthesia.
Hello, good morning to everyone. In this session, I would like to invite Dr. Manoj Chaurasia. He is Associate Professor, Department of Anesthesia and Critical Care, KGMU, UP, Lucknow. And he will be talking about the video demonstration of fiber optic difficult airway management and how to do it. Dr. Manoj Chaurasia.
Pointer. कैसे काम करते हैं? पॉइंटर नहीं है? नहीं, पॉइंटर इसमें है लेकिन दिखेगा नहीं ना. अच्छा, रेड वाला है. What is the topic? Topic is fiber optic intubation. After some slide, we will go to video demonstration of fiber optic intubation. Fiber optic intubation is an effective technique for establishing airway access in patients with both anticipated and unanticipated difficult airway. It was first described by Peter Murphy. Peter Murphy ने जब पहली बार किया था, he was a surgeon or anesthesiologist. He was anesthesiologist. He was senior registrar anesthesia, and he does not have any fiber scope. He sees the surgeon. उसने सर्जन को देखा, they are using choledocoscope. तो उसने सोचा हम भी शायद कुछ देख ले एयरवे में. उसने एक पेशेंट में से ही देखने की कोशिश की, उसको अच्छे से दिख गया लैरिंक्स, और उसने इंटूबेट कर दिया. इट वाज इन 1960s, और उसने इस पे एक पेपर पब्लिश कर दिया. फेलो एनेस्थेसियोलॉजिस्ट ने सोचा कि ये तो, बट ही हैज नॉट गिवन एनी प्रूफ सच एज वीडियो और एनी फोटोग्राफ. तो सजन जो दूसरे एनेस्थेसियोलॉजिस्ट थे, उन्होंने कहा ये गलत है, हमें प्रूफ चाहिए. उन्होंने भी यूज किया. तो जब यूज किया पहली बार कोलेडोस्कोप, तो उनको क्या दिखाई दिया वहां पे? सिक्रेशंस, ब्लड, रेड रेड दिखाई दिया. उन्होंने कहा ये सब झूठ है, इन्होंने गलत किया है. तो ऐसे हमारा फाइबर ऑप्टिक स्कोप धीरे धीरे उसने कंपनी से लेके फिर उसने ट्राई किया. तो नाउ व्हाट इज द इंडिकेशन ऑफ फाइबर ऑप्टिक? We will discuss about indication, principle of fiber optic, component of fiber optic bronchoscope, nurse supply of airway, and how will we prepare the patient, and what are the complications. Indications are definite history of anticipated difficult intubation. हम यूजुअली क्या करते हैं, पहले किसी पेशेंट को इंटूबेट करना तो फाइबर ऑप्टिक को लेकर नहीं चले जाते हैं. पहले हमें अनएंटिसिपेटेड मिलता है, फिर हम एंटिसिपेट कर लेते हैं कि नहीं ये डिफिकल्ट है, फिर नेक्स्ट हम प्लानिंग करते हैं कि एंटिसिपेटेड है, हम फाइबर ऑप्टिक इसको यूज करेंगे. नोन आर सर्वाइकल, सस्पेक्टेड सर्वाइकल स्पाइन इंजरी और डिजीज, फेल्ड इंटूबेशन, कंजेनाइटल एयरवे एबनॉर्मलिटी, bronchial lavage we are using it in ICU, and in OT we are using verification of endotracheal tube positioning. It may be ETT or single or double lumen. हमने इंट्रोड्यूस कर दिया, ETT प्लेस कर दिया, लेकिन पेशेंट का सैचुरेशन नहीं आ रहा है. नॉर्मल लैरिंगोस्कोपिस किया, पता चला ट्यूब एक साइड लेफ्ट साइड चली गई, यूजुअली राइट साइड में जाती है, तो हम सिंगल एंडोट्रैकियल ट्यूब पोजीशनिंग के लिए भी इसको अच्छे से यूज कर सकते हैं. These are the component of fiber optic laryngoscope. It contains body, जिसमें हमारा होता क्या होता है, टिप डिफ्लेक्शन कंट्रोल लीवर, फोकसिंग रिंग, आई पीस, वर्किंग चैनल and insertion cord which contains fiber optic bundles, optical system and mechanical system. This is typical this is more illustrated. The tip of fiber optic bundle, fiber optic scope, it contains light source, objective lens and working channel. Usually the total length is 900 mm, 1 मीटर से थोड़ा आसी पास होता है, and insertion card की 600. This is body which contains eyepiece, focusing ring and suction channel and working channel. What is the function of working channel? हमने अभी ओटी में पूछा कि ये कौन सा चैनल, किसी रेजिडेंट ने बोला ड्रग चैनल है, तो हम जो वर्किंग चैनल है उससे हम ड्रग भी दे सकते हैं. व्हाट इज ऑक्सीजन? ऑक्सीजन इज ए ड्रग. हम ऑक्सीजन भी दे सकते हैं, उससे हम लवाज भी कर सकते हैं, और सर्जन क्या कर सकते हैं, अगर हमें बायोप्सी लेनी है तो हम बायोप्सी भी ले सकते हैं. अब ये है कि कौन सी साइज की हम यूज करेंगे, किसमें कितने साइजेस की आती हैं, तो 2.2 डिफरेंट कंपनीज अपनी साइज की बनाती हैं. 2.2, 2.5, 3 इंटरनल डायमीटर ऑफ फाइबर स्कोप. तो हम नियोनेट या प्री मैच्योर में 2.2 या 2.5 यूज करते हैं. अब हम इसमें कितने साइज की मैक्सिमम जो है 9 साल से बड़े के लिए हम 6 इंटरनल डायमीटर की यूज करेंगे. अब हम कितने साइज की ट्यूब डालेंगे उसमें, तो ट्यूब अगर हम 7 की डालेंगे तो फाइबर स्कोप का साइज हमारा कितना होना चाहिए, 1 कम होना चाहिए, 6. या ये इंपॉर्टेंट कि जो मिनिमम साइज की फाइबर स्कोप है दैट इज 2.2 mm इंटरनल आईडी. अब इसका साइज ही इतना छोटा है तो इसमें वर्किंग चैनल नहीं होता है. क्यों? क्योंकि टिप में हमें क्या रखना है, लाइट सोर्स भी देना है, लेंस भी रखना है, तो उसमें वर्किंग चैनल की जगह ही नहीं होती है. तो स्मॉलेस्ट साइज डज नॉट हैव वर्किंग चैनल. व्हाट इज द प्रिंसिपल ऑफ फाइबर ऑप्टिक? सो द प्रिंसिपल डिलाइड मेनली ऑन द टोटल इंटरनल रिफ्लेक्शन. ऑब्जेक्टिव हमने जो लाइट सोर्स टिप पे है, लाइट सोर्स टिप से ऑब्जेक्ट पे जाएगा, ऑब्जेक्ट से इमेज, वहां पे एक लेंस रहता है वो इमेज बनता है, दैट इज प्रोसेसेस and total internally reflected and goes to the eyepiece and processing unit that displays in the monitor. Usually light travels in parallel line. Critical angle is important. When the angle of incidence is equal to critical angle, light travels in parallel line. But in this scenario, the angle of incidence increases the critical angle and the light is totally internally reflected. So where angle of incidence is more than critical angle, light is totally. So the principle of fiber optics is based on total internal reflection. Sometimes examiner ask how will you sterilize. तो आपने टेक्नीशियन को देखा होगा, आप काम करने के बाद वो क्या करता है, सक्शन कर लेता है सक्शन पोर्ट से. यूजुअली दिस शुड बी सक्शन्ड विद डिटर्जेंट सॉल्यूशन. डिटर्जेंट से सक्शन कर लेना चाहिए। फिर उसके बाद स्टेराइल वाटर से सक्शन करना चाहिए, तो सक्शन चैनल आपका वो हो जाएगा। फिर उसके बाद हम इसको ईटीओ कर सकते हैं। ईटीओ कैसे करते हैं? 4 to 5 आवर्स के लिए 130 डिग्री फ़ारेनहाइट टेम्परेचर एंड 20 psi प्रेशर पे। बट रूटीन क्लीनिंग हम इसको कर सकते हैं। हाउ वी विल डू? इमीडिएटली क्लीन अप द फाइबर स्कोप एंड वॉल विद डिटर्जेंट solution followed by 20-minute hour disinfection with 2% glutaraldehyde. स्टोरेज हम कैसे करते हैं इसको? अगर हम इसको बेंड करके रखेंगे तो फाइबर ऑप्टिक में ब्रेक, सो इट इज स्टोर्ड स्ट्रेट। नाउ यू कम टू प्रिपरेशन ऑफ द पेशेंट फॉर awake fiber optic bronchoscopy. First, एक्सप्लेन द इंडिकेशन ऑफ द पेशेंट। पेशेंट को आप एक्सप्लेन करो कि ये नॉर्मल लैरिंगोस्कोपी नहीं हो सकती है, हम इसको फाइबर ऑप्टिक से करेंगे, आपको थोड़ा कोऑपरेट करना पड़ेगा। फॉलो द फास्टिंग गाइडलाइन, साइकोलॉजिकल प्रिपरेशन, टेक वीनस एक्सेस, बेसलाइन मॉनिटरिंग, एंड देन वी एडमिनिस्टर एंटीसाइलोगोग। इट इज मोस्ट इंपॉर्टेंट थिंग, एंटीसाइलोगोग। We usually use glycopyrrolate. अगर आपने ये नहीं दिया तो आप अंदर जाओगे, सिक्रेशन देंगे, you cannot see any structure. Anti-anxiety agent, we use midazolam. And then sedation for cooperation with spontaneous respiration. These are pre-medicated drugs: antiemetic, anti-sialogogue, anti-anxiety, and sedation, fentanyl. What are the application technique of topical anesthesia? We can spray, we can give local anesthesia in gauge piece, we can use cotton applicator, we can use McKenzie technique, atomization devices, inhalation of nebulized lignocaine, and spray as you go. The use of vasoconstrictor reduces the bleeding, shrinks the nasal mucosa, resulting in a better surgical exposure. Local anesthetic we use 2% for injection, 4% for nebulization, and 10% for spray. Commonly used local anesthetic are cocaine and lignocaine. Cocaine has an advantage because it has vasoconstrictor property, but it should be avoided in patient with hypertension and CAD. But usually we use lignocaine 4% solution and 10% spray. Topical anesthesia of airway, we have to anesthetize nasal passages, oropharynx, larynx, and trachea. Nerve supply of airway is by 3 nerves: trigeminal, blue color is seen, trigeminal nerve usually supplies the nasal area, glossopharyngeal nerve, oropharynx, and trachea and vocal cord, trachea and larynx by vagus. This is the area of nerve supply by trigeminal, glossopharyngeal, and vagus nerve. In an intubated patient, you can see which nerve supplies which area. Nasal passage is supplied by medial and lateral by anterior ethmoidal branch of nasociliary nerve, floor by superior dental nerve, and posterior long and short sphenopalatine nerve. We use xylometazoline for nasal preparation, 0.05%. Previously we use plazets soaked in local anesthetic. This diagram shows the plazets of local anesthetic for glossopharyngeal nerve block. Nasal preparation we have done. Now we have to see which nerve is left or right, which is very patent. So we have to, एक बार क्या हुआ कि हम लोगों ने फाइबर ऑप्टिक ब्रोंकोस्कोपी शुरू कर दी, ट्यूब लगा दिया, ऑन्कोटी की बात है। अब ट्यूब डालना, ट्यूब नहीं, सब कुछ दिख रहा है, ट्यूब नहीं जा रही है, तो So, first you choose that which size of endotracheal tube is feasible for intubation. So, progressively larger size of nasal airway coated with 2% lignocaine should be applied, so that we can see the appropriate size which endotracheal tube has to be inserted. Anesthesia of oral cavity and pharynx. We can use viscous lignocaine for gargle, that is 4%, and 10% lignocaine spray. After pre-medicating the patient, we usually nebulize the patient with lignocaine, that is 4%. Then we can go for invasive glossopharyngeal nerve block, and it is easily assessed by the transverse traverses the palatoglossal fold. A 25 gauge needle is inserted into the membrane near the floor of the mouth at the anterior tonsillar pillar, 0.5 cm lateral to the base of tongue. Advance slightly, and 2 ml of 1% lignocaine or 2% lignocaine can be injected. This diagram shows the glossopharyngeal nerve, and it is near to the tonsils. This diagram also shows the tonsil. It is near to the base of lateral part of base of tongue and in the palatoglossal and palatopharyngeal arch. And we can use some intubating oral airway. If you are going to intubate the patient orally, to avoid the biting of the fiber scope, we use airway, because it has slot to fit the insertion cord or tube. Ovocipian airway, Williams airway, Burman's airway. Sometimes it is asked in examination what is this and what is the name of this airway. And one is mask, Patil Syracuse mask. Sensory innervation of larynx. Now we come to toward the larynx. Above the vocal cord, it is supplied by superior laryngeal nerve, and below vocal cord, it is supplied by recurrent laryngeal nerve, and trachea is supplied by recurrent laryngeal nerve branch of vagus. This diagram shows the superior laryngeal nerve, which is between the hyoid bone and thyroid cartilage. There are two branches, internal branch and external branch. Superior laryngeal nerve block. It requires neck extension. Identify the greater cornum of hyoid bone and superior cornum of thyroid. Pressing the contralateral greater cornum of hyoid bone, laryngeal structure to be displaced toward the side to be blocked. This shows better anatomy. This diagram shows better anatomy of the superior laryngeal nerve. 22 or 23 gauge needle is walked.
Sorry to interrupt you. Hello, sir. Sorry to interrupt you. You have only 5 minutes remaining.
Okay, it is completed. Transtracheal block. Place index finger and third finger of the non-dominant hand in space between the thyroid and cricoid cartilage. A trachea can be held in place by placing the thumb and ring finger on either side of thyroid cartilage. The midline should be identified. This diagram shows the recurrent laryngeal left and right, which are traversing on side of the trachea. This is for transtracheal block between thyroid cartilage and cricoid cartilage. Immediately after introduction of the catheter into the trachea, a loss of airway resistance and aspiration of air confirms placement, and the needle is removed from the catheter. The patient is then asked to take a deep breath and then asked to exhale forcefully. At the end of expiratory effort, 3 to 4 ml lignocaine solution is rapidly injected into the trachea. The patient is asked to take a deep breath and fiber optic is passed through the vocal cord. If cough precipitated, additional lignocaine can be sprayed through the working channel. After passing through cord, scope is advanced till we see tracheal rings. When the tip of the scope is at the carina, tube is advanced into trachea. Rotate the tube 90 degrees anti-clockwise so that Murphy's ice comes anterior. This one will prevent tube tip to be hang up on the right arytenoid. After placement of the tube, withdraw fiber optic slowly while confirming the position of tube. Complications, you always know the local anesthetic toxicity complications, systemic toxicity, vascular injury, structural injury and gastric aspiration, trauma and local anesthetic toxicity. What is the cause of failure? Lack of experience, secretion and blood, inadequate anesthesia. Fiber optic should be held straight, never advance the scope if you are unable to see, pull back to avoid injuries, always use Byte block if using oral pathway. What is this? This is the view when you see the larynx. The first one shows Cormack-Lihan grade 1, 2 and 3, 2A and 2B, 3, grade 3 and grade 4. So what we use in our hospital, usually nebulization with 4% lignocaine, spray 10% superior laryngeal block, transtracheal block and spray as you go technique. Thank you. ये लेना है क्या?
Good morning everyone, myself Dr. Shashank, assistant professor here in KGMC. अभी होल्ड करेंगे, है ना, ठीक है. फाइबर ऑप्टिक इंटूबेशन हर JR3 का जो है सपना होता है यहाँ पे कि हमें फाइबर ऑप्टिक करने को मिले. JR2 असिस्ट करता है, आगे का सपना उनका पूरा होगा JR3 में. तो उसी का एक शॉर्ट वीडियो हमने बनाया जो हमारे रेजिडेंट्स ने किया था OT में. तो क्या हम देखेंगे उस वीडियो में? बहुत शॉर्ट वीडियो है, आपको बेसिक से समझाया सर ने, बाकी डिटेल में आपको थ्योरेटिकली एक्सप्लेन कर दिया है. बस आप क्या प्रोसेस करते हैं, क्या उसकी जो गाइडलाइंस है, कैसे कैसे आपको प्रिपेयर करना है. मेनली होता है हैंड हाइजीन एंड स्टेरिलिटी, उसको मेंटेन करते हुए आप कैसे फाइबर ऑप्टिक करेंगे वो ज़रूरी है. गंदगी तरीके से नहीं करना है कि जैसे आप कहीं भी करते हैं वैसा नहीं है, स्टेराइल तरीके से करना है, कोई भी काम करना है. प्ले करिएगा. पॉज कर यार, उसमें मुझे साउंड चाहिए, साउंड बढ़ाओ. भाई स्पीकर लगाओ.
Sterile surgical gown with a cap and mask, and also we should wear
एक सेकंड पॉज
sterile
करो,
surgical gloves of appropriate
पॉज
size.
करो यार, स्पीकर में कनेक्ट करो ना यार. माइक लगा के कौन चलाता है? शादी में थोड़ी ना बजा रहे हो. स्पीकर में कनेक्ट करो. मैंने मॉर्निंग में बताया था ना, सो कनेक्ट करने के लिए. उनको सुनाई नहीं देगा, वीडियो में आवाज़ ही तो है, वो नहीं सुनेंगे तो कैसे होगा. हम बाद में मिलेंगे, अभी वीडियो के मुलाकात होगी। चलो चालू करो।
Before we start doing fiber optic intubation, we should perform the following steps. First of all, we should do a hand hygiene or hand wash for 30 seconds at least. We should wash our hands with running water and soap from elbow to the tip of the fingers. After that, we should wear a sterile surgical gown with a cap and mask, and also we should wear the sterile surgical gloves of appropriate size. Patient should be explained about the process of awake intubation. Our goal is to provide conscious sedation for comfort and amnesia to patient. Patient should be given nasal decongestant like oxymetazoline in 0.05%. It should be instilled in both the nostrils. Patient should be nebulized with 4% lignocaine. 5 ml should be used to nebulize the patient before fiber optic intubation procedure. Before intubation, patient should be given pre-medication, that is IV antiemetics, IV anti-sialagogue. Lignocaine sprays of 10% and 15% spray are used to sensitize tongue, faucets, soft palate, uvula and posterior oropharyngeal wall. 3 to 4 sprays are required for 10% of concentration. To block the internal branch of the superior laryngeal nerve, a 25 mm needle is walked off the cornu of hyoid bone in an anterior chordate direction, aiming in the direction of thyroid ligament until it can be passed through the ligament. By pressing the contralateral greater cornu of the hyoid bone, the laryngeal structures to be displaced towards the side to be blocked. At a depth of 1 to 2 cm, 2 ml of 2% lignocaine with epinephrine is injected into the space between thyrohyoid membrane and pharyngeal mucosa. Block is to be repeated on the other side similarly. Transtracheal block can be achieved by placing your index finger and third finger of the non-dominant hand in the space between the thyroid and cricoid cartilage. Trachea should be held in midline by placing your hand on either side of the thyroid cartilage. Fiber optic bronchoscope consists of mainly 3 parts: the body, the insertion part and the tip. Body consists of a lever which is used in the movement of up and down of the tip, the suction port which is used for suctioning the airway secretion, and the working channel through which drugs are given when you are using spray as you go technique. Fiber optic bronchoscope, in some places there are monitors to see the airway structures, and in some places there are only optical eyepiece through which you can directly see inside the airway. After pre-medication, invasive blocks and nebulization, our patient is finally prepared for awake fiber optic intubation. We put the tip of the fiber optic through one of the nostrils gently. Via the airway, we advance the tip towards the epiglottis. When the epiglottis is visible, we use the 2% lignocaine, at least 2 to 3 ml, and spray it through the working channel to provide a spray as you go technique. After that, we gently move through the vocal cords and we enter inside the trachea. We will advance till we see the carina. Then the ET tube, which is being already preloaded on the fiber optic, will be advanced into the trachea through the vocal cords. After this, the ET tube is secured and the fiber optic tip is withdrawn back slowly and gently with under vision. We will secure the tube, and after the removal of the fiber optic, we will connect the anesthetic machine and check it its placement through ET tube and auscultation.
So basically आपकी ट्यूब पड़ गई तो पेशेंट सेफ है। और हमें ये चीज़ का ध्यान रखना है, जो हम लोग लोकल एनेस्थेटिक यूज़ कर रहे हैं तो उसका डोसेज, जो मैक्सिमम डोसेज अलाउड है, वो कितना हमें रखना चाहिए। कि जैसे अगर आप विथ एड्रेनलिन दे रहे हैं या विदाउट एड्रेनलिन दे रहे हैं, ठीक है। बेसिकली एड्रेनलिन देने के फ़ायदे क्या है? फ़ायदे यही है जो सर ने बताया, वैसो कंस्ट्रिक्शन करता है। तो उससे क्या होगा, एक तो आपका एब्जॉर्प्शन रेट स्लो हो जाता है, आप ज़्यादा उसको यूज़ कर सकते हैं और उसका इफेक्ट भी लॉन्गर रहता है। आप प्लेन वाला यूज़ करते हैं तो उसमें आपका लिमिटेड अमाउंट ऑफ डोज आप दे सकते हैं। टॉक्सिसिटी पे ध्यान देना है, मेनली CNS कार्डियोवैस्कुलर जो कॉम्प्लिकेशंस होते हैं उस पर आपको फोकस करना है कि 4.5 mg पर kg मैक्सिमम डोज आप प्लेन का यूज़ कर सकते हैं। एंड उसके लिए आप मैक्सिमम 7 to 8 mg पर kg तक आप जा सकते हैं विथ एड्रेनलिन, ठीक है। एंड अलग अलग सबके जो आप यूज़ करते हैं, जैसे 2% सॉल्यूशन यूज़ किया है तो उसके पर ml में कितना होता है, जैसे 1% में आपका 10 mg पर ml है, 2% में 20 mg है, ठीक है। और जो 10% आप स्प्रे यूज़ करते हैं तो 10% स्प्रे में क्या है, ईच पफ कंटेन्स ऑफ 10 mg ऑफ लिग्नोकेन, ठीक है। तो अकॉर्डिंगली आप यूज़ कर रहे हैं तो आप डोज कैलकुलेट कर लीजिए, मैक्सिमम 300 mg आप यूज़ कर सकते हैं लिग्नोकेन का, ठीक है, ताकि कोई उसके ऊपर आता है तो आपको टॉक्सिसिटी के फीचर्स ना आने लगे, ठीक है। बाकी वीडियो यहीं पे ख़त्म हुआ। कोई क्वेश्चंस होंगे और उसमें क्विजेस हैं, वो आपके लिए बाद के लिए हैं, तो अभी फ़िलहाल के लिए यहीं पे ख़त्म करते हैं। थैंक यू एवरीवन।
Thank you, Manoj sir and Shashank sir, for such an informative lecture and video. I request Professor Dinesh Singh sir to felicitate Dr. Manoj Chaurasia sir.
Next topic in airway management session is airway assessment and identification of a difficult airway. Speaker is Dr. Shireen Parveen, Associate Professor at Iraz Medical College. She has 12-year experience in anesthesiology. She has 15 national and international publications. Her area of interest are airway management, regional anesthesia, and pain management. Dr. Shireen.
Good morning, everybody. Thank you, sir, for introducing me. And I would also like to thank organizing committee for inviting me here. The topic of my lecture is airway assessment and identification of difficult airway. So airway assessment is an integral part of anesthesia, and all of you must know it already. So it is just for a reason why it is important to assess the airway. Next slide, please. Okay. According to the National Audit Project 4, which was about difficulty in airway management, failed intubation accounts for 1 in every 2,000 elective surgeries and 1 in every 300 in emergency surgeries. failed mask ventilation accounts for 1 in every 5,000 cases, and CI/CV situation contributes to 25% of anesthesia-related deaths. According to the ASA closed claims, database revealed that airway assessment accounts for 34% of all claims, and that difficult intubation has been the most common damaging event in anesthesia claims. So, why do we evaluate the airway? We evaluate the airway to predict difficult mask ventilation, to plan and prepare, and to choose a method. Prediction of the difficult airway allows time for proper selection of equipment, technique, and personal experience in difficult airways. So, I will be discussing my topic under the following headings. First of all, history, then general examination, then specific indices like individual and group indices. Then we will come to investigation and advanced indices. And finally, we will discuss about difficult airway. So first come in airway assessment is history. History is very important. We have to ask about previous anesthesia records of difficult airway. It is very important to ask. Then comes the history of any surgery, burns, trauma, or tumor in and around the airway. Then history of concurrent diseases like rheumatoid arthritis, ankylosing spondylitis, and diabetes mellitus. Any history of recent meals, any recent URI, and OSA, any caps, crowns, or loose teeth, all should be asked. Then comes the general examination. We have to look for dentition, distortion, disproportion, and dismobility. After taking a brief history, you can predict difficulty in airway management by just looking at the general appearance and facial features of the patient. If the patient is massively obese, if she's pregnant, if there is presence of facial hairs like beard, by just looking at the patient you can tell. Then these are the components of the airway examination. We have to look for nostril patency, length of the upper incisors and their alignment, condition of the teeth, relationship of upper incisors to the lower incisors, ability to protrude or advance the lower incisors in front of the upper incisors, inter-incisor distance, size of the tongue, visibility of the uvula, that is Malapati Grading, presence of heavy facial hairs, compliance of the mandibular space, Thyromental distance with the head in maximum extension, length of the neck, thickness of the neck, and range of motion of head and neck, and also cheek pad. Now, there are some airway compromising conditions which you can identify by carefully observing the patient. I'm not going into detail because time is very short. There can be some congenital conditions as well as acquired conditions. Then comes to the physical examination indices. We will talk about some specific indices to assess the airway in a systematic manner. First of all, we will discuss about the assessment of cervical and atlanto-occipital joint movement. Then we will discuss about assessment of temporomandibular joint function, then assessment of mandibular space, assessment of adequacy of oropharynx, and finally assessment of quality of glottic weaving. First of all, assessment of cervical and atlanto-occipital joint movement. For this, we have to find out whether the patient is able to flex the neck by touching his chin to the manubrium sterni, and whether he is able to extend his head adequately by looking at the ceiling without moving the eyebrows. These are the indirect indices of difficult airway, like prayer sign and palm print test. A positive prayer sign and palm print test are indirect indices to predict difficulty in airway management, as it may be associated with cervical spine rigidity. This is because stiffness of interphalangeal joints due to non-enzymatic glycosylation of proteins and abnormal cross-linking of the collagen. Now the assessment of temporomandibular joint function. Temporomandibular joint exhibits two functions basically. First of all, rotation of the condyle in the synovial cavity, which is responsible for 2 to 3 centimeter of mouth opening, and then the forward displacement of the condyle, which is responsible for further 2 to 3 centimeter of mouth opening. There are three methods to assess the temporomandibular joint function. First is interincisor gap, or we call it mouth opening. Second is jaw protrusion, and the third one is upper lip bite test. Interincisor gap should be more than 5 centimeter, or it should admit 3 fingers at least. When it is less than 3 centimeter, there will be difficulty in laryngoscopy and intubation. Similarly, mandibular protrusion test. There are three classes, A, B, and C. In class A, lower incisors can be protruded anterior to the upper incisors. In class B, the lower incisors can be brought edge to edge with the upper incisors. And in class C, the lower incisors cannot be brought edge to edge with the upper incisors. Class B and class C are associated with difficult laryngoscopy. Now the upper lip bite test. In class 1, lower incisors can bite the upper lip above the vermilion line. In class 2, lower incisors can bite the upper lip below the vermilion line. And in class 3, lower incisors cannot bite the upper lip. Significance is it has less inter-observer variability and poor predictive value. Now the assessment of mandibular space. Mandibular space can be expressed as thyromental and hyomental distance. This determines how easily the laryngeal and pharyngeal axis will fall in line when the atlanto-occipital joint is extended. Thyromental distance is the distance between thyroid notch and mental symphysis with the head fully extended. Normally, it should be more than 6.5 centimeter. When it is less than that, then you will face difficulty in airway management. Limitations are little reliability in prediction and variation according to the height and ethnicity. And for this ratio of height to thyromental distance, this indices is developed. It is a useful bedside screening test. Ratio of height to thyromental distance should be more than should be less than 23.5. If it is more than 23.5, it is a very sensitive predictor of difficult laryngoscopy. Hyomental distance is the distance between mentum and the hyoid bone, and it should be more than 6 centimeter. If it is less than that, then you will face difficulty in laryngoscopy. Another test is sternomental distance. It is the distance from the upper border of manubrium to the tip of mentum when neck is fully extended and mouth is closed. Minimum acceptable value is 12.5 centimeter. It is the single best predictor of difficult laryngoscopy and intubation because it has high sensitivity and specificity. Now, test for assessing adequacy of oropharynx. We can assess the adequacy of oropharynx by using Malapati grading and narrowness of palate. Malapati grading, all of you must know, it is a simple scoring system that relates the amount of mouth opening to the size of the tongue. It provides an estimate of space available for oral intubation by direct laryngoscopy. It is performed by having the patient open the mouth as wide as possible and stick out the tongue without phonation. Ensure that the patient is in sitting position and an observer's eye should be at the level of the patient's open mouth. All of you must have known the grades of Malapati grading, 1, 2, 3, and 4. It roughly corresponds to the Cormack's and Lehan's laryngoscopic view. Additionally, grade 0 can be given if any part of epiglottis is visible. But it has poor inter-observer reliability and has limited accuracy. Now the assessment of glottic viewing during laryngoscopy, Cormack and Lehan's grading. In grade 1, there is visualization of entire vocal cords. In grade 2, there is anterior commissure is not visible. In grade 3, epiglottis is only visible. And in grade 4, no glottic structures are visible. Now, the group indices. Because individual airway assessment tests are limited by their low sensitivity and positive predictive value, therefore, group indices has been developed in an attempt to improve the predictive value of the airway assessment. These are some of the group indices like Wilson score, Benimoff's analysis, Lemon's assessment, and all. Lemon law is we evaluate Malapati grading, obstruction, and neck movement. Look for facial trauma, swelling, tumor, large incisors, beard, large tongue, short neck, and evaluate for interincisor distance, thyromental distance, and thyroid to floor of mouth distance. Now comes the radiographic predictors. Plain radiographs can play a part in airway assessment, although not routinely. And CT scan is advisable only for complex airway pathologies. On X-ray neck, we can say if the occipit to C1 spinal process distance less than 5 millimeter, it predicts difficulty in airway management. Similarly, if there is increase in posterior mandible depth more than 2.5 centimeter and the ratio of effective mandibular length to its posterior depth is less than 3.6 and there is tracheal compression, it predicts the difficult intubation. CT scan is used in cases of complex airway pathologies to assess tumors, any trauma, inflammation, mass. Apart from the radiological predictors, advanced indices provides additional information about a potentially difficult airway, like flow volume loops, acoustic response measurements, ultrasound, and flexible endoscopy. Airway ultrasound. Point of care ultrasound of airways is a rapid non-invasive technique which can be performed at the bedside and can play an important role in airway assessment. So these are the advanced indices: airway ultrasound, nasoendoscopy, virtual endoscopy using CT images. Now the definitions of difficult airway. The clinical situation in which a conventionally trained anesthesiologist experiences difficulty with mask ventilation, difficulty with intubation, or both. Difficult ventilation, difficult intubation, more than 3 attempts, longer than 10 minutes, and failure of optimal or best attempt. These are the predictors of difficult mask ventilation. Prediction of difficult placement of supraglottic devices. How to predict difficulty in creating surgical airway. And to summarize, airway assessment is a critical part, and the difficult airway assessment must be performed prior to all attempts. While these criteria helps identifying difficult airway, it does not guarantee an easy intubation, so be prepared. Hope for the best, but always prepared for the worst. Thank you.
Thank you, ma'am, for such a wonderful lecture. I request Dr. Satish Verma, sir, to felicitate Dr. Shireen, ma'am. Thank you, sir. Thank you, ma'am.
Our next speaker for this session is Dr. Ashish Kanojia. He is additional professor in the Department of Anesthesiology, SCPGIMS, Lucknow. And his area of interest is airway management, development and designing of medical devices. He'll be talking about difficult airway management and newer gadgets of difficult airways.
Good morning, everyone. First of all, I would like to thank the organizers for giving me this opportunity. So, I will be talking about an overview of difficult airway management and some of the newer devices which has come up for airway management. So here, declaration and conflict of interest. I have some patents related to video laryngoscope and video bronchoscope, and provided consultancy to some of the manufacturers for airway management related products, but without any financial benefits. So what is difficult airway? As mentioned by previous speaker, so the first definition which is conventionally used is upper one, which was told by the previous speaker. So it's a clinical situation in which conventionally trained anesthesiologist experiences difficulty with face mask ventilation of the upper airway, or difficulty with tracheal intubation, or both. This is the conventional definition which has been given by Difficult Airway Society, which is used. But recently, American Society of Anesthesiologists has come up with the newer guidelines, which are given in 2022. So they have included not only mask ventilation and intubation, but also included difficulty in supraglottic airway placement and difficulty in extubation and difficulty in getting the invasive. So these are the differences which has come up recently. So let's see what is the spectrum of difficulty. So in previous definitions, only emphasis was on the mask ventilation and tracheal intubation, but now with the newer guidelines, they have covered the whole spectrum, starting from mask ventilation, tracheal intubation, supraglottic airway, and surgical access. So difficult mask ventilation has been already discussed by the previous speaker. So I will be touching only on the difference which has come up with the recent guidelines. So in previous one, when conventionally trained anesthesiologist using 100% oxygen was unable to maintain SpO2 of more than 90%, that was considered difficult mask ventilation. But now they have included confirmation with the EtCO2 as well. So this is main difference. Then recent guidelines have also included the signs of inadequate mask ventilation. So just go through these. And difficult laryngoscopy has been covered by previous speaker. The red colored one is the difference with the recent guidelines. So recent guidelines has included difficult supraglottic airway ventilation as well in the definition. So if conventionally trained anesthesiologist is unable to insert the supraglottic airway, or is unable to ventilate with the adequate ventilation with the confirmation of EtCO2, and there is obstruction in the inflow or outflow of gases, then this is taken as difficult supraglottic airway. Then many a times it is said that go for best attempt laryngoscopy. So what is best attempt laryngoscopy? Laryngoscopy which is performed by reasonably experienced laryngoscopist with the patient in optimal sniffing position, having no muscle tone, and the laryngoscopist has option to change the size or type of blade. So this is the best attempt laryngoscopy. Then when we face difficult intubation, we keep on trying attempts to intubate. So what is the end point when we should stop? So these are the indication for interruption of tracheal intubation, and try some other measures to restore the oxygenation to prevent hypoxia. So if intubation attempts has taken more than 30 seconds, patient saturation has gone below 90, and if there are arrhythmias or patient develops cyanosis, then this is the indication when you should interrupt the attempts for tracheal intubation and try other measures like supraglottic airway devices, bag mask ventilation, call for help, or other. These are some terms which are very frequently used. One is burp, that is backward, upward, rightward pressure. So this is different from what we call Selix maneuver. In Selix maneuver, we put pressure on cricoid, so to prevent aspiration. Many times that makes your laryngoscopy and intubation difficult. But here with burp maneuver, pressure is applied on the thyroid cartilage, and in 90% cases, it helps to improve the CL grading and thus helping in intubation. So then one term is triple failure. What is that? When you are unable to ventilate with the mask, supraglottic or intubation, then it is called triple failure, and this is the most dangerous zone, as you will not be able to oxygenate the patient. Then these are some techniques which are for difficult intubation, which has been enumerated, and techniques for difficult ventilation. So when it comes difficult intubation, what are the causes of difficult intubation? It can be patient related, it can be performer related, and it can be equipment related. Patient related has been discussed by the previous speaker, can be congenital or acquired. And performer related can be inadequate assessment, preparation and planning, lack of experience. And then equipment related can be malfunction of equipment or non-availability of equipment. Then airway management can be divided into assessment, planning phase, preparation phase, performance phase, then comes extubation and follow-up care. So assessment has been discussed depending on history, examination, radiological assessment. So these are some mnemonics which help to remember. So this is the overview of difficult airway management, which is taken from Difficult Airway Society Guidelines 2015. So there is Plan A, Plan B, Plan C and Plan D. So we'll be discussing one by one. So during planning and strategy, you have to, after assessment, if you anticipate that it is going to be difficult, then you have to plan and make a strategy whether you want awake or under anesthesia, you want with muscle relaxant or without muscle relaxant, you want to go for invasive or non-invasive, because in recent 2022 guidelines, they have given the choice to choose between invasive and non-invasive from the beginning. Then you want to go for conventional laryngoscopy and intubation, or want advanced like video laryngoscopes, fiber optic straight away from the starting. Then if you have anticipated the difficult intubation and want to plan for awake intubation, then you have to discuss with the patient and tell him why it is important, safety versus comfort. He may feel difficulty in breathing, he may have coughing and gagging, so you have to inform the patient and take the consent for that. Then what is Plan A? A you can consider is as alternate. So in alternate plan, you have alternate methods like different size, different types of blades, different handles, different positions, of the patient and the performer. You can use video laryngoscope, video stillates, boozies, or front of neck access even, and combination of those techniques. Like if you are having difficulty in doing intubation with fiber optic, then you can use combination of supraglottic airway device along with the fiber optic to increase the success. So this is according to newer guidelines of ASA 2022. Then plan B for bag mask ventilation. However, in newer guidelines, the supraglottic devices has been incorporated. 2-person bag mask ventilation can be used, and on each step, try to call for help and try to awaken the patient once intubation has been failed. Then plan C is try to oxygenate with bag mask ventilation or supraglottic airway device, because in new guidelines there is lot of emphasis on oxygenation, not on the intubation or securing a definitive airway. Rather, there is emphasis on the oxygenation and prevention of hypoxia. And plan D is front of neck access in the form of cricothyrotomy, tracheostomy. Then comes the stage of preparation. We have to prepare patient, we have to prepare equipment, and then performer. In patient, I have already told, counsel the patient, talk to him, what is the need of awake intubation, what we are going to do. If that fails, what is the backup plan accordingly. And in equipment, the basic equipment in the form of different sizes of conventional laryngoscopes, supraglottic airway devices, video laryngoscopes, fiber optic, and other resuscitative drugs and measures. And then performer have plan A, plan B, plan C, and performer should be experienced, having good experience with the technique with which you are planning to go. So in difficult airway situation, it is must that one should do only those techniques in which he is familiar and confident. So do not attempt any newer techniques or gadgets in difficult airway as such straightforward. First practice it on the normal airways, then only go for doing it on difficult airway. Then for preparation of patient, previous speakers has already touched upon it. Just remember the rule of 3. 3 group of drugs if you are planning for awake intubation. 3 group of drugs: anticialogogue, local anesthetic plus vasoconstrictor, and sedatives. 3 areas to be anesthetized: nasal passage, nasopharynx, and then oropharynx, and the larynx and trachea. And during block, 3 nerves or their branches to be blocked. So 3 drugs, 3 areas, and 3 nerves. So these has already been discussed. Then this is the recent guideline by ASA, what gadgets we should have when you are planning for management of difficult airway. So we should have rigid laryngoscope, different sizes, video laryngoscopes, tracheal tubes of different sizes, then boozies, stillates, supraglottic airways, fiber optic, and the last thing which has been recently added is you have to a way to confirm that your tube is in proper place. For that you need capnograph, disposable one, or the one which we are using. So this is a main difference from the previous one. Then fiber optic has been taken. Then comes the plan D, that is access of the front of neck. And that you have option of cricothyrotomy, maybe scalpel and bougie technique, or needle one, and then tracheostomy. So this is scalpel bougie technique. In most of the guidelines, this is preferred over needle technique, which was used previously, as the success rate with this technique is better and it is a faster technique as compared to the needle. So I'm not going into the details as time is not permitting us. This is needle cricothyrotomy. So recently there are recommendations for extubation as well, which has been included in the new ASA 2022 guidelines of ASA. So just go through it and just, if I have to summarize it, never plan extubation if it was a difficult airway without having proper backup for re-intubation, and it's very much advisable to go for guided extubation, and that you choose a bougie or tube exchange catheter over which you can remove the endotracheal tube, see whether he is able to maintain or not, or you can use fiber optic on which you can extubate the patient. So never go straight forward for extubation, and patients should be fully awake during extubation. So what are the do's and don'ts? Do's during awake intubation or difficult intubation: use anesthesiology, have different sizes of endotracheal tubes, different type of endotracheal tubes like PVC, flexometallic and all, and a different type of tip. Then have supraglottic airway devices of different sizes and different type of supraglottic airway devices having different sealing mechanism, because many times one type supraglottic may not work, like LMA may not work, but laryngeal tube may work and vice versa. So different type of supraglottic devices. At least you should have a 2 type of supraglottic devices with different sealing mechanisms. So it is highly recommended that one must go and practice at least 2 type of supraglottic airway devices with different sealing mechanisms in routine practice, so that we can utilize those expertise during difficult scenarios when there is a difficulty in intubation. Then when you assess that this patient is going to be difficult airway, do not produce deep plan of anesthesia. Do not use technique that you are not familiar, which I have already told you. Avoid multiple attempts. Call for help earlier. Discuss with the seniors what can be the plan. Make a strategy to have a plan A, plan B, plan C, according to your expertise, according to the gadgets and infrastructure available. And try to prevent hypoxia. So it is not the intubation which saves life, it is the ventilation and oxygenation which saves life. So oxygenation and prevention of hypoxia is the utmost important. And don't panic. Try to ventilate with the bag mask ventilation, try to ventilate with supraglottic and all, and call for help early if there is a situation of can't intubate, can't ventilate situation. So these are the main features of newer guidelines which have come up in 2022, which I have already mentioned. There is a lot of emphasis on oxygenation, there is a lot of emphasis on awake intubation, and there is emphasis on the number of attempts and total time which have passed. So these things should be taken, and they have included extubation guideline as well. So I would like to suggest that for exam going residents, please go through these guidelines, because these are the latest one which may be asked in the exam. So here comes the second part of my presentation, which will include newer airway management devices. Since I am not having much time, so I will be going just briefly into these devices, and will be discussing some devices which are of more interest. So supraglottic airway devices, as all of you know, they have revolutionized the airway management. So in newer devices also, this is the area which is growing very fast. In last decade, around 1 device per year was adding into the armamentarium. But in last 1 decade, it has increased to 2 devices per year. So this was the first supraglottic airway device. This is Leishman's airway, which was discovered in way back 1937, but never got popularized. The real revolution came when the laryngeal mask airway was introduced. So after that, there have been a number of devices which has been added into the. So some newer devices which you may be familiar, like Buska mask, LMA protector, LMA blockbuster, and some may be newer to you, like gastro LMA or gastro LT and intubating laryngotracheal tube. So this is Buska mask. I think many of you have must used it. It's a 3rd generation, so I'm not going into the details. This is LMA protector. So it's a newer laryngeal mask airway. It has got 2 gastric channels to help in the drainage, and it has got second seal also. So it is like ProSeal, but with additional gastric channel and secondary seal, which helps to prevent aspiration. So second seal, which you can see at the tip, it prevents aspiration. And unlike ProSeal, you cannot intubate through ProSeal because the airway channel is very narrow. But through LMA protector, you can intubate also blind as well as fiber optic guided. Then this is LMA gastro. This is specifically designed for endoscopic procedures. So here the gastric channel through which we used to put Ralph's tube is wide enough to allow the passage of endoscope so that advanced endoscopic procedures can be performed. Then this is gastro LT, again with the same principle. This is specifically designed for endoscopic procedures, advanced endoscopic procedures, where you need to give general anesthesia to the patient as procedure is taking a longer duration. So the main channel is wider, which is going to esophagus, through which endoscope is inserted, and the blue vertical one is for insufflation of gas and ventilation. This is how it is done. And this is a newer device. This is intubating laryngeal tube. Again, having wider airway channel, which allows fiber optic guided intubation and ventilation as well. This is AirQ. Many of you must have seen it. This is specifically designed for ventilation and intubation. So it has a short and wide channel with a removable connector. These are different type of AirQ. Mid one is AirQ self-pressurizing, in which you need not to inflate the mask. It is already inflated. And then AirQ blocker. In AirQ blocker, you have a additional catheter which has got a cuff at the tip so that it can prevent aspiration. This is LMA blockbuster. This is specifically designed for providing better ventilation as well as providing capability for blind intubation as well as fiber optic guided intubation. It has got a specialized endotracheal tube which has elongated tapered tip which allows easier insertion. This, you can see the tip. And this is video laryngoscope. It can be connected to smartphones or tablets. This is infrared intubating system. This is a very useful device. This is used during fiber optic guided intubation. How we use it? We have to apply on the cricothyroid membrane just like this and tie it around the neck. And when we switch it on, it gives flashes of light. So when you have difficulty during fiber optic intubation, which is esophagus, which is larynx, then it helps a lot. Like you can see in the lower, there are light transmitted through the cricothyroid membrane. So it helps in identifying where you have to go. Especially useful in difficult airways with lot of swelling and secretions. So it helps to guide your fiber optic into the airway. This is a microcuff tube. They have come up with the adult microcuff also. Initially it was marketed for pediatric patient. So main difference with the conventional tube is it's a membrane with which cuff is made is very thin. It's 5 to 6 times thinner than the conventional. It's around 10 micron. But the strength is 4 times higher. And with the lower pressure, it provides better seal. It doesn't have the wrinkles through which microaspirations can occur. So it is good for prevention of ventilator-associated pneumonias and all. This is a very interesting device. Rapid orotracheal intubation guiding system, what is known as ROTIGS. It was invented by ENT surgeon to help in the awake laryngoscopic and bronchoscopic visualization and intubation. So it incorporates a dental device, a Byte block, and a guiding channel. So it is very interesting device and helps a lot during intubation, awake intubation with a fiber optic guided. You have to insert like shown in upper part, and then you have to insert the fiber optic through the guiding channel. Since it's not touching the base of tongue, it will avoid the gag and it will keep your bronchoscope in the midline. So it makes a lot easier to do awake intubation. Then comes dual endoscopy. This technique is very useful, especially in very difficult airway situations. Here what we do, we use two visualization devices like a combination of video laryngoscope and video slit, or video laryngoscope and fiber optic bronchoscope to help you to guide the tube in proper place in lesser time. And it can be used in areas where there is lot of secretions and blood, which will make fiber optic intubation alone difficult. So in this, you can use the video laryngoscope to help to check out whether you are able to see or not. And then if there is lot of blood or secretions, then you can use video stillet or bronchoscope as a light vent. So it will help a lot in difficult airway situations. In newer guidelines, these combinations are allowed and recommended where you face difficulty with the conventional one. So then comes very interesting part, intubation robots. So there are a couple of intubation robots available. There are few case reports where these have been used in mannequins as well as in the patients. So this one is known as Kapler's intubating system. This is another one which has been developed. So The present intubating robots require manual assistance from a anesthesiologist, as you see during robotic endoscopic surgeries. But in coming time, many companies are working with the robots which will be autonomous based on the artificial intelligence, which will help to guide the tube based on the infrared sensors or electromagnetic fields to guide the tube in proper position. So it is assumed that in next 2 decades, these may be reality, and at many centers, these can be seen intubating the patient. But the problem with these robots is that once they are deployed in the proper working, the trainees which are getting intubations lot of times, and they are fighting who will be doing more. Maybe in coming time, you have to fight with the robot also, because many a times these robots will be deployed, and these will be based on the machine learning. So all the robots which are doing intubations, these data will be collected and these will be shared among these robots. So these robots will be having a vast experience as compared to the human. So for the experts, robots may not be that threat, but for trainees, it can be a problem. So thank you so much.
Thank you, sir, for such a detailed and informative lecture. I would now like to request Professor Dinesh Singh, sir, to felicitate Dr. Ashish Kanodia, sir. Thank you, sir.
Now the next topic would be airway management in emergency. How different and how difficult it is. Speaker would be Dr. O.P. Sanjeev, Assistant Professor at HDPGI Lucknow. He has 10 years of experience in anesthesiology and emergency medicine. He has total 27 national and international publications. He is reviewer and member of editorial team in some reputed journals. Dr. O.P. Sanjeev, sir.
Hello. Good morning, chairpersons. I sincerely thank you for kind words for me. Good morning, JP Singh, sir, HOD Anesthesiology, KGMC, and dear students. Till now, we have covered some crucial components of the airway management. Airway management begins with assessment of airway. It goes to difficult airway management, and then the advanced airway. I suppose all important components have been well covered till now. So I don't think anything is left for me to discuss with you. Do you think there is anything left? I don't think. किसी को एयरवे असेसमेंट, डिफिकल्ट एयरवे मैनेजमेंट और फाइबर ऑप्टिक से ज़्यादा क्या चाहिए? आई डोंट थिंक. पर हम आपको काम करेंगे, माल वही रहेगा, सिर्फ उस पर मेड इन इंडिया लिखा रहेगा. मतलब आपके जो एयरवे मैनेजमेंट आपको पढ़ाए गए हैं, आई विल अटेम्प्ट टू कस्टमाइज इट फॉर इमरजेंसी डिपार्टमेंट. Anesthesiologists are the experts of the airway. This is your domain. I am also an anesthesiologist, but I have turned out to be emergency physician. पर अधिकार आपका है, तो आपका डोमेन है, उसको बस मैं थोड़ा सा कस्टमाइज करूंगा कि ईडी में किस तरह से हो सकता है. बिकॉज आई हैव बीन ए स्टूडेंट ऑफ एनेस्थेसियोलॉजी फॉर 9.5 years. डिप्लोमा एनेस्थेसिया, डीएनबी एनेस्थेसिया, एमडी एनेस्थेसिया, सीनियर रेसिडेंसी, पीडीसीसी, एवरीथिंग. But he was never taught airway management in emergency department. If you look the data related with airway management in AD, you will find huge number of complications, huge number of peri-intubation complications, and misplacement of tubes in ED. Because airway management in ED is similar to the airway management in OR or ICU, but it's not the same. There are some differences, and difficulties are part and parcel of the hurriness. फ्लाइट्स में एक्सीडेंट हमेशा कम होती हैं, कार में हमेशा ज़्यादा होता है, क्योंकि कार में कभी भी हम लोग स्टार्ट करने के पहले शायद 5 सेकेंड का भी समय नहीं देते हैं to check even the tire pressure. There are only 4 tires in our car, but we never check it. Ignite करते हैं और भागते हैं. Flights में there is a checklist. Anesthesia में there is a checklist in OT. But in ED, the healthcare workers are not so well oriented with airway management. So there are multiple lacunas. We will cover slowly the things one by one. So my plan of presentation, I will begin with case scenarios. We'll move to challenges of airway management in ED, assessment of airway in ED, techniques of airway management, RSI, and at the end I will discuss some case-based approaches. I have put case scenarios before you to make you oriented about the need of, about the type of airway management in ED. Can some of you can read the first case for me, please? Of 56 here, first.
56-year-old man waiting in the queue for OPD consultation, falls down and becomes unresponsive. Rushed to the emergency department with doubtful pulse and only gasping respiration.
Okay, please, thank you very much, sit down. So what is the diagnosis here? Likely diagnosis. You cannot diagnose a case with just few words. Man was waiting for OPD consultation, he falls down, become unresponsive. भाई cardiac arrest का क्या है? Unresponsive, pulseless, no respiration और gasping respiration. तो आपके पास एक पेशेंट आ रहा है रस करता हुआ कार्डियक अरेस्ट, लाइकली कार्डियक अरेस्ट, नहीं भी हो सकता है, बट लाइकली कार्डियक अरेस्ट. सेकेंड केस, कैन समवन डिड प्लीज?
A young man comes to emergency department with stridor, drowsiness and cyanosis, which he developed acutely during a dinner party 15 minutes back.
What is the likely diagnosis?
Obstruction.
Foreign bodies.
Foreign body.
Choking. Okay, thank you. Third one.
A 62-year female weighing around 80 kg, a known case of COPD, arrives in emergency department with drowsiness.
Okay, so what is the likely diagnosis? Likely diagnosis just. Anyone? Maybe CO2 narcosis?
CO2,
Okay. Fourth one.
A 60 years male, known case of CKD with anuria, landed in ED with severe subacute
severe shortness of breath.
Shortness of breath.
Okay, thank you very much. So यहाँ पे severe shortness of breath है, the likely cause is fluid overload. The likely problem is hyperkalemia. So you have to use the anesthetic agents with great caution, right? So I have just put 4 cases before you to make it oriented about the need of the type of the requirement of airway management needs inside the emergency department. So challenges are, the need is unpredictable. The need may be emergent, the need may be urgent. Anesthesiologist given a call to manage the airway, to intubate, and when you arrive in ED actually, you find the patient is all well. So the need in ED is always unpredictable. The patient might have rushed due to hypoglycemia, he was drowsy. Before you arrive, emergency physicians had infused 25 or 50% dextrose, this patient is now all well. तो उसमें गुस्साना नहीं है कि हमें क्यों बुला लिए थे, हम important काम कर रहे थे डिपार्टमेंट में. Because the airway in emergency is dynamic in itself. It is always unpredictable. Second component is unfamiliar location, obviously. OT में हम लोग बिल्कुल शेर की तरह होते हैं. We can intubate any patient. But CT स्कैन रूम में क्या होता है, MRI सूट में क्या होता है, हालत खराब होने लगता है, बिकॉज द लोकेशन इज अनफेमिलियर. यहाँ पे तो दूसरा डिपार्टमेंट है, अनफेमिलियरिटी के और ज़्यादा चांसेस है. लुक एट द 3, पुअर इंस्ट्रूमेंट सप्लाईज एंड नो प्रिपेयर्डनेस. आप OT में रोज रोज एयरवे मैनेजमेंट का काम करते हैं अपना ICU में, आपके सारे आपका जो OT अटेंडेंट होता है उसको ही पता होता है इंट्राट्रैकियल ट्यूब क्या है, लैरिंजियोस्कोप क्या होता है, एट्रोपिन क्या है, ग्लाइकोपाइरुलेट क्या है. बट यहाँ पे आपको हो सकता है कि आपको उतना प्रिपेयर्डनेस ED में ना मिले, राइट. असेसमेंट ऑफ एयरवे इज डिफिकल्ट. टिल नाउ वी हैव गॉन थ्रू एटलीस्ट 5 or 6 slides of airway assessment, different scoring system by Dr. Serene and Dr. Kanozia, And everywhere it looked that everywhere there is an important component of mouth opening. Mouth opening is actually not possible if a patient is drowsy, if patient is agitated, if he or she cannot obey your command. आप बोलोगे मुंह दिखाइए बड़ा सा, हो सकता है कि अपना हाथ ऊपर उठा दे, अपना पैर ऊपर उठा दे. तो जब तक माउथ ओपनिंग का असेसमेंट आप नहीं कर पाते हैं, ना आप लेमन कर पाएंगे, ना 332 कर पाएंगे. तो एयरवे असेसमेंट इज एक्चुअली द बिग चैलेंज इन इमरजेंसी डिपार्टमेंट. एक बार मैं इसको और डिस्कस करूंगा आपसे अगर टाइम रहा. फुल स्टोमक, all emergency airways are full stomach, traumatic or non-traumatic. I am discussing here only critically ill, non-traumatic patients. Medical surgical history is largely unknown. And we encounter a patient of fluid overload in heart failure with severe shortness of breath, and actually the coexistent comorbidity is aortic stenosis. And patient may develop severe hypotension if fluid is not loaded during pre-intubation period and backup infusion of noradrenaline is not prepared. Decision making for the need of a definitive airway. Who will take the call that this patient actually needs intratracheal intubation? Patient bystanders is not going to give you a straightforward consent. Doctor sahab, go ahead, I am here with you. They will never say like this. They will always say, she was all well 2 hours back inside my home. What is wrong? Just in 2 hours, you are going to intubate him or her and put on mechanical ventilation. इंटुबेशन तो छोटी चीज़ है. अगर डिफिकल्ट इंटुबेशन है, फंस गए और उसका सर्जिकल लिया, अगर सिलडेंजर क्राइको करना पड़ा, क्राइकोथायरोटोमी, आप कैसे समझाओगे कि हम इनके साथ हम इनके गर्दन का ऑपरेशन करने वाले हैं? बीमारी फेफड़े की ऑपरेशन गर्दन का. सो ऑब्टेनिंग ए कंसेंट इज ऑलवेज डिफिकल्ट इन ईडी. इट इज नॉट एज convenient or comfortable as we see in our surgical patients. Challenges are not only limited with, as I mentioned in previous slides, we are always been taught proper positioning of patient for a convenient and easy intubation. In ED, this is not only patient which is positioned properly, but rather you have to also take a proper position to intubate. You can see the third image. If there is field, it was directed to us. Like COVID-19, another disaster comes with multiple injuries, and if people are sent to the field or railway station or airport to manage the airway, you will have to take the position as we are seeing in the pictures. Assessment of airway in AD I will not discuss because it is well elaborated by my previous co-speakers. So I will just discuss pitfalls for direct laryngoscopy and intubation and some pearls. Pitfall is mouth opening, no, many a time not possible. Malapati classification, no, why? Because Malapati classification is based on mouth opening and protrusion of tongue, not possible, many a time. Third, layman, M is Malapati, no. 332, 3 is mouth opening, no. So airway assessment is really challenging in ED. Pearls are assess the airway at earliest possible moment. आपको ED में बुलाया गया था, आपने पिछली बार इंटुबेट किया नहीं, आप आ रहे हो डिपार्टमेंट अपना वापस, कह रहे पेशेंट तो ठीक है. आने के पहले उसका एयरवे असेसमेंट जरूर कर लीजिएगा. अगर दोबारा कॉल आता है तो आप फिर झंझट में ना फंसे. कोई भी पेशेंट अगर ईडी में आता है उसका एयरवे असेसमेंट वैसे ही रूटीनली करना चाहिए जैसे सर्जिकल पेशेंट से करते हैं, जैसे आप लोग करते हैं. अब हमारा जब एकेडमिक शुरू होगा हम अपने जेआर्स को बताएंगे कि जैसे हेड टू टो मैक्लियोर और हचिसंस में लिखे हैं एग्जामिनेशन के लिए, यू मस्ट इंक्लूड एयरवे असेसमेंट इवन फॉर ग्रीन पेशेंट्स, बिकॉज एनी ग्रीन पेशेंट में become yellow and red anytime. So airway assessment must be an important component of head to toe examination for all patients coming to ED. Now some basic skills. Bag mask ventilation is very basic skill but very critical. It is not easy to acquire. Bag mask ventilation is very, very difficult. An anesthesiology resident can be passed if he or she cannot intubate, but he or she cannot be granted degree if he or she cannot ventilate by bag and mask. because oxygenation is priority as described in previous co-speaker, my teacher Dr. Kanauji है. Oxygenation is priority. Oxygen तो आपको करना ही करना है. You can use oropharyngeal airway or nasopharyngeal airway. We anesthesiologists, residents are very hesitant in using oropharyngeal airway. It is nothing against our ego if we cannot maintain the patency of the airway with basic skills of head tilt, chin lift and jaw thrust. अगर इससे एयरवे मेंटेन नहीं हो रहा है तो इसमें कोई इज्जत नहीं जा रही है. You can well use oropharyngeal airway. It makes the bag mask ventilation quite easier. Why not to use it? Why to struggle? Two-handed mask technique maintains better seal, we all know it. Frequent assessment of airway patency, ventilation and oxygenation, this is all required. Because this is not that you are going to just intubate the patient, give some anesthetic agents and putting the tube inside the trachea, no. You will have to resuscitate, you will have to participate in management of the patient thoroughly, comprehensively. Extraglottic devices we have just seen. Conventional laryngoscopy and tracheal intubation. Never hesitate to use endotracheal introducer or bougie. My dear friends, I am working in emergency medicine from last 3.5 years. Right, I have worked in anesthesiology for 10 years. I left my anesthesiology when I was regular faculty of anesthesiology at AIIMS Patna. In emergency medicine, I am from last 3.5 years. And what I recognized actually, our 90% intubations require bougie. Only 10 to 20% tracheal tubes are passed directly through laryngoscopy without aid of bougie or endotracheal introducer. So whenever you go to ED to intubate a patient, never hesitate to use bougie. Direct endotracheal tube, very difficult to introduce, very difficult to negotiate. Bougie makes your job quite simpler. And errors associated with failed laryngoscopy are rust or frantic laryngoscopy. Laryngoscopy without a plan. अब इमरजेंसी है तो प्लान तो रहेगा नहीं. बट हड़बड़ी का मतलब हड़बड़ी नहीं होता है मेरे दोस्त. हड़बड़ी का मतलब होता है प्रोटोकोलाइज्ड. ऐसी कोई भी चैलेंज नहीं है जो पहली बार आपके जीवन में आती है एयरवे मैनेजमेंट में. नो, पहली बार नहीं आती है. आपको कई बार पढ़ाया गया होता है, आप उसकी सेंसिटिविटी को समझ नहीं पाते. जितने सीनियर एनेस्थेसियोलॉजिस्ट होते हैं एयरवे मैनेजमेंट की प्लानिंग वो उतने ज़्यादा करते हैं. कई बार हम लोग कहते थे कि अरे मास्टर तो बेकार है तो डिले ही करा देता है रोज 10-15 मिनट. नो, चूंकि उसने अपनी आंखों से कॉम्प्लिकेशंस देखे हैं उसकी सेंसिटिविटी उतनी ज़्यादा है. Anesthesiologist is not just doing laryngoscoping and putting the tube, but rather it is the planning beforehand which makes your patient safe and you make also you safe. आपकी और पेशेंट दोनों की सेफ्टी है प्लानिंग में. आप कैसे प्लान करते हैं इसको. Laryngoscopy and intubation hardly takes 10 to 20 seconds, does not it? But the preparation may take hours together. घंटों लग सकते हैं. जब तक आपको बूजी नहीं मिल रहा है, you can well maintain oxygenation with bag and mask. What is wrong with it? Nothing. Advanced devices, already we discussed with the previous speaker. RSI. RSI is the cornerstone of emergency airway management. आप लोग भी करते हैं ना सर्जिकल पेशेंट में इमरजेंसी इंटूबेशन में. What does RSI stand for? Can someone help me? Please loudly. I wish to get it loud and clear. Rapid sequence intubation. Would anyone like to differ? The House A says it is rapid sequence intubation. House B, would you like to second or would like to differ? I don't think anything is done in rapid sequence in RSI. Intubation, laryngoscopy and intubation always takes 20 seconds. It takes minutes together for consultants, 40 seconds for JR3, 20 seconds for JR2 and 10 seconds for JR1. Because you people are confident. Less years of experience, more the confidence. JR2 वो एंटिटी है जो कंसल्टेंट को ढंग से चाय नहीं पीने देता है. बिकॉज वो अभी बॉस बना है, उसका JR1 आ चुका है. एक्सपर्टाइज अभी आई नहीं है. ही हैज नॉट एक्वायर्ड स्किल्स. ही इज नॉट सेंसिटिव बिकॉज ही इज नॉट रिस्पॉन्सिबल. JR3 उसके सर के ऊपर है. तो जीवन में इस बात को याद रखिएगा, एयरवे मैनेजमेंट में बहुत क्रिटिकल स्टेप है ये। किसी की जान जाती है या बचती है, यस और नो, आर पार की लड़ाई है। सो बी वेरी केयरफुल। JR3 इसलिए ढंग से काम करता है कि उसको कुछ स्किल्स आ गए होते हैं और थोड़ा वो डरा भी रहता है कि अगर कुछ कांड हुआ तो पास नहीं हो पाएंगे फिर। अदरवाइज JR3 भी वैसा ही कांड करे, बस ये डर जो है उसको थोड़ा रिलैक्स करता है और कंसल्टेंट उसके बेसिस पे चाय कॉफी अपना PPT बना लेता है, राइट। सो इंटुबेशन एंड लैरिंजियोस्कोपी इज ऑलवेज रैपिड प्रोसेस। ऐसा करते हो लैरिंजियोस्कोपी करके सोच रहे हैं कि अच्छा इंटुबेट करे कि ना करे, आज इंडोटेकल ट्यूब डाले कि नहीं, वी नेवर डू लाइक दिस। सो लैरिंजियोस्कोपी एंड इंटुबेशन इज ऑलवेज डन इन रैपिड सीक्वेंस। You can correct me if you find I'm wrong. So recently I read that the Society of Emergency Physicians read RSI as rapid sequence induction. And if you read the definition, I will read. RSI is the administration after pre-oxygenation and patient optimization of a potent induction agent followed immediately by a rapidly acting neuromuscular blocking agent to induce unconsciousness and motor paralysis for tracheal intubation. अब इस डिफिनेशन में कहाँ पे है लैरिंजियोस्कोपी और इंटुबेशन? बहुत जल्दी जल्दी कर रहे हैं हम लोग, नो। एक्चुअली RSI इज द प्रोसेस ऑफ रैपिड इंडक्शन, इज नॉट द रैपिड इंटुबेशन एनी टाइम. So there is a different school of thought, and they read RSI to be rapid sequence induction. और रैपिड सीक्वेंस इंडक्शन टर्म यूज करने से ये बात बिल्कुल क्लियर हो जाती है कि ये रैपिडिटी जो है वो इंडक्शन के साथ है या इंटुबेशन के साथ नहीं है, राइट. 7 इंपॉर्टेंट पीज ऑफ RSI आर प्रिपरेशन. देख रहे हो इतने हड़बड़ी में भी फर्स्ट पी इज प्रिपरेशन, सेकेंड पी इज प्री ऑक्सीजनेशन, थर्ड पी इज प्री इंटुबेशन ऑप्टिमाइजेशन. प्री इंटुबेशन ऑप्टिमाइजेशन क्या है? प्री इंटुबेशन ऑप्टिमाइजेशन इज लिमिटेड मोर और लेस टू द प्री ऑक्सीजनेशन ओनली, बट नो, you are going to manage the airway of a patient who may be hemodynamically unstable, and anesthesiologists are considered to be the best resuscitation amongst the medical fraternity, does not it? अब देखते हो ना कहीं पे कार्डियक अरेस्ट होता है, जैसे एनेस्थेसिया वाले पहुंचते हैं, अरे अब तो आ गए चलो, हो जाता है ना माहौल. मतलब अगर आप MBBS स्टूडेंट की नज़र से देखो तो एनेस्थेसियोलॉजिस्ट बिल्कुल भगवान की तरह अपीयर होता है. जहाँ पे 10 लोग ऐसे वैसे कुछ कुछ कर रहे हैं, जगल मतलब स्क्रम्बलिंग चल रही है, कुछ पता नहीं चल रहा क्या, जब एनेस्थेसियोलॉजी का JR भी आ जाता है तो ही टेक्स द लीडरशिप, इज नॉट इट. तो मेरे कहने का मतलब है कि उस लीडरशिप को मेंटेन करने के लिए सिर्फ प्री ऑक्सीजनेशन नहीं करना है. इफ यू फाइंड दैट द पेशेंट इज इन शॉक, टेक टाइम टू रिससिटेट. यू कैन टिल नाउ you can breathe with bag mask ventilation, there is nothing wrong. You can maintain oxygenation, right? Thereafter paralysis with induction, that is RSI actually. Positioning, placement with proof and post intubation management. तो इंटुबेट करके भागना भी नहीं है, राइट. इंटुबेट करके आप भागे और पीछे से ED का स्टाफ दौड़ता हुआ है कि साहब वो तो जो आप ट्यूब डाले थे वो तो फिक्स किए नहीं, तो ट्यूब निकल चुका है. स्टे ओवर देयर. सेलिक्स मैन्यूवर वी आर ऑलवेज टॉट कितना न्यूटन का प्रेशर लगाना चाहिए, कैसे प्रेशर लगाने चाहिए, बट इसका थोड़ा डाउटफुल रोल है RSI में. टाइमिंग ड्यूरिंग RSI इज वेरी इंपॉर्टेंट. 0-10 minutes, that is you can take up to 10 minutes for preparation, pre-oxygenation and pre-intubation optimization. So RSI does not mean that you have to jump with the laryngoscope and tube, and within fraction of second you have to put the tube inside the trachea. No, RSI is not like this. RSI is like preparation, pre-oxygenation, pre-intubation optimization, paralysis with induction, positioning, placement with proof, post-intubation management, right? मेरे बाद कोई स्पीकर है नहीं, लंच टाइम है, so I can extend for 3-4 minutes, but I will finish. I'll finish. So 0-10+ minutes. 10 minutes RSI gives you for preparation, pre-oxygenation and pre-intubation optimization. भाई गलती क्या है, दौड़ना क्यों है हड़बड़ी में? Take time to optimize before putting tube. 0 is the timing of paralysis with induction, where we administered induction agent by IV push, followed immediately by paralytic agent by IV push. 30 सेकेंड के बाद तक पोजिशनिंग कर लेना है. विद इन 45 सेकेंड, 0 to 45 सेकेंड में रैपिड सीक्वेंस इंडक्शन का मतलब क्या है कि हम लोग चूंकि एनेस्थेटिक एजेंट दे रहे हैं, एयरवे रिफ्लेक्सेस लॉस हो सकते हैं, फुल स्टोमक है, तो ट्रैकिया को जल्दी प्रोटेक्ट करना है, राइट. तो 45 सेकेंड के अंदर इंडक्शन के बाद, इंडक्शन 45 सेकेंड्स के अंदर ट्यूब प्लेस होने हैं और 0+1 मिनट में पोस्ट इंटूबेशन मैनेजमेंट शुरू कर देना है, राइट. Pre-oxygenation is with 100% oxygen, 8 vital capacity breaths is ideal for RSI, followed by 3 minutes of tidal volume breaths if possible. And if nothing is possible, at least 4 vital capacity breaths are important. Pre-intubation optimization during RSI. Fentanyl you all use very commonly. Fluids or blood for resuscitation, vasopressors, deep thoracostomy. Pharmacology of RSI, intermediate is the first choice. Why? हेमोडायनामिकली, हाँ जो आप समझ रहे हो वही बात है. Ketamine second choice. Ketofol needs validation, but to me it suits well for the ED purposes. The mixture of ketamine and propofol. Muscle relaxant, obviously the succinylcholine is first choice, and where it is contraindicated, you have to go for procuranium. और ये बात याद रखना है एक कि RSI कहाँ पे नहीं करते हैं, कहाँ पे नहीं करते हैं RSI. Yes, anticipated difficult intubation states contraindication for RSI. You must remember it. So surgical airways, rarely the method of first choice in ED, as I mentioned earlier. बीमारी सांस की, ऑपरेशन गर्दन का, nobody will allow to do it until unless crashing. But in situation of can't intubate, can't oxygenate, we can well go for, where there is a difference between life and death, we can well go for surgical airway access. Surgical cryo or its variant to be performed. Seldanger technique Seldanger technique has not been validated or proven to be superior to surgical cryo. So as per your experience, anesthesiologists go with Seldanger technique, surgeons go with surgical cryo. Now case-based approach, I will finish very shortly. अनस्टेबल पेशेंट पे क्या होता है, प्रीफरेंस डायलेमा होता है कि एयरवे फर्स्ट और रिससिटेशन, हेमोडायनामिक स्टेबिलिटी फर्स्ट. तो आपके अपने क्लिनिकल डिस्क्रिप्शन से वहां पे मैनेज कर रहे हैं कि किस तरह से वी हैव टू गो अहेड, राइट. आईवी हेमोडायनामिक ऑप्टिमाइजेशन करना है, आरएससी फार्माकोलॉजी आई हैव ऑलरेडी डिस्कस्ड. रिएक्टिव एयरवे डिजीज में क्या करना है कि एयरवे इज इनवेरिएबली पेटेंट एंड प्रोटेक्टेड, प्रॉब्लम इज विद रेस्पिरेटरी फटीग, ऑल कैन मैनेज. डिस्टॉर्टेड एयरवे, दिस इज इंपॉर्टेंट, आई विल टेक 1 or 2 minutes to finish it up. Distorted airways and acute upper airway obstruction. Causes of upper airway obstruction, I am dealing with critically non-traumatic patients. I am not going to deal with trauma patients, right? So infectious like viral and bacterial laryngotracheobronchitis, that is croup, parapharyngeal and retropharyngeal abscesses, hematomas, epiglottitis, Ludwig's angina किसी ने देखा है? किसी ने नहीं. Ludwig's angina किसी ने नहीं देखा. भाई तो फिर KGMC में पीजी का करने कोई फायदा नहीं है दोस्त. इंडिया का नंबर 1 कॉलेज है ये, यू मस्ट हैव सीन. तो लोग याद नहीं कर रहे हो या मतलब कुछ कंफ्यूज कर रहे हो, आई कैन से. द सबक्यूटेनियस जो फ्लोर ऑफ माउथ का इन्फेक्शन है, लडविग्स एंजाइना, वो एनेस्थेटिस्ट के लिए नाइटमेयर है, उसको मैनेज करना. आप अगर अपने सीनियर से पूछोगे, उन्होंने जरूर केस देखे होंगे और वो नाइटमेयर की तरह आपको एक्सप्लेन करेंगे. यहाँ पे एक रेड फ्लैग हमने किया है कि a patient with acute upper airway obstruction, a disrupted airway or distorted airway, who can protect and maintain the airway and can maintain oxygenation and ventilation should always be considered a difficult airway. Could you get it or not? A patient who has patent airway, who can maintain his oxygenation, but however it is a difficult airway. Why? Because this is distorted airway. There may be Ludwig's angina, there may be foreign body, there may be croup, there may be laryngeal edema due to bee sting. प्रोग्रेसिव एयरवे ऑब्स्ट्रक्शन है, इसलिए अपॉर्चुनिटी लूज ना करिए. वो डिफिकल्ट इंटूबेशन, डिफिकल्ट एयरवे है वो. प्रोलॉन्ग सीजर्स में हम लोग क्या करते हैं, जो prolonged seizures होते हैं उसमें intubations के indications हैं acute hypoxemia, prolonged seizure refractory to anticonvulsants. Foreign body in adult airway, you must have read in BLS or ACLS sequences. Pediatric airway हम एक बात बताना चाह रहे थे कि bag and mask ventilation is contraindicated in foreign body aspiration, but in case of pediatric foreign body you can well go for the bag and mask ventilation because the trachea of the newborns or young kids are compliant. Bag and mask ventilation can generate sufficient pressure to pass some gas of air between the foreign body and the tracheal wall. So bag and mask ventilation is never contraindicated in case of pediatric foreign bodies. Third is there is one push-pull approach. In push-pull approach, actually if you cannot retrieve the foreign body from the trachea, it is suggested to just push it in any of the two mainstem bronchus. What is the advantage of pushing it further down? Because you will get cleared at least one side of lung. So if you cannot pull, you can push it to the one of the main two mainstem bronchus, and then pull the tube to put in the trachea so that the other lung can be ventilated. Okay, thank you very much.
Any queries till now from the students?
Any questions?
Sir, I want to know the difference between RSI 1 and RSI 2, sir. Sir, RSI and modified RSI differences, sir.
Any more questions?
What you were asking, RSI and modified RSI. In RSI, you pre-oxygenate, you induce, and till you intubate, you should not ventilate. In modified, you can ventilate also with the low tidal volume. That is the main difference. Otherwise, ventilation is allowed in modified, whereas it is not allowed in RSI.
Thank you, sir, for sharing your deep knowledge and valuable experience of airway management and role of anesthesiologist in emergency department. I now request Dr. Satish Verma, sir, to felicitate Dr. O.P. Sanjeev, sir. Thank you, sir. I would now like to request Dr. Aparna Shukla, ma'am, to present a token of gratitude to our respected chairperson, Professor Dinesh Singh, sir.
Now, 15 minutes break for tea, and please finish the tea within time and come for next session after the felicitation. Yes. And quiz will be
and a
before
token of
lunch.
respect to our respected chairperson, Dr. Satish Verma, sir. Thank you, sir. Thank you, ma'am.
So we can now proceed for tea. तो लेट हो जाएगा.
सुनाई देगा? I request all the participants to come back inside the hall so that we can proceed with our next session. All delegates to return back to the hall as soon as possible.
हेलो अंकित कहाँ पे है?
वाला स्पीकर चलने लगा.
गुड मॉर्निंग, रादर गुड नून होना चाहिए, अब तो 11:30 हो गया है. आई ऑन द बिहाफ ऑफ डिपार्टमेंट ऑफ एनेस्थीसिया वेलकम यू ऑल, सीनियर पर्सन्स लाइक एल डी मिश्रा साहब, संजय धीराज. This is great effort on part of Dr. Manish and his team that he has started this program, and the planning of the department is it will be annual program. Whether it is central zone sponsored or not, we will do it for our students and other institutions. It will be in somewhere by end of February every year. And one request that please give some feedback after the end of this 3-day session. In Ram Manohar Lohia Hospital, they are having 7-day session, full day. So I will try to find out what we are missing and how to get it better on the feedback of yours, and from I will take some clue from RML Hospital, New Delhi. With these words, I again welcome you all, and especially Dr. L.D. Mishra Sahab. He's a great teacher and a great friend of the Department of Anaesthesia, KGMU. Welcome, sir. Thank you.
Thank you, sir.
Let us now proceed with our next session. So I would like to call our respected chairperson, Professor L.D. Mishra, sir, Professor, Department of Anaesthesiology, Saraswati Medical College, Chief Medical Superintendent and Distinguished Professor of Anesthesia for Life BHU, Varanasi. He was a former president of Indian Society of Neuroanesthesia and Critical Care, former vice president of ISA National. Our next chairperson, Professor Vishal Arora, sir, Professor, Head of the Department, Department of Anesthesiology, Saraswati Medical College. He is a certified ATLS and BLS instructor as FCCS and PALS instructor. Thank you, sir.
We all are here. I wish there could have been more PGs here, but somehow there are many programs going on around Lucknow as well as every part of India. So probably because of that, the number have gone down. I'm very happy to be part of this very interesting academic feast organized by the Department of Anaesthesiology, KGMU. I am especially very thankful to Dr. G.P. Singh and Dr. Manish. Lately, I have become very fond of Manish, he was working in Hindu Institute of Medical Sciences for a while with me, and I found him very, very interesting, interested in academics, and I said, this is not the right place for you. And that's how he kept trying, and now he's with you in the KGMU. My co-chairperson, Dr. Vishal Arora, I'm very happy that he's my colleague as well at Saraswati Medical College. Rather, I work under him. He is the head of department at Saraswati Medical College. The session today is on respiratory diseases. London speakers, 4 of them, will discuss on the pre-hospital, they will discuss about the evaluation, pre-operative optimization. I trust they will also talk about the pre-habilitation, which is like optimization, but there are some differences at some points. And then the management. The first 3 speakers will confine themselves to the pre-hospital, pre-operative evaluation, assessment, optimization, and pre-hospitalization, as well as the other aspect of monitoring. And the last speaker will present a very interesting case scenario of a lobectomy case with a respiratory problem. Here, the speakers as well as the students, I wish they will be covering 2 aspects of the presentation issues. When a patient with respiratory disease comes to us, he may need a lung surgery or a respiratory tract surgery. So those are one set of issues. Then a respiratory disease patient comes to us as associated disease. He has something something else presenting for which he needs surgery. Some other body system may be sick, maybe ill, and he may require some surgery other than lung or the respiratory tract. So even there, if patient has respiratory disease, there's a lot of need to be done. A lot of pre-hospital, pre-operative optimization is to be done. And issues are more or less same, but then yes, the differences are there. The case scenario is quite interesting, going to be. I trust Dr. Das, who is a very learned colleague, will also take the issue of pre-rehabilitation of his case before he talks about clinical management. So over to Dr. Vishal for introducing the first speaker.
Thank you, sir. Good morning, everyone. I'm honored to be here. We'd like to call our first learned speaker, Dr. Vinod Srivastav, who is Assistant Professor, Department of Anesthesia and Critical Care, KGMU. His area of interest includes difficult airway management and critical care anesthesia. He'll be delivering a talk on PFT's evaluation and examination of respiratory system. Dr. Vinod, sir, please start.
We will discuss the initial part of the respiratory system.
That is the basic, the evaluation and examination of the respiratory system, PFT, bedside PFT, and 6-minute walk test. So the question is why we need the examination of the respiratory system, especially in the field of the anesthesia. Because mainly we are concerned with the anesthesia, and the lungs is the most important organ for the anesthesia practice, for the anesthesia medicine. So the purpose of the examination is to locate the disease, to assess the disease, to locate to what part of the lung is involved, to its severity, and how to optimize and prepare patient for the surgery. So it starts. This? कहाँ से इधर से काम करेगी? Okay. So any part, any system is examined in the basically the two parts, the history taking parts and the physical examination part. Especially the respiratory system is, we can divide in the two parts, upper respiratory tracts and lower respiratory tracts. Our respiratory tracts start from the oral cavity or nasal cavities up to the larynx. And beyond this, all parts of the trachea, bronchus, primary bronchus, secondary bronchus, up to the alveoli, it is the lower respiratory tract. So the history. Patient present with either the history, patient itself tell, or you have to the skill to retrieve the symptoms from the patients, more or less related with the respiratory disease. There are some cardinal symptoms like the cough, expectoration, hemoptysis, chest pain, dyspnea, and wheezing. These are usually a patient present with these symptoms. You can say the patient has more or less the respiratory disease, although it may be also related with a cardiac disease. Then we have to focus some other symptoms that may be related with the system, hoarseness of voice, fever, evening rise of temperature, particularly in part in the tuberculosis, swelling of the feet. If patient has a chronic cor pulmonale, epistaxis, upper respiratory system examination was for the any ear, nose, throat, sinusitis, rhinitis, running nose, sneezing, etc. Syncope. Syncope may be patient. If patient has a severe and persistent may be present with a syncope. Bone pain, especially in the patient of the bronchogenic carcinoma, bone pain may be present. Altered mentation. Patient with a type 2 respiratory failure may have the altered mentation. Some general symptoms like appetite, loss of weight, especially in the pulmonary tuberculosis or the CA pains the patient, fatigue and sleep. These are the general symptoms that may be related with this disease. We also look for some past history. We also for the TB, any ATT treatment, alcohol, smoking, tobacco histories, family history of any asthma, allergy, eczema, and occupational, because lungs are very related with some occupational, like the patient working in the asbestos factory may be present with the symptoms. So the examination parts. Always examined, we do always physical examination done in the two parts. First is the general examination, and second is the systemic examination. We will examine for the general appearance, hydration, nutritional status, dyspnea, we see the patient is cachexic or not. We see any bedside clues, if there is a sputum pot or inhalers, can we assume that patient is have lung disease. While examining, we see the accessory muscle use, mental status, cyanosis, clubbing, JVP, pedal edema, lymphadenopathy, and tremor. All this may be related with the respiratory disease. This is the figure showing the clubbing. Actually, is the vulvar enlargement of the short part of the nail beds. We can see in the second figure, there is a loss of that diamond shape of the space when we finger to opposite to the nails. And if the clubbing is present, what comes in our mind? Maybe patient has some pulmonary causes of the clubbing, although it may be some extra pulmonary causes like the cardiac causes, congenital heart disease, some elementary causes, some endocrine disease, but more causes may be present, the pulmonary causes like the bronchogenic carcinoma, lung abscess, bronchiectasis, tuberculosis, diffuse fibrosing, alveolitis, and empyema. We also look for the tremor. If patient has especially the type 2 respiratory failure, CO2 retention may be present with a flapping tremor. Another condition where you find the flapping tremor is a hepatic encephalopathy, but we can just keep patient is present with other symptoms with the flapping tremors, that may be the cause of the COPD. Fine tremor, the patient taking regularly the beta 2 agonist, that may be side effect of that drugs. Now comment on the system examination. All part of the system, especially the chest, is examined in the 4 part. Every system is examined in the 4 part: inspection, palpation, percussion, and auscultation, as you all know, done in the MD, in the MBBS examination, final prof. We examine every parts very systemic manner, not from the top of the bottom to the, from the top to the bottom. We examine the front, side, as well as back side. There is some specified area. In the front is a supraclavicular area, infraclavicular, and the mammary area, inside axillary and infra-axillary. In the back side, supra, inter, and infrascapular area. So keep this picture in mind. While examining, you can just judge which part of the lobe is involved. Just see this figure. Now, first is the inspection of the chest. We see the first shape of the chest, whether the patient has symmetrical chest or not. Basically, we see the transverse diameter and anterior-posterior diameter. Transverse diameter is always higher than the AP diameter. The ratio is around the 7:5. But in some condition, if patient present with where is the transverse and AP diameter is almost equal, that is the barrel shape, found in the patient of the emphysema. Patient, if it is a transverse diameter less than the AP diameter, in some congenital disease, patient, especially child present with that is the pigeon shaped, called the pectus carinatum. Also present with the funnel chest, especially this is found in the occupational cobblers or some congenital disease. So flat chest, maybe the TB and rickets. We also look for some spinal deformity of the chest, kyphosis, scoliosis may be present. Now, second part of the inspection will look for the types of breathing. Basically, there will be 2 types of breathing: abdominothoracic or thoracoabdominal. The men are usually the abdominothoracic and the female are usually thoracoabdomen. But in some condition, we suppose is the purely abdominal, it concludes that the patient has some respiratory disease like the pleural effusion, pleuritis, if patient is predominantly of the abdominal respiration. Another part of the inspection is the rate and rhythm of respiration. Basically, the rate is 14 to 18 per minute. We see there is a regular or irregular. We look for the chest expansion, where the patient is expanding bilaterally symmetrical or not. We also look for the position of the trachea and the apex beat. These 2 points, we can estimate that there is a mediastinal shifting or not. So for the position of trachea, we look for the sign of the trail sign. In the lower figure, there is a trail sign. If trachea is shifted to that side, sternocleidomastoid become prominent on that side, giving the prominence of the, you can see clear in the below pictures. Looks for apex beat. If there is any visible pulsation, you can see the apex beat. Normally, the position is in the 5th intercostal space in the mid-clavicular line. We also look for some accessory muscles, LNEZ, sternocleidomastoid, intercostal recession. If the patient is, while talking, we look for, if patient has any distress, these muscles will be prominent. Also look for any scars, engorged vein or bulging on the chest, in the all area, front, back, as well as side, and then cervical lymph node. But the next part is the palpation. All the finding of the inspection is basically confirmed by the palpation, palpatory methods, with the tracheal position, apical impulse, movement of the chest diameter, chest expansion, and we also see some special, where is the phonation part, that it is transmitted up to which intensity will be discussed by here. So first we see the position of the trachea, whether the trachea is shifted or not. Normally the trachea is either midline or shifted somewhat right.
So how will we palpate? We keep the finger in the supraesternal notch, upward movement, and see the space between the sternocleidomastoid and the trachea. If there is equal space, we can say that trachea is in a central position. There is some condition we can estimate if the trachea is shifted to the same side, where is the fibrosis, collapse, or pneumonectomy. The trachea is shifted to the same side. In some conditions like the massive pleural effusion, pneumothorax, hydropneumothorax, that pushes the trachea to the opposite side. Now, this picture you can say how will you measure the transverse and AP diameters. If I inspection, what see there is a barrel chest, we measure here by the helping of the card and inch tape methods. We'll put a card front and back and then take the length between them. We also measure the expansion at the level of the nipple. This is the method. By the palm method we can examine the movement of the expansion. We put a palm of hand on the front, on the back, on the apices, and thumb in the midline, either sternum or the vertebral side on the back side, and ask the patient to inspire, to inhale, and see the movement of the thumb. It will move apart. Then we see there is the equal movement of the thumb, equidistant from the midline or not. If the equal movement, that can say that there is a bilateral symmetrical, and also see the distance between them. We can say what is the expansion. Normally 5 centimeter is there as expansion. No, tactile vocal fremitus. This is a basically when we
Dr. Vinod.
Yes, sir.
This side. Actually, you are expected to speak about PFT, the bedside PFT, and 6-minute exercise test. Those are very, very important information that we will.
Yes,
no,
sir,
but you have no time to talk all this, and then you will not have time for the other things. You have to prioritize more important things
sir,
in these 18 minutes.
We are trying to some proper general examination.
ठीक कर लो, लेकिन 18 मिनट में हम बंद कर देंगे. कर लो कोई बात नहीं है.
Okay, I will cover this very short.
We'll close at 18 minutes. 2 minutes for question answer.
Okay, tactile vocal fremitus, when we phonate, we keep the ulnar border of the hand on the intercostal space, and we found and ask the patient to say 999. We can estimate. There is some condition. If the increased TVF, the consolidation, cavitation, decreased TVF, this is the list of the left side. So percussion is the next methods. We percuss by the right hand on the left hand, the middle finger put on the intercostal space, and by the movement of the index finger, distal phalanx putting on the middle phalanx of the left hand. This is the methods. Area of percussion is the front. Usually in the front area we percuss up to the 6th intercostal because of the cardiac and liver dullness. In the lateral side we up to the 8th intercostal space, and back we up to the 11th intercostal space. This is the figure you can show. Now the percussion note. Basically we should have the practice with the it is a very subjective perception, so you should be well practiced with the normal patient. Resonant is found in the normal lung. If patient hyperresonant, we can assume that patient has a pneumothorax emphysema. Is a dull note, we can say there is a consolidation. There is a tympanic notes, which is usually found in the hollow viscous like the stomach and the larynx. We can say the patient has a myopneumothorax. Auscultation. Auscultation is by the stethoscope, and the same area like the percussion. This is the picture showing how we will examine. Bilateral symmetrically, one side by side, with the right, then left, then fill left, then go right. So whatever is sound usually, what is the normal sound? Normal sound is the vesicular sounds. And the characteristic of the sound is inspiration is longer and intenser than the expiration. There is no gap. This is the normal vesicular sound. Bronchial sound is when we put the stetho, if you want to know, put the stetho on the trachea or the larynx, you found the inspiration, expiration almost same intense, and there is a gap. Usually found on the tracheal larynx, but if it is found in any patient, so we can say the patient has a lung fibrosis and collapse. Vesicular breathing sound with a prolonged expiration, can say the patient has an obstructive disorder like the asthma and chronic bronchitis. We also look for some added sound like the rhonchi, capitation, and pleural. So we can, here after examination and history, we can assume that patient has somewhat respiratory disease or not. Then we go for the some specific test, basic test, we can evaluate in the bedside test, and then for some imaging studies. Now I will cover the next is the pulmonary function test. Pulmonary function tests are group of non-invasive tests that show how well the lungs are working. This test measures the lung volume, capacity, rate of flow, and gas exchange. It is used for to know the functional nature of the disease, whether it is obstructive or restrictive, identify site of air obstruction, to assess the severity of disease, to assess the prognosis of disease, as a response to treatment, and also identify the patient who has a perioperative risk of the pulmonary complication. So we basically categorize the PFT in a 3 categorization. Seeing the ventilatory function of the lung and chest wall, we do some the bedside PFT, static lung volumes and capacities, vital capacity, inspiratory capacity, and some dynamic lung volumes that is especially done in the spirometries, FEV1, FEVC, and the ratio of that. Gas exchange methods by the alveolar arterial oxygen gradients, diffusion capacity test, gas distribution test, and ventilation perfusion test. And last, some cardiopulmonary interaction to know the status of the cardiopulmonary status is do some test, 6-minute walk test, shuttle walk test, stair climbing test, and cardiopulmonary exercise test. Now, this can be usually done in the PSC. If you found the patient has a respiratory disease, we can estimate how the how the gravity patient has that disease. First, we do the breath holding test, suprassessed breath holding test. What done? Ask the patient to take a deep breath. After 2 to 3 normal breaths, take 2 deep breaths and hold till the next breath. And we have the stopwatch and calculate and measure the how much patient has hold this breath. If patient has more than 25 seconds, we can say this is the normal cardiopulmonary reserve. Between 15 to 25, we can say that limited CPR. And if there is a less than 15 seconds, very poor cardiopulmonary reserves. So this is if they are less than 15, we will further evaluate the patient to know the degree and severity of disease and optimization of the patient. This is the absolute the contraindication for the elective surgeries. So we can estimate the vital capacities basically if 25 to 30, 3500 ml vital capacity and so on. Now next is it's also very easy, can be performed in the PSC clinic, match blowing test, Snyder's match blowing test. How it will be done? There are some prerequisites before doing this. You should, while doing, you should not doing like this. You should only the tidal volume, you normal breathes. While blowing, you should have mouth wide open, not sleeping. Chin will support it, not movement. There should be no movement of the head or chin. There should be no air movement in the room. And the mouth and mouth should be at the same level. If any patient can blow out the mask, that we can estimate that he has breathing capacity of the 60 liter per minute, and the FEV1 is the more than 1.6 liter. But if cannot blow out much, we can definitely say this patient has limited capacity of this dynamic lung capacities. Another test is a Green and Berowitz cough test. We ask the patient to take a deep breath and do the cough, followed by the cough. If patient is able to cough, is a good strength, has a good effective, is a good capacity. If it is inadequate, we can say the patient has a less capacity. The FEC is less than 20 ml per kg, FEN is less than 15 ml per kg, and peak expiratory flow rate is less than 200 liter per minute. This is the next test is the force expiratory time. We put a stethoscope on the trachea and ask the patient to take a deep breath and forcefully exhale, and ask the sound, expiratory sound in the trachea. If it is a 3 to 5 seconds, we can say that is a normal. There is no any obstructive, basically no to the between the obstructive and restrictive disease. If it is more than 6, we can say the patient may have the obstructive lung disease. If there is a 3 or less than 3, maybe probability patient has the restrictive lung disease. The right peak flow meter is also done by a small device. Patient take a deep breath and exhale on that device and can measure the peak expiratory flow rate. Male usually has the 450 to 700 liter per minute. Female has 350 to 500 liter per minute. If less than 200 liter per minute, there is an inadequate cuff efficiency. Is a de Bono visual blowing test. It also measures the peak expiratory flow rate. This patient blows down a wide bore tube at the end of which is there is a whistle. एक साइड में एक उसके whistle लगा देते हैं and blow करते हैं इस साइड से तो उधर से आवाज आएगी. साइड में एक होल होता है जिससे एडजस्टेबल नॉब होती है. उस नॉब होल को हम बड़ा करते जाते हैं और देखते उस नॉब पे जहाँ पर वो स्टॉप करना बंद कर देता है, विशल ब्लोइंग बंद कर देता है, उस पॉइंट पर हम नोट कर लेते हैं. इसमें रीडिंग रहती है तो कितना पीक एक्सपायरेटरी फ्लो रेट. If it is less than 200, that the patient has the limited small airway disease. Now, this is a very important. Now, it is a handheld, the microspirometers. It has almost same features as like the spirometry what we do in the lab or departments. Basically, this can be done, is very portable and can be done in the PSC clinic, and most probably should be available after some times in all PSC clinic or in OPDs. So we same like procedure, we take a deep breath and exhale maximum for the 6 seconds. We can read vital capacities FE and FEC in this microspirometers. Another test is a single breath test. Ask the patient to take a deep breath and counts 1 to 3. Normal 30 to 40 minutes. If he can count that patient has a normal capacity. Is less than 30, then patient has some problems, some obstructive or restrictive disorders. Another is a bedside test or can be the pulse oximeter. This is very easy and simple. So now we come to the some specific spirometry. After doing the PFT, found the patient may have some disease, disorders of any obstructive or restrictive. We advise for the spirometry. It test works by measuring airflow into and out of your lungs. It cannot measure the residual volumes, so not the FRC and TLC. The dynamic parameters can be observed is the FE1, FEC, peak expiratory flow rate, mid force expiratory flow between 25 to 70% and maximum voluntary ventilation. But we keep that in mind before any referring any patient, we have to assess whether the patient has this disease or not, because these are some contraindication for the spirometry. If patient has hemoptysis of unknown origin, patient has a pneumothorax, unstable angina pectoris in the last 2 months, the recent MI, history of the recent MI, thoracic, abdominal or cerebral aneurysm, recent eye surgeries, recent abdominal or thoracic surgical procedures, any history of syncope associated with the forced expiration. We will not advise that patient for the spirometry. What we measures in the spirometry, basically three parameters index we can measure from the spirometry. We can estimate the patient. We can interpret it on this basis. Patient has what type of disease. FE1, it is the forced expiratory value in the first second, and it measures the general severity of the airway obstruction. Suppose the patient diagnosed airway obstruction, we can on the basis of the FE1 we can diagnose the patient as more than 80% of the predictive value. What is the predictive value? Every patient, every subject has a predictive value. There are some predictors like the age, height, genders, and ethnic features. We can calculate of each subject the predictive value of the FE1, FEC, the ratio, PFR. So we can compare from the predicted value. If it is more than 80 normal, 50 to 80 mild reduction, 30 to 50 moderate. So this is the next is the FEC, the maximum value air that can be breathed out forcefully in the maximum 6 seconds. Usually we don't need a total 6 seconds. So 80 to 20 normal, 70 to 80 is the mild, 50 to 70 is the moderate, and less than 50 is the severe reduction. This is the ratio of the what percentage of total FVC expelled in the first second is reduced in the obstructive disorders. So basically, based on these parameters, we can found four types of disease we can make a diagnosis. It may be the normal, obstructive, restrictive, or mixed obstructive and restrictive. For this, I am showing a flow chart. Always remember these flow charts in your mind. So it will be very helpful for deciding. First, we see the ratio FVO and FVC. If it is a normal, you can always say there is no obstructive lung disease. Either it may be normal or reduced. If FVC normal, then we can say the patient has a normal. If there is a FVC, forced vital capacity is decreased, we can say patient has restrictive disease. Second is the, if it is reduced, less than 70%, more than 70 is a normal. If less than 70 of the predictor value, we can the reduced. When see the FVC next part, normal, then patient has obstructive airway disease. If it is reduced, then the patient may have the mixed type of patterns, obstructive as well as restrictive. If obstructive, we further see the FV1, its severity, we can decide is the what type of the obstruction and by some reversibility criteria. And reversibility criteria is if any patient shows the post-bronchodilator therapy more than 12% improvement plus more than 200 ml in the FV1, we can say the patient has chances of the bronchial asthma. So there is some for your exercise. This is the reduce. What is the diagnosis? If you reduce is obstructive. If कभी भी रेशियो रिस्ट्रिक्टिव में reduce नहीं होता है क्योंकि उसमें वाइटल कैपेसिटीज बहुत ज़्यादा कम होता है, FV1 भी कम होता है रिस्ट्रिक्टिव में, बट FV1 और FVC is always normal or higher. If reduced, the patient most probably has the obstructive disorders. Forced vital capacity is normal. FV1 is decreased, so is obstructive. Next, this is a normal. FV1 is vital capacity is reduced. FV1 is reduced. What is this? This is a restrictive. Because of the ratio is a normal. FV1 is a decrease in both obstructive as well as restrictive. But the vital capacity is markedly reduced in the restrictive. Next is here reduce, here be reduced, vital capacity is reduced. Then is a mixed type of. There are some flow volume loop as we can see, and we can diagnose what type of the patient has a normal in the emphysema, in the unilateral main stem bronchial obstruction, fixed upper airway obstruction like the thyroid goiters, there are expiratory as well as expiratory, both phases affected. In the variable extrathoracic upper airway obstruction, like the there is a vocal cord palsy. In the variable intrathoracic, like the tracheomalacia, we see the expiratory phase is affected. In the restrictive disease, almost same the flow volume, but size is decreased. And last one is the neuromuscular weakness. So you have to remember this type of the flow volume loop. Now in the last 6-minute walk test, it is developed by the American Thoracic Society, and it was officially introduced in 2002. 6-minute walk test is a submaximal exercise test. It's used to assess the functional exercise capacity of the moderate to severe the cardiopulmonary disease. Basically, this test, we ask the subject to walk 30 meter or 100 feet corridor over 6 minutes. Patient को हम कहेंगे 6 मिनट तक आपको चलना है, 30 मीटर का एक कॉरिडोर बना लेंगे या 100 feet ऑलमोस्ट सेफ, और वॉक करना है. एंड देन वी मेजर द 6 minute वॉक डिस्टेंस. पेशेंट अगर बीच में रुक भी जाता तो कोई दिक्कत नहीं, रुक जाए फिर उसके बाद अगर मूव कर रहा है. इस 6 minute वॉक डिस्टेंस it also has some predictor value. It depends on the patient subject age, weight, height and genders. कुछ स्टडी की गई है, उन्होंने देखा है कि नॉर्मली फॉर द हेल्दी मैन के लिए 580 मीटर्स होता है एंड 500 मीटर फॉर द हेल्दी वुमेन. देयर इज अनदर स्टडी इन राइट L98. उन्होंने किया कि देयर में भी 630 नॉर्मल रेंज होती है, तो बहुत कंफर्म नहीं कि कितना होता है, डिपेंड ऑन द मेनी फैक्टर्स. Is used for the assessment of moderate to severe cardiorespiratory status, used for response to treatment. It is also for the predictor of morbidity and mortality. But there is some absolute contraindication, just like the spirometry. If patient has a recent history, unstable angina or history of MI, you should not advise for the 6-minute walk test. There is a relative contraindication at the time of examination if patient has heart rate more than 120, systolic blood pressure more than 180, and diastolic more than 100, should not advise. We can derive some how useful for the 6-minute walk test. We can derive the DSP, distance desaturation product. So if patient has initially 100% saturation, and while the 6-minute walk patient has a suppose 85, then we multiply the distance covered in the 6 minutes to the saturation and divided by 100. So we can estimate next time the patient comes, we do the same test and found the patient is improving or not. It also correlated with some PFT variables, FE1, FEC, and diffuse capacity of the carbon monoxides. Maximal oxygen consumption is also can be estimated by the 6-minute walk test. There is a calculation. Distance covered in the 6 minutes divided by 30, we can just what is the maximum oxygen consumption. If patient has less than 15 ml per kg per minute, suppose patient has walked only 400 meters and divided by 30, it comes almost 13 or 14, that means patient has a risk of morbidity and mortality is very increased. And very likely patient is less than 10 is also very high. So the greater your oxygen consumption, the more oxygen your body can consume, and the more effectively your body can use that oxygen to generate the maximum amount of the ATP energy. So what is our purpose? The proper and comprehensive examination of the respiratory system can avoid unnecessary overuse of invasive and expensive investigation. It predict perioperative complication, assess response to treatment, and helps in optimization of patient and could give the better outcome post-operatively. Thank you, sir.
Thank you. Thank you for the lovely presentation. Any queries or any comments by the audience? Any questions? Okay, we'll move on to the next topic.
Just to complete the subject, why only 6 minutes is taken? Why not 8 minutes or 5 minutes?
Sir, there is some study initial 9-minute test was done, but patient who has suffering from this disease cannot complete this. 6 minutes is, then it was done in 3 minutes and progressively increased, found that 6-minute walk is ideal in many different studies.
Not ideal. 6 minutes is good for sub-maximal exercise. It is not maximal, you are not tired, the individual is not exhausted, but he has performed fairly enough to the extent of sub-maximal. When you do when you also incorporate maximal exercise, then you call it CPET, cardiopulmonary exercise test, which is same as 6 minutes plus maximal exercise. So you have graded level of exercises, and you find the saturation and the oxygen level, and then you interpret. Thank you.
Thank you, sir.
So Dr. Anshul Jain will present a video, I'm not sure. Dr. Anshul Jain, a very learned colleague who is not here? Anshul not here? Dr. Anshul is a professor of anesthesiology at Jhansi Medical College. He is also vice principal. Recently, I had spoken to him about some examination matter, and he's a very friendly person while talking on phone. I'm sorry that he is not here. He'll be presenting a video on the pre-operative evaluation, pre-operative optimization, especially in COPD and asthma patients. I hope in his presentation he will also cover a general optimization in a surgical patient, at least in a respiratory surgical patient. So over to the video.
Good morning, everyone. I was supposed to deliver a talk in KGMU itself, but unfortunately, due to some administrative reason, I haven't been able to come. So I'm using Zoom, the biggest contribution of COVID. So you deliver this lecture. I'm sharing my screen now and hope you will enjoy my lecture. Here I go. Yeah. It's pre-op optimization and anesthetic implications in COPD and asthma patients. So first of all, I would like to tell you the problem statement. Pulmonary complications are the most common perioperative complication attributable to anesthesia, and they cause significantly longer hospital stays, and they are also most costly complications because most of the patient went to ICU, and you can understand the ICU charges are very high. Prevalence of these pulmonary complications are as high as 1.5 to 6.8%. Upper abdominal surgery are at increased risk, particularly. And in all these pulmonary complications, what is the most common factor? COPD is the most common underlying disease in all these cases. So, coming back to my topic, what is the definition means of asthma and COPD? So you can understand the basic pathogenesis and their implications in anesthesia also. Asthma is defined as a chronic inflammatory disorder characterized by reversible airway obstruction. Note the word reversible. And bronchial hyperresponsiveness. Clinically, asthmatics exhibit recurrent episodes of wheeze, cough, chest tightness, and shortness of breath. It is more prevalent in younger age group, and females are almost equal or slightly more than males. Means there is more prone in females. COPD, chronic obstructive pulmonary disease, defined as chronic disease characterized by persistent, note the word persistent airflow limitation that is usually progressive and is associated with an increased chronic inflammatory response in the airways and the lung to noxious particles and gases. It mainly affects elder age, and males are more prone than females. Now, if we compare both the asthma and COPD, we'll find that asthma is slightly more common. It is affecting my younger age group. Family history is there, completely reversible, and intermittent dyspnea is there. However, COPD is not fully reversible. Progressive dyspnea is there, and there is a history of exposure to risk factor. Sputum production is high, whereas in asthma, sneezing and wheezing is high. So, if we say the diagnostic criteria of the both the conditions, we will find a common factor, that is FEV1 by FVC. That is the force expiratory volume in 1 second divided by whole force vital capacity is less than 0.7, and there, which is reversible after bronchodilator therapy. However, in COPD, it will remain less than 0.7 even after bronchodilator therapy. मीन्स अगर हमने ब्रोंकोडायलेटर दिया और अगर कोई चीज पूरी तरह रिवर्स हो गई तो वो पेशेंट लैंड करेगा अस्थमा की कैटेगरी में, और अगर हमने ब्रोंकोडायलेटर देने के बाद भी पूरा रिवर्स नहीं हुआ, उसका जो रेशियो है वो 0.7 से कम ही रहा, तो वो लैंड करेगा सीओपीडी की कैटेगरी में. कब सस्पेक्ट करना है? हिस्ट्री में. इन केस अगर नॉन पेशेंट है देन इट्स ओके, अदरवाइज इफ अ स्मोकर, patient has a history of breathlessness, age has more than 60 years, and in hernia patient. Why hernia? Because hernia के लिए एक propensity क्या होती है कि जब इंट्राएब्डोमिनल प्रेशर बढ़े तो मोस्टली अगर पेशेंट कफ करता है तो उसको हर्निया होने के चांसेस ज्यादा हैं. इसलिए हर्निया में एक पेशेंट को स्लाइटली ज्यादा रिस्क रहता है कि मतलब ज्यादा चांसेस है कि वो सीओपीडी का हो. एग्जामिनेशन में what we can see is the use of accessory muscles, accessory respiratory muscles. Increase AP transverse diameter means the chest would be barrel shaped, maybe barrel shaped. And V's rhonchi cause crepitations on auscultation. Match blowing test is one test which provides a rough estimation of FEV1 and peak expiratory flow rate. Negative results suggest FEV1 less than 1.6 liter. You can see this figure. Here the patient or the subject is asked to blow the matchstick with the complete with or wide open mouth, means like that. Not ऐसे नहीं करना है, इस तरह करना है, इस तरह करना है. ठीक है. तो अगर उसका जो पीक एक्सपिरेटरी फ्लो रेट है, मीन्स एक्सपिरेटरी फ्लो उसका अच्छा है तो वो माचिस को बुझा देगा, अदरवाइज माचिस को नहीं बुझा पाएगा। तो ये क्या सजेस्ट करेगा कि उसका PEFR कम है और FEV1 कम है। और अगर फिर भी हमारा हिस्ट्री में नहीं निकल पा रहा पेशेंट को कि वी आर अनेबल टू क्वांटिफाई कि ये सच में COPD का है या नहीं है, तो देयर आर फ्यू क्वेश्चनेयर व्हिच वी कैन आस्क टू नो दैट पेशेंट माइट बी अ COPD पेशेंट, like do you smoke, do you have GARD, do you ever felt chest tightness or difficulty catching your breath, do you ever been told that you have wheezing, do you ever use any inhalational medication for your breathing, have you ever visited an emergency department for breathing problem, have you ever had frequent bronchitis, have you ever had rhinitis, do you frequently cough, or do you have allergy to latex or tropical fruits? So with these questionnaire you will find that 99% of patient, if they are COPD patient, they will answer some positive as on a positive note. So if we continue the examination after if we suspect a patient is of means COPD, and what next to do, you have to go for bedside spirometry with a diagnostic method of choice and categorize the patient as well. NICE scoring and gold classification for categorization is used. So what is the gold class categorization? In this, we categorize the COPD patient into 4 categories. There is mild, moderate, severe, and very severe, depending on the FEV1 of the percentage predicted. ये FEV1 परसेंट प्रेडिक्टेड का क्या मतलब होता है? मीन्स जो पेशेंट का FEV1 है उसको हम उसकी ही एज के और हाइट के जो नॉर्मल FEV1 है उससे डिवाइड करेंगे। उसका फॉर्मूला ये लिखा हुआ है। मीन्स अगर पेशेंट का तो उसका जो रेशियो आएगा वो हमारा होगा FEV1 परसेंटेज प्रेडिक्टेड। अगर इसका किसी भी पेशेंट का लेस देन 30 है तो वो सजेस्ट करता है कि बहुत ही सीवियर उसे डिजीज है। फर्दर इवोल्यूशन क्या करेंगे? चेस्ट एक्सरे एक रूटीन होता है कि हर कार्डियो रेस्पिरेटरी पेशेंट में हम चेस्ट एक्सरे कराते हैं, बट चेस्ट एक्सरे हैज नो मच इम्पैक्ट ओवर द मैनेजमेंट एंड साइमल्टेनियसली उसको रेडिएशन एक्सपोजर भी हो रहा है। और फिर तो if it's a hospital protocol you can go, otherwise you can avoid it. ECG more valuable than chest X-ray, estimate right heart strain secondary to lung disease. इकोकार्डियोग्राफी अगर सीवियर डिसीज है तो डेफिनेटली आप इको कराएंगे, अगर मेजर सर्जरी है तो भी आप डेफिनेटली इको कराएंगे। तो उससे एग्जैक्टली आपको पता लगेगा कि पल्मोनरी आर्टरी हाइपरटेंशन तो नहीं है। Arterial blood gas analysis particularly important in emergency situation. Estimate PaCO2 which may be eliminated. As you can see कि जो भी आगे भी आएगा कि हाइपरकैप्निया होता है कुछ पेशेंट्स में। ऑप्टिमाइजेशन, तो फर्स्ट क्वेश्चन अराइजेस कि व्हाई डू वी नीड ऑप्टिमाइजेशन? पेशेंट तो चलते फिरते आ रहे हैं तो उनमें क्या दिक्कत है, कि क्या दिक्कत हो सकती है? So anesthesia increase basal atelectasis first of all. Everyone know that under spontaneous respiration the means non-dependent portion of lung or apical portion of lung receive more मोर वेंटिलेशन परफ्यूजन रेशियो, और सेइंग जो डिपेंडेंट पोर्शन होता है लंग का उसमें वेंटिलेशन भी ज्यादा होता है और परफ्यूजन भी ज्यादा होता है। दैट्स बिकॉज ऑफ द नेगेटिव मींस पुलिंग मैकेनिज्म ऑफ आवर रेस्पिरेशन। ये प्लूरा नेगेटिव प्रेशर जनरेट करती है और उसके बाद एयर जो डिपेंडेंट पोर्शन है उसमें ज्यादा जाती है और परफ्यूजन भी जो डिपेंडेंट पोर्शन है उसमें ज्यादा होता है। लेकिन जो वेंटिलेशन परफ्यूजन रेशियो है वो जो नॉन डिपेंडेंट पोर्शन है उसमें ज्यादा होता है। बट व्हाट हैपेंस व्हेन अंडर एनेस्थीसिया एवरीथिंग रिवर्सेस, क्योंकि अब हम पॉजिटिव प्रेशर वेंटिलेशन देते हैं। तो इस केस में क्या होता है, जो लो रेजिस्टेंस एरिया होता है उसमें एयर ज्यादा जाती है, और इन दैट केस जो नॉन डिपेंडेंट पोस्चर है मीन्स उसमें एयर ज्यादा जाएगी, बट जो परफ्यूजन है वो अगेन डिपेंडेंट पोस्चर में ज्यादा जाएगा। तो वेंटिलेशन परफ्यूजन मिसमैच होता है। और जो बेसल पोर्शन है, जैसे कि अभी देखा आपने बताया मैंने कि उसके जो बेसल या डिपेंडेंट पोस्चर है उसमें एयर नहीं जा रही है, तो धीरे धीरे क्या होने लगेगा, उसमें अगर प्रोलॉन्ग सर्जरी है तो बेसल एपिलेक्टोसिस होने लगेगी। और एनेस्थेटिक एजेंट प्रोड्यूस अ इम्पैक्ट ऑन हाइपोक्सिक पल्मोनरी वैसोकंस्ट्रिक्शन आल्सो, एंड बिकॉज इन सीओपीडी देयर इज एयर एंट्रैपमेंट व्हिच रिजल्ट इन ओटोपी। ओके, तो वो एयर जो है वो उसमें पार्टिसिपेट ही नहीं करेगी डिफ्यूजन में, इसकी वजह से उसका जो रेस्पिरेटरी पैरामीटर्स हैं और ज्यादा डिटोरिएट होने लगेंगे। सेकेंडली, जो एनेस्थीसिया है, ड्रग्स एंड न्यूरोक्सियल ब्लॉकेड आल्सो दे हैव इम्पैक्ट ऑन सिस्टमिक वेस्कुलर रेजिस्टेंस, and airway instrumentation itself have posed deleterious effect on bronchovascular parameters. It may produce this bronchoconstrictions. Okay. और डिफ्यूजन ऑफ नाइट्रस ऑक्साइड इन एम्फाइसीमेटस बुले, तो ये बुले को एक्सपेंड कर सकते हैं और वो बुले फट भी सकता है, तो मींस द बुले में रप्चर, सो वन हैव टू बी कॉशियस व्हाइल यूजिंग नाइट्रस ऑक्साइड. अल्ट्रेशन इन CO2 लेवल नॉर्मल मींस अब जो पर्सन आपका चलता हुआ आ रहा है, हो सकता है उसको वो CO2 45 लेके चल रहा हो, आपने उसे एनेस्थीसिया दिया, आपने उसका CO2 कम कर दिया और आफ्टरवर्ड्स यू विल फाइंड दैट ही इज नॉट गेटिंग रिवर्स्ड. Why? Because you don't know the pre-op CO2 level what the patient has. So this and moreover, a reduced chest movement during surgery and in post-op period secondary to pain, it is itself very deleterious. So that's why we need optimization. So before optimization or means anything, we will perform a rapid risk benefit analysis. We will assess urgency of surgery and severity of disease, provide assurance to the patient, and under elective planned situations, COPD pose only little over 1% chance of additional complications. So the first thing is assess urgency of surgery. Means कोई भी अगर डायरेक्ट इमरजेंसी सर्जरी है, for example blunt trauma आया है, patient COPD का known case है, तो you can't say that we are going to means optimize this patient and afterwards we'll perform the surgery. You can't say that. You perform a risk benefit analysis. Means कि जो आपका ज्यादा रिस्क है वो क्या है, वो जो प्रॉब्लम है पेशेंट की अंडरलाइन डिसीज जिसके लिए सर्जरी हो रही है उससे ज्यादा रिस्क है, उसके प्रोग्रेशन से, या जो आप एनेस्थीसिया दे रहे हो इससे ज्यादा रिस्क है. सो बेसिक फंडा इज दिस. ड्यूरेशन ऑफ ऑप्टिमाइजेशन आई विल टॉक फर्स्ट, क्योंकि अगर कोई भी इमरजेंसी सर्जरी है तो हम जो भी चीज 2 आवर्स में कर सकते हैं वो करेंगे. अर्जेंट सर्जरी है तो 2 days में जो भी हम ऑप्टिमाइजेशन कर सकते हैं वो करेंगे, और इलेक्टिव सर्जरी है तो वी विल टेक अराउंड 2 weeks फॉर प्रॉपर ऑप्टिमाइजेशन. सो क्या करेंगे अपन ऑप्टिमाइजेशन में? सबसे पहले अगर पेशेंट स्मोकर है, वी विल ask him to stop smoking. Abstinence for as short as 12 to 24 hours pose beneficial effect. मीन्स अगर अर्जेंट सर्जरी भी है तब भी हम पेशेंट को कहेंगे कि आप अपना स्मोकिंग बंद कर दो, क्योंकि 12 to 24 आवर में पेशेंट का जो कार्बन मोनोऑक्साइड लेवल है ब्लड का वो कम हो जाता है. मीन्स उसका जो HbA1c कर्व है वो राइटवर्ड शिफ्ट होने लगेगा, उसका निकोटीन लेवल कम हो जाता है, एंड विद इन 48 to 72 आवर्स, विद इन 3 days कार्बोक्सी हीमोग्लोबिन पूरी तरह से खत्म हो जाता है, उसके सिलियरी फंक्शंस भी इंप्रूव होने लगते हैं. एंड इन it takes complete 3 months to decrease overall post-operative morbidity and mortality. But you can see that within means 12 hours में भी फायदा होना है उसको, तो जितना भी मिनिमम पीरियड है हम उसको एब्स्टिनेंस करने के लिए बोलेंगे. ओके. सेकेंड, we will dilate the airways, means relieve spasm. So how we are going to accomplish that? We'll give beta-2 agonist, we will give anticholinergics, we will give steroids. Okay, steroid reduce inflammation, so increase the diameter of medium and smaller airways. जो edema हो रखा है small और medium size airway का, अगर उसका edema कम हो जाएगा तो उनके caliber का size बड़ा हो जाएगा. ठीक है, this is how steroid used to work, and for all these drugs inhalational route is preferred over systemic route. And third part is loosening the secretions, that is liquefaction. For that what we are going to use steam inhalation and mucolytics, and third one is saline nebulization. So steam inhalation is itself a very good cheapest method, and it improves ciliary function too. Steam inhalation should be advised every 4 to 6 hours for 5 minutes, and you will find that within 2 to 3 days the chest secretions have been liquefied, and it's very easy to remove, means to drain them out. Treating the infection, use appropriate antibiotic as per the advice of respiratory medicine, and it has got a lot beneficial effect because RTI is the most common cause of acute exacerbation in COPD patient. Active respiratory tract infection increase chance of perioperative pulmonary complications by around 10 folds. Even in emergency situation, what I have told that 2 hours का optimization आपको लेना है, तो क्या करना होगा? Even in emergency situation, one should start a broad spectrum antibiotic with respiratory coverage before airway instrumentation. Means जैसे ही patient आया है, आपको लग रहा है कि severe emergency में है, तो उसको COPD का केस है, उसको क्या करना है आपको? एक तो उसके बीटा एगोनिस्ट स्टार्ट करना है और उसे एक एंटीबायोटिक का शॉट देना है जिसका रेस्पिरेटरी वो क्लियर में पैसेज हो, जैसे कि आप एमोक्सिक्लेव यूज कर सकते हो. ठीक है, तो और अगर इलेक्टिव सिचुएशन है तो यू हैव टू डिफर सर्जरी फॉर 2 वीक्स सो एज टू जो भी उसका इन्फेक्शन है ताकि वो पूरी तरह से सबसाइड कर जाए. सो afterwards you will try to remove the secretion. ड्रेनेज किस तरह कराना है, पेशेंट को कफिंग, इंसेंटिव स्पायरोमेट्री और वाइब्रेटर्स लगाकर हम ट्रेन करा सकते हैं. ओके, सो व्हाट आर द एनेस्थेटिक implications? If patient is already on bronchodilator and steroid, they have to be continued dose to be reported in preoperative room. So what will the choice of anesthesia? Everyone I think should know that preferred peripheral anesthesia is peripheral nerve blocks, and even in for truncal surgery, central neuroaxial block is preferred over general anesthesia wherever feasible. For major surgery, general anesthesia with epidural block is the preferred method. And for intrathecal block, there is one important consideration that I want to mention. लेवल है वो T8 से नीचे रखना चाहिए, क्योंकि T8 के ऊपर अगर पैरालिसिस होती है तो T8 के ऊपर एक्सपिरेटरी मसल्स की जो एसेसरी एक्सपिरेटरी मसल्स हैं उनकी भी पैरालिसिस हो जाएगी. नहीं, जो सीओपीडी का पेशेंट होता है वो एक नॉर्मल पर्सन की तरह उसका एक्सपिरेशन एक्टिव पैसिव प्रोसेस नहीं होता है, लेकिन बल्कि उसे एयर बाहर निकालने के लिए, एक्सपायर करने के लिए जोर लगाना पड़ता है, जिसमें उसकी एसेसरी एक्सपिरेटरी मसल्स यूज होती हैं. और हम स्पाइनल लेवल हाई कर देंगे तो वो ब्लॉक हो जाएंगी और वो पेशेंट अच्छे से एक्सपायर नहीं कर पाएगा. Now continuing anesthetic implication for general anesthesia, what are the preferred regard? For induction agent, ketamine and propofol are preferred. For muscle relaxation, vecuronium and rocuronium preferred, and volatile anesthetic, sevoflurane is preferred over halothane. And one more implication that you have to use humidifier gases. Halothane में क्या है, ये theoretically it sensitizes the myocardium to rhythmogenic effect of theophylline, and if we have got a better option, sevoflurane available, it's wise to go with sevoflurane. So these are agent and their mechanism, means respiratory mechanism. You can see in this table that opioids. One more thing that if everyone would like to have a few word about opioid. Opioid हम जो short acting है उनको use कर सकते हैं, और जो maintenance है उसमें ट्रेमाडोल preferred opioid होता है, और पेंटाजोसिन को भी अपन use कर सकते हैं. ठीक है, जो फेंटेनिल, एल्फेंटेनिल, सुफेंटेनिल, रेमिफेंटेनिल है, इसमें रेमिफेंटेनिल इसलिए क्योंकि शॉर्टेस्ट एक्टिंग होता है, उसकी मसल रिजिडिटी थोड़ी शॉर्ट एक्टिंग है तो थोड़ी कम रहती है, मींस ड्यूरेशन कम हो जाएगा उसका. वेंटिलेशन स्ट्रेटजी क्या होनी चाहिए? मॉडरेट टाइडल वॉल्यूम से हम पेशेंट को वेंटिलेट करेंगे. प्रेशर कंट्रोल वेंटिलेशन और वॉल्यूम कंट्रोल वेंटिलेशन दोनों यूज कर सकते हैं. जो एक्सपिरेटरी टाइम है वो हम बढ़ा देंगे, और पीप हम 5 to 10 सेंटीमीटर रखेंगे. इतना रखेंगे कि जो पेशेंट का ऑटो पीप है इसको हम ओवरकम कर पाए. परमिसिव हाइपरकैप्निया, अगर पेशेंट का प्रीऑपरेटिव CO2 लेवल ज्यादा है तो इंट्राऑपरेटिव CO2 का जो लेवल है उसको हम 40 मिलीमीटर ऑफ मर्करी के ऊपर मेंटेन रखेंगे, ताकि क्योंकि इन पेशेंट्स में क्या होता है पर्टिकुलरली कि जो रेस्पिरेटरी ड्राइव है वो हाई लेवल ऑफ CO2 पर मेंटेन रहती है. तो अगर हम CO2 लेवल कम कर देंगे तो पेशेंट पोस्ट ऑपरेटिव अर्ली रिवर्स नहीं होगा एंड ही विल रिमेन इन एपनिया. ओके, ओपियोइड्स में एज आई मेंशन दैट अवॉइड लॉन्ग एक्टिंग ओपियोइड, यूज under short acting opioid, remifentanil is the preferred one. So what happen if there is perioperative bronchospasm? Perioperative bronchospasm को हम आइडेंटिफाई कैसे करेंगे कि SpO2 पेशेंट का कम होने लगेगा और EtCO2 थोड़ा सा बढ़ने लगेगा, और जो पीक इंस्पिरेटरी प्रेशर है वो पेशेंट का रेज करने लगेगा. तो ट्रीटमेंट में सबसे पहले वी विल इंक्रीज FI टू मेंटेन SaO2 more than 95%. The thing should be noted that many people say that patient stop every surgery and start ventilating with 100% oxygen. No, but here the guideline would say that O2 is self-irritant to the respiratory mucosa and reduces the mucosal clearance also. And moreover, the target SaO2 should not be more than 95%, means not be 100%. It would be just more than 95%. तो अगर पेशेंट का 96% सैचुरेशन आ रहा है उसका FI 0.6 में ही, तो हम उसको 6 पे ही मेंटेन करेंगे. ये नहीं करेंगे उसे 100% ऑक्सीजन देकर उसका 98-9% लाने का ट्राई करें. General measures what we'll adopt, we will disconnect from ventilation and start manual back ventilation to evaluate pulmonary compliance and identify other causes of high circuit pressure. We'll increase the concentration of volatile anesthetic. जो भी हम volatile anesthetic यूज कर रहे हैं उसका concentration हम बढ़ाएंगे, एक्सेप्शन डेस्फ्लोरिन का, क्योंकि उसके concentration पर बढ़ाने में ब्रोंकोस्पाज्म के चांसेस होते हैं. तो और अगर अवेलेबल हम कुछ और यूज कर रहे हैं उसके बढ़ाने से फायदा नहीं हो रहा तो we may switch over to sevoflurane. We'll assess depth of anesthesia because many a times जो intubation induced bronchospasm है वो इसलिए होते हैं कि patient का depth adequate नहीं होता. And then if these measures fail, then we will we will administer short-acting beta-2 agonist by inhalational route. Proportionating and salbutamol are the drug of choice for that purpose. And the time of onset is within 5 minutes. The peak effect is within 60 minutes. And the duration of action is 4 to 6 hours. Efficacy wise, terbutaline और salbutamol दोनों की efficacy बराबर है. और particular thing ये है कि अगर हम इसको continuous रूट से दे सकें मीटर डोज इनहेलर से तो वो ज़्यादा बेहतर होता है बजाय इसको इंटरमिटेंट पफ्स देने का. और नेबुलाइज एपिनेफ्रिन का कोई एडिशनल बेनिफिशियल इफेक्ट नहीं होता है टर्बुटालोन और साल्बुटामोल पर. तो दिस इज वन मोर थिंग कि अगर पेशेंट का तुरंत इंटूबेशन या कोई चीज देने के बाद ब्रोंकोस्पाज्म हुआ है तो दो चीजें हो सकती हैं कि एलर्जिक यानी एनाफिलेक्टिक ब्रोंकोस्पाज्म है या फिर हाइपर रिएक्टिव ब्रोंकोस्पाज्म है. तो इसको डिफरेंशिएट करने के लिए होता है कि जो एनाफिलेक्टिक ब्रोंकोस्पाज्म होता है उनमें कॉन्कोमिटेंट कार्डियोवास्कुलर फीचर भी होते हैं. ओके तो मींस पेशेंट का बीपी फॉल होगा, पेशेंट का पल्स गायब हो जाएगा. बट जो हमारा हाइपर रिएक्टिव एयरवे की वजह से ब्रोंकोस्पाज्म होगा मींस तो उसमें ये सब इतनी जल्दी नहीं होगा. और इसमें जो अगर पेशेंट का बीपी भी फॉल हुआ है, पल्स भी ब्रेडिकार्डिया हुआ है या पल्सलेस हो गया तो इन दैट केस यू विल गिव 100% ऑक्सीजन, स्टॉप एनेस्थेटिक agent and manual bag mask ventilation you will perform and will keep the patient in treadle mark position. Okay, fluid epinephrine is the drug of choice in that case and you have to administer steroid also. Whereas in this hyperactive airway bronchoasthma as already told. सो अब पोस्ट ऑपरेटिव केयर में क्या करेंगे? पोस्ट ऑपरेटिव केयर में क्योंकि पेन कंट्रोल को हम टॉप मोस्ट प्रायोरिटी देंगे. वो मरीज को दर्द होगा तो वो ना तो खांस पाएगा और ना हिल पाएगा जिसकी वजह से उसका जो पल्मोनरी चेंजेस है वो बढ़ता जाएगा. तो एपिडुरल रूट को प्रेफर्ड करते हैं जहां पर फिजिबल होता है क्योंकि वो एक पर्टिकुलरली पैच को एनेस्थेटाइज कर देगा, मींस पेन कंट्रोल प्रोवाइड करेगा. ओपियोइड आर हाईली इफेक्टिव फॉर पोस्ट ऑपरेटिव एनाल्जेसिया लेकिन वो एक रिस्क भी कैरी करते हैं कि पेशेंट को रेस्पिरेटरी डिप्रेशन ना हो जाए. तो इसके लिए क्या है जो रिकमेंडेशन है वो ये है कि जो ओपियोइड की डोज है वो सीओपीडी पेशेंट में 50% रिड्यूस हो जाती है और बैकग्राउंड इन्फ्यूजन पर्टिकुलर आप पीसीए यूज कर रहे हो तो उसको हमारे को अवॉइड करना है. इंसेंटिव स्पायरोमेट्री शुड बी रिज्यूम अर्ली so as to prevent atelectasis. Okay? और जो पेशेंट का जो रेस्पिरेटरी केयर का ट्रीटमेंट चल रहा था वो भी हमें जल्दी से जल्दी रिज्यूम कर लेना चाहिए. So I think this is a short talk about this COPD and asthma, and you can see the pink buffer and blue blotter which you are learning since your MBBS period. So you can learn more about the our reference books like Miller and Harrison. Okay. Thank you.
Thank you, Dr. Anshul, for keeping time as well as deliberating the issue very well, very much in time. We are indeed, we have become wiser today on asthma and COPD. Any question, please? Or any suggestion from the senior faculty? Anybody? Dr. Das? Dr. Manish? Dr. Vishal?
The importance of cessation of smoking along with the pre-optimization measures are very important at postgraduate level for your practical and theory exams. They were stressed very correctly. And I think the further perioperative bronchospasm may occur even in ICU besides the OT cases. So a postgraduate has to learn this at the practical level besides the theoretical concerns also. So it was very well stressed by the speaker. Thank you.
Yeah, very good. In addition to stopping smoking as much as possible, the abstinence of alcohol, as well as taking up exercises as much as possible within the given time, especially in elective procedures, is going to help a lot, especially in these respiratory COPD patients, as well as asthma patients. In exercise, do not take it easy. It's a very useful thing if done for 6 weeks. It does a lot of good to the patient, including increasing body mass, the muscle mass, reducing complications. Indeed, alcohol abstinence for 4 weeks reduces complications to 31% from 71%. So there are umpteen number of references of advantages of all these. Psychological optimization is also quite important. So in addition to this, one has to remember that even though fortunately the bronchial asthma status is not seen so often, maybe none of you might have seen, but it might happen one day to any of us. Any of our patient may go into status asthmaticus, asthma patient, or may go into a difficult bronchospasm or hypoxemia. So we have to learn as to how to avoid first, because airway is very reactive. One should not do instrumentation unless patient is ready for that. Means adequate anesthesia, adequate depth of anesthesia, and adequate pre-operative optimization. As mentioned all this, including what I am telling, what Vishal has told. And then, in addition to all that, keep ready bronchodilators with you whenever you are dealing with such patients. Not necessarily only asthma, even COPD patients can have very difficult bronchospasm. So thank you so much. I think we have done a good job in this presentation. Now over to Dr. Vishal for the inviting third speaker.
Thank you, sir. We have another distinguished and exhaustive speaker, Professor Sanjay Dhiraj from SGPGI. We all know him very well. He doesn't need an introduction. His expertise is palliative care, ultrasound guided nerve block. He's a AHA certified instructor, BLS, ACLS, and he's also a nodal officer for Indian Academy of Palliative Care certification course. Over to you, sir. Thank you.
Thanks a lot for the introduction. And good afternoon, everybody. So, first of all, I would like to congratulate the organizing committee for such a nice event. And the topic for today is lung isolation techniques and devices. So, कितने लोगों ने किया है, वो कितने लोग devices क्या क्या हैं basically? DLT है और bronchial blockers हैं. तो कितने लोगों को DLT यूज़ कितने किया है? तो हाथ उठा लो प्लीज़. सब लोगों ने किया ना करीब करीब. और bronchial blockers नहीं किए. तो हम लोग ऐसा करेंगे ना, तो मेरे स्लाइड्स में पहले मैंने थोड़ा सा DLT के बारे में यूज़ किया है, तो लेट अस रिवर्स इट. पहले मैं bronchial blocker पढ़ा देता हूँ और उसके बाद हम DLT, क्योंकि DLT सब लोगों ने करके रखा हुआ है. ठीक है. सो हमको लंग आइसोलेशन करना क्यों? बेसिकली दो प्राइमरी कॉज हैं लंग आइसोलेशन. एवरीबडी नोज हिंदी में सब बात कर सकते हैं ना. ठीक. तो हमको करना इसलिए सो दैट फर्स्ट ऑफ ऑल वी नीड टू विजुअलाइज समथिंग. थोरेसिक कैविटी में हमको विजुअलाइज करना है, या हमको ऐसा करना है कि एक लंग को दूसरे लंग से सेपरेट करना है. ठीक. तो उसी तरह से इसके इंडिकेशंस भी बनेंगे. सो फर्स्ट ऑफ ऑल द एब्सोल्यूट इंडिकेशंस वुड बी लाइक टू अवॉइड स्पिलेज, लाइक इन्फेक्शन हो गया, अगर मैसिव हीमोरेज हो गया, आपको एक लंग में हो रहा है, दूसरे लंग से सेपरेट करना है, आपने ब्लॉकर यूज़ कर लिया या आपने DLT यूज़ कर ली. देन टू कंट्रोल द डिस्ट्रीब्यूशन ऑफ वेंटिलेशन, लाइक ब्रोंकल प्लूरल या ब्रोंकोक्रिटिस फिस्टुला है, एक सर्जिकल ओपनिंग है मेजर कंडक्टिंग एयरवे की, या कोई एक जायंट यूनिलैटरल सिस्ट है. ठीक है. या आपको एक यूनिलैटरल ब्रोंकोएल्वुलर लवाज करना है. और रिलेटिव इंडिकेशंस वो सब सर्जिकल इंडिकेशंस हैं. दैट इज़ थोरेसिक एनोरिज्म है, कोई न्यूमोनेक्टोमी करनी है. ठीक है. इसी तरह से सर्जिकल, अब जैसे अभी हम लोग क्या कर रहे हैं, ज़्यादातर जो CABG करा रहे हैं, हम लोग रोबोटिक करा रहे हैं कुछ, तो उसमें भी यूज़ कर रहे हैं ये ब्रोंकियल ब्लॉकर. सो रिलेटिव कॉन्ट्राइंडिकेशंस क्या हो जाएंगे? वही कॉन्ट्राइंडिकेशंस हो जाएंगे ना, जैसे कि अगर कोई डिफिकल्ट इंटूबेशन है, पेशेंट हाइपोक्सिया में है, ठीक है, पल्मोनरी आर्टरी हाइपरटेंशन है, या हो सकता है कि अननोन डिफिकल्ट इंटूबेशन है, सीवियर COPD जैसे आपने पढ़ा, हीमोडायनामिक अनस्टेबिलिटी है, आप पहले से एक में अपना स्ट्रेस है कि आपको ब्रोंकियल ब्लॉकर डालना है, या उसके साथ एक ऐसा है कि एयरवे भी डिफ़िकल्ट है, उसके साथ आपने एक पेशेंट लेकर रखा है जिसमें हीमोडायनामिक अनस्टेबिलिटी भी है, तो लेट अस अवॉइड इट. कोई फ़ायदा नहीं है उसमें उस तरह से करने का. Relevant anatomy क्या है? तो that we all know that 10 to 13 centimeters है. The offtake of the right bronchus is at 25 degree and the offtake of the left bronchus is 45 degrees. We know that this is the important part कि left main bronchus जो है continues about 5 centimeters and then divides. But the right main bronchus is shorter, it is wider and it is more vertical. Also जो उसका ऑफटेक है, जो एक राइट अपर लो ब्रोंकस है, दैट इज़ लाइक इट इज़ 2 सेंटीमीटर्स रादर देन 5 सेंटीमीटर्स. वहाँ 5 सेंटीमीटर्स है, यहाँ 2 सेंटीमीटर है इन अडल्ट मैन एंड 1.6 इन अडल्ट फीमेल्स. दो मेथड्स हैं हमारे, डबल ल्यूमेन ट्यूब और ब्रोंकियल ब्लॉकर्स। अब ब्रोंकियल ब्लॉकर में चले आते हैं पहले हम लोग, और ठीक रहेगा। हाँ ठीक। तो ब्लॉकर्स जो है ना, राइट और लेफ्ट को ब्लॉक करना है आपको। एडवांटेजेस क्या है, जैसे कि आपने एंडोट्रेकियल ट्यूब प्लेस की है, वहीं से आप ब्लॉकर प्लेस कर सकते हो, ठीक है ना। आपने एंडोट्रेकियल ट्यूब डाल दी पेशेंट में और उसके अंदर से आपने ब्लॉकर डाल दिया। डबल ल्यूमेन ट्यूब तो आप ऐसा नहीं कर सकते, डबल ल्यूमेन ट्यूब एक डबल ल्यूमेन ट्यूब है, उसमें से नहीं जाएगा, ठीक। इट कैन बी यूज इन पेशेंट्स ऑफ एयरवे ट्रॉमा में भी यूज़ कर सकते हो। कभी कभी ना एंडोट्रेकियल ट्यूब क्या, डबल ल्यूमेन ट्यूब अगर यूज़ कर रहे हो और पेशेंट को एयरवे ट्रॉमा है, तो इट बिकम्स वेरी डिफिकल्ट टू नेगोशिएट दैट द डबल ल्यूमेन ट्यूब। ब्रोंकियल ब्लॉकर का ऐसा नहीं है, आपने एंडोट्रेकियल ट्यूब डाल के रखी है, उसमें से आप ब्लॉकर प्लेस कर दोगे, ठीक। और सिलेक्टिव लोअर ब्लॉकेट भी कर सकते हो, ये हम लोगों ने किया नहीं है। डिसएडवांटेजेस क्या है कि आपको 7.5 तो मिनिमम चाहिए ट्यूब, क्योंकि आपको ना कभी कभी आपको दोनों चीज़ें डालनी है, उसमें से फाइबर ऑप्टिक भी जाएगा एंडोट्रेकियल ट्यूब में से, और उसमें से ब्लॉकर भी जाएगा, ठीक है। तो दोनों चीज़ें जाएंगी, और इसलिए आपको मिनिमम 7.5 की ट्यूब चाहिए, पर 8.5 की आपको ऑप्टिमम है, वो उतनी आप यूज़ करते हो, है ना, ठीक। और इट इज़ डिफ़िकल्ट टू सील ऑफ द राइट अपर लोब, क्योंकि आपको पता है ना उसका ऑफ शूट हो जाता है, तो थोड़ा मुश्किल पड़ता है उसके लिए। और इट इज़ मच जैसे डबल ल्यूमेन ट्यूब तो आपको पता है कि आप उसको छोड़ भी देते हो तो अब निकलेगी नहीं है वो, पर ब्रोंकियल ब्लॉकर ऐसा नहीं है। आपको समझ में आएगा कि इट इज़ मोर डेलिकेट, सो इट कैन गेट डिसलॉज्ड। अब ना ब्रोंकियल ब्लॉकर्स भी बहुत तरह के आ रहे हैं। तो पहले तो उन लोगों ने क्या किया था कि एंडोट्रेकियल ट्यूब में ही इनकॉर्पोरेट करके रखी हुई थी एक ब्रोंकियल ब्लॉकर। साइड का चैनल है, एंडोट्रेकियल ट्यूब डाली आपने, उसमें साइड में चैनल है, उसमें ब्लॉकर आपने आगे बढ़ा दिया, ठीक। तो इसको कहते थे यूनिवेंट ट्यूब। पर अभी जो आ रहे हैं, और हम लोग जो अभी यूज़ कर रहे हैं, आंट वाला एंडोब्रोंकियल सेट यूज़ कर रहे हैं। एक ये है, एक कोहेन है, एक फूजी ब्लॉकर है और ईजी ब्लॉकर है, ठीक। अवेलेबल साइजेस क्या है, इसका ज़्यादातर 5, 7 और 9 फ्रेंच है। फ्रेंच का क्या है अभी, फ्रेंच कैसे करते हो आप लोग डिफाइन? फ्रेंच 1 फ्रेंच या किस तरह से करते हो? हाँ 1/3, ठीक। तो जितना भी आएगा फ्रेंच उसको 3 से डिवाइड कर देंगे तो आपको पता लग जाएगा कितना मिलीमीटर की ट्यूब है। एक्सटर्नल डायमीटर है ये। तो इस तरह का ब्लॉकर है, ठीक है। इसका ये वाला टिप है, ये बैलून है इसका, ठीक है। और जो ये आंट वाला है, ठीक। और इसकी यहाँ पर एक लूप होता है, ठीक, जो कि ये लूप में हम लोग, ये वाला जो लूप है ना इस तरह से डिजिटल लूप, ये हम लोग ना उसके अंदर ये फाइबर ऑप्टिक में उसको डालेंगे, ठीक है। ये पूरा ट्यूब है और यहाँ पर एक ये अडेप्टर है, ठीक है। इसको अब और स्टडी करेंगे हम लोग। सो ये ब्लॉकर है, हम लोगों ने निकाला, ये ब्लॉकर का एंड है जो कि राइट या लेफ्ट ब्रोंकस में जाएगा, ठीक है। तो पहले हम लोगों ने क्या किया, ये एंडोट्रेकियल ट्यूब डाल दी, ठीक। अब इसमें देखना हमको ये पड़ेगा कि आपको ये समझ में आ रहा है कि उसकी टिप होगी ट्यूब की एक, वो कैराना से दूर होनी चाहिए। वो जितनी कैराना से दूर होगी ना उतना ही आपको नेगोशिएट करने में ईजी रहेगा, क्योंकि आप अगर कैराना और एंडोट्रेकियल ट्यूब की टिप है बहुत पास है, और क्यों आपका ब्लॉकर और फाइबर ऑप्टिक दोनों जा रहा है, तो क्या होगा ना कि वो आप नेगोशिएट नहीं कर पाओगे लेफ्ट राइट। तो अब थोड़ा सा, तो इसके लिए ना हम लोगों ने ऐसा किया है कि जब ये डाल लेते हैं ना उसके बाद भी एक बार फाइबर ऑप्टिक डाल के देख लेते हैं कि कैराना कितना दूर है, जिससे कि आपको पता लग जाए। आप ऐसा नहीं कर सकते आपने डाल दी ट्यूब, चलो ये कैराना के बहुत पास होगी तब भी चलेगा, ऐसा नहीं है, ठीक। तो इसमें एक ये पॉइंट है। ये फिर ना इसका एडेप्टर है, ये एडेप्टर में से ना यहाँ से देखो, यहाँ पर एक एडेप्टर है, यहाँ से जाएगा एंडोब्रोंकियल, यहाँ से जाएगा ब्लॉकर, ठीक है। यहाँ से जाएगा फाइबर ऑप्टिक, ये है एंडोट्रेकियल ट्यूब का पेशेंट वाला एंड, ठीक है। यहाँ ट्यूब होगी ये, और ये है वेंटिलेटर का एंड, ठीक। अभी हम लोग करेंगे तो हमको समझ में आ जाएगा, ठीक है। पहले हम लोगों ने इसको थोड़ा जली लगाया, ठीक है। अब देखो हम लोगों ने फाइबर ऑप्टिक पहले से डाल के रखा है इस एंड से, ठीक है, और दूसरे एंड से हम लोग अब ब्लॉकर डालने जा रहे हैं, ठीक। तो असेंबली ऐसे बन जाएगी। ये अडेप्टर है, जो हमारा अडेप्टर था, इसमें से एक तरह से फाइबर ऑप्टिक जा रहा है और एक तरफ से हमारे जा रहा है ब्लॉकर, और फिर हम लोगों ने ब्लॉकर का जो एक लूप था ना, वो हम लोगों ने ये फाइबर ऑप्टिक है हमारा, ये फाइबर ऑप्टिक के अंदर हमने इसको स्नाल कर दिया है, जिससे कि दोनों एक साथ अब असेंबली एक साथ मूव करेगी, ठीक है, तो इस तरह से होगा। देखो इस ये फाइबर ऑप्टिक है, इसमें मैंने ये लूप फंसा दिया और इस लूप को ना फंसा के आप पीछे से खींचोगे तो ये टाइट हो जाता है। ठीक, तो अब असेंबली आपकी ऐसी हो जाएगी, ये आपका वेंटिलेटर है, ये आपका ब्लॉकर है, ये आपका फाइबर ऑप्टिक यहाँ से जा रहा है और ये आपकी ट्यूब है इस तरह से पड़ी हुई और यहाँ पर आपने स्नाल करके रखा हुआ है। सो ये हम लोगों ने बना रहे हैं, करके रखा हुआ है। अब और ये देखो, अब तुमको तो ये हम लोगों ने अंदर घुसेड़ा ना, ये इस तरह से गया है ये, तो ये आपका फाइबर ऑप्टिक से आपको इमेज दिख रही है कि ये ब्लॉकर जो है, दिस इज़ द करेना, दिस इज़ द राइट एंड दिस इज़ लेफ्ट, हम लोगों ने यहाँ पर इसको प्लेस कर दिया है। ठीक है, इसमें ना आप क्या कर सकते हो, वहाँ जाके जब आप वो प्लेस में पहुँच जाओगे तो आप उसको लूजन कर सकते हो लूप को। तो जैसे आप लूप को लूजन करोगे तो धीरे धीरे करके आप फाइबर ऑप्टिक को धीरे से निकाल लोगे उसमें से और ब्लॉकर वहीं पर रह जाएगा। ठीक, अच्छा ये जो वीडियो है, सुनो वीडियो हम लोग प्ले करते हैं अभी। सो पहले हम ना क्या करेंगे ना, चेक कर लेंगे कि वो कैराना से कितना दूर है। ठीक है, पहले हम लोग, अभी हमने कुछ नहीं किया, अभी हम लोगों ने सिर्फ ये किया है कि अडेप्टर लगा के रखा हुआ है, एंडोट्रैकियल इंटूबेशन कर चुके हैं और फाइबर ऑप्टिक करके ये देख रहे हैं कि वो कैराना, लेफ्ट साइड, लेफ्ट ब्रोंकस, राइट ब्रोंकस, एक चेक जिस तरह जैसे आप यूएसजी करते हो ना, यूएसजी करने से पहले आप चेक करते हो, देखते हो कि कहाँ कहाँ है, क्या क्या स्ट्रक्चर्स हैं, तो अभी हम जस्ट चेक कर रहे हैं। अब हम लोगों ने ये ब्लॉकर हटाया वहाँ से, ब्लॉकर हटा के फिर हम लोगों ने इसको थोड़ा सा आगे कर देते हैं, ये चलता रहेगा इसमें। तो हम लोगों ने एक बार कफ चेक करके देख लिया इसका, ठीक है, कि कफ लीक तो नहीं कर रहा है। ठीक है, हमने कफ चेक कर लिया, कफ लीक नहीं कर रहा है। उसके बाद करने के बाद अब हम लोगों ने ये ब्लॉकर वाला एंड खोला। ठीक है, इसको आप लूजन कर सकते हो, इसमें से फिर ब्लॉकर जाएगा, इसको टाइट भी कर सकते हो, क्योंकि क्या होगा ना, इसमें से फिर नहीं तो एयर लीक करेगी। अब इसका एक लूप है, देखो वो पहले डालेंगे, उसके बाद वो ब्लॉकर उसमें से डाल देंगे। फाइबर ऑप्टिक पहले से डाला हुआ है इसके अंदर। ठीक है, अब हम लोग इसको निकाल लिया, पूरी असेंबली को निकाल लिया अभी। ठीक है, क्योंकि अभी हमको ना वो लूप को इसके अंदर फंसाना है, जिससे कि एक असेंबली एक साथ मूव कर पाए। तो ये हम लोग ने फिर उसको स्नाल कर लेंगे। ठीक है, अब ये असेंबली ना दोनों तरफ से एक साथ मूव करेगी। अब ये अब ऊपर जो टाइट कर रहे हैं ना, बहुत ज़्यादा टाइट नहीं करना, नहीं तो फिर आप उसको पुश इन नहीं कर पाओगे। सॉरी, ये वाला इसके बाद उसके बाद ये दूसरा वो मतलब उससे कंटिन्यूएशन है। थोड़ा सा आगे कर देता हूँ, इसमें ना बहुत सारा ये बेसिकली वो सीएबीजी के लिए ना, रोबोटिक सीएबीजी के लिए लिया है पेशेंट, तो थोड़ा सा ऐसे ही रहेगा, इसका बीच में मॉनिटर भी देखना पड़ रहा है। अब देखो एंडोट्रैकियल ट्यूब से वो हम लोगों ने पूरी असेंबली एक साथ मूव कर रही है, ऊपर से आप पुश कर रहे हो, मूव कर रही है, और फाइबर ऑप्टिक से हम लोग गाइड करेंगे कि हमको राइट साइड जाना है कि लेफ्ट साइड जाना है। अब देखो हम लोगों ने ना यहाँ पर यहाँ पर हम लोगों ने वो फाइबर ऑप्टिक के साथ गए, असेंबली के साथ गए, जाने के बाद हमने लूप लूज़ किया, लूप लूज़ करने के बाद हमने उसमें से फाइबर ऑप्टिक निकाल लिया, और ये जो कैथेटर है वहीं पर पड़ा हुआ है, ठीक है। अब इसको हमको इन्फ्लेट करना है। पहले ये देख लेना है कि ऐसा नहीं है कि ये बहुत ज़्यादा अंदर कर दिया हमने कि वो जो राइट और लेफ्ट सेगमेंट अब ब्लॉक कर रहे हो, तो थोड़ी देर बाद हम लोग इसको हम इसको इन्फ्लेट कर लेंगे, बस इसमें यही है, ज़्यादा है नहीं, ठीक है। तो जब व्हेन इट इज़ इन्फ्लेटेड देन इट लुक्स लाइक दिस, ठीक है। ये इन्फ्लेट हो गया है बैलून वहाँ से वहाँ जाके लेफ्ट ब्रोंकस को। सो दिस इज़ अ स्कीमेटिक डायग्राम कि हम लोग क्या करना चाह रहे थे, एंड दिस इज़ व्हाट, उसके बाद यहाँ रख लेंगे हम लोग। तो ये आंट का तो ये है, इस तरह से करते हैं। इसमें क्या होता है कि आप ऐसा भी कर सकते हो कि अगर आपको उस वो जो, क्योंकि ब्लॉकर है ना वो, तो ब्लॉकर के वो जो साइड जो वायर है, जो लूप के साथ वायर गई थी, वो उसको निकाल सकते हो। तो एक छोटा सा आपको एक चैनल मिल जाएगा जिससे आप, अगर आपको थोड़ा सा ऑक्सीनेट करना है या सीपैप देना है या सक्शन करना है तो वहाँ से कर सकते हो, बट वो फिजिबल ज़्यादातर होता नहीं है, क्योंकि वो जो उसका जो वो सिर्फ वायर के जितना ही उसका एक डायमीटर है, सर्कमफ्रेंस है, सॉरी, उतना। देन कम्स द यूनिवेंट, जो हम लोग बात कर रहे थे ना, ट्यूब के अंदर ही इनकॉर्पोरेटेड है, ये हो गया। और उसके बाद एक कोहिन टिप है, कोहिन टिप भी वैसा ही है, पर इसमें आपको स्नार नहीं है, मतलब कि आपको उसको फाइबर ऑप्टिक के साथ करना नहीं पड़ता है। इसमें क्या होता है ना कि यू हैव एक प्रॉक्सिमल कंट्रोल होता है, जिससे आप घुमा फिरा के ना आप उसको टिप को डिफ्लेक्ट कर सकते हो, राइट साइड लेफ्ट साइड, तो उससे आप कर सकते हो। आप पर फाइबर ऑप्टिक डालते हो और देखते हो कि आप कर पा रहे हो कि नहीं कर पाए। इसमें वो लूप नहीं रहेगा जिस तरह से आप लूप करते हो। ये इस तरह से ना, ये यहाँ से ये वाला जो है ना, ये डायल, इस डायल को जब मूव करते हो ना तो ये टिप पूरी घूमती है लेफ्ट राइट, तो इस तरह से है कोहिन का। और एक फूजी ब्लॉकर है, और अभी एक जो नया आया है वो इजी ब्लॉकर है, ये भी बहुत अच्छा है, ये हम लोग यूज़ नहीं किए हैं। पर इसमें क्या है ना कि आपको समझ भी आ रहा होगा, इस ब्लॉकर में ना आगे की तरफ उन्होंने ये कराया ना कि एड पर बैठ जाएगा और ये राइट और लेफ्ट चला जाएगा, तो आपको जो भी ब्लॉक करना आप कर सकते हो आप फिर, ठीक है ना। उसके बाद तो एडवांटेजेस डिजाइन तो बाद में कर लेंगे। तो ये सब ब्लॉकर के बारे में हो गया। अब हम लोग थोड़ा सा उसके एक बोरिंग टॉपिक जो है थोड़ा सा ये डिस्कस कर लेते हैं, DLT का। तो हमको पता है 2 सिंगल ल्यूमन बॉन्डेड टुगेदर, एंड इसके पार्ट्स होते हैं, या डिस्टल एंड होगा इसका ब्रोंकियल, इसका कफ होगा, ये ट्रैकियल एंड का डिस्टल एंड होगा, उसका कफ होगा, उसके साथ इसके प्रॉक्सिमल एंड होंगे, और यहाँ पर एक स्टिलेट होगा जो यहाँ तक जाता है, और उसके साथ इससे बैलून्स होते हैं दोनों, ठीक। और ये राइट और लेफ्ट हो गए, और राइट साइड में एक मर्फीज आई होगी, यही उसके साथ जो राइट अपर लोब ब्रोंकस है ना, उसके साथ ये चैनल इसके साथ मिलना चाहिए, तभी राइट अपर लोब ब्रोंकस वेंटिलेट होगा, नहीं तो वेंटिलेट नहीं हो पाएगा। इंडिकेशंस आपको समझ में आ गया होगा कि जहाँ भी हम लेफ्ट साइड से सर्जरी कर रहे हैं, बहुत नियर द लेफ्ट मेन ब्रोंकस या वहाँ पर ट्यूमर है, तो वहाँ पर हमको राइट साइड करना पड़ेगा, ठीक है। ट्यूब साइज ऐसे बोला गया है फॉर्मूला, पर ज़्यादातर जो है ना, आप ये इसको स्लाइड तो पढ़ी रहेंगे तो आप ये यूज़ कर सकते हो ये फॉर्मूला, पर ज़्यादातर हम लोग यही यूज़ करते हैं कि फीमेल्स लेस देन 160 तो आप 35 करो, मोर देन 160 37, मेल्स के लिए लेस देन 170 39, एंड मेल्स के लिए मोर देन 170 है तो आप 41 यूज़ करोगे। और डेप्थ ऑफ इंसर्शन जो है पेशेंट हाइट इन सेंटीमीटर्स डिवाइड बाई 10, और उसमें 12 प्लस कर दोगे, पर ये काफ़ी वेरिएबल रहता है। आप ज़्यादातर क्या करते हो, लेफ्ट डबल ल्यूमन ट्यूब जाते हैं और उसके फिर आप बढ़ाते रहते हो जब तक रेजिस्टेंस नहीं आता, वहाँ रुक जाते हो और फिर फाइबर ऑप्टिक से असेस कर लेते हो। एंड दिस आर द प्रिपरेशन फॉर द ट्रॉली। एंड डबल ल्यूमन ट्यूब का आपको जानते हो कि एक कनेक्टर भी होता है उसके साथ, आप कनेक्ट करोगे, पहले आप ट्रैकियल ल्यूमन एक बार वो कर लोगे, उसके बाद आप ब्रोंकियल ल्यूमन देख लो, ब्रोंकियल कफ देख लोगे। उसके साथ बस इसमें यही याद रखना था कि दिस कॉन्केविटी विल पॉइंट टुवर्ड्स द रूफ, ठीक है। जैसे ही ये टिप पार कर जाएगा वैसे ही आप 90 डिग्री एंटी क्लॉकवाइज टर्न कर दोगे, सो दैट इट गोज टू द लेफ्ट साइड। सो दिस इज़ अ स्कीमेटिक डायग्राम। आप गए, ये वोकल कॉर्ड है, यहाँ से जब पार करने के बाद आपने इसको टर्न कर दिया और ये लेफ्ट साइड चली गई। सो ये पेशेंट था, हम लोगों ने इसमें किया था। और उसके बाद पहले तो आप बायलैटरल एयर एंट्री चेक कर लोगे, देख लोगे कि बायलैटरल एयर एंट्री है कि नहीं, और दोनों कफ इन्फ्लेट कर दिया आपने, बायलैटरल एयर एंट्री इक्वल है कि नहीं। उसके बाद यू विल ब्लॉक वन साइड एंड सी वेदर द वेंटिलेशन इज ओनली अकरिंग ऑन द अपोजिट साइड। ये करने के बाद देन ये तो कर लेते हैं। उसके बाद पर फाइबर ऑप्टिक आपको करना ही पड़ेगा यूज़। फाइबर ऑप्टिक यूज़ करके व्हाट यू सी इज़ दैट यू कैन फॉलो द ब्रोंकियल कफ। ब्रोंकियल कफ आपको दिखना चाहिए, ये कराना है। ये देखो ब्रोंकियल कफ इसमें दिखता है, यहाँ पर ये ब्लू कलर का दिखेगा आपको, पता तो आपको पता लग जाएगा कि ये मेरा लेफ्ट साइडेड ही है अब ये। एंड हर्निएशन नहीं होना चाहिए उसके साथ। और अगर राइट साइड कर रहे हो तो फिर आपको, अगर आप वहाँ पर जा पाए और देख पाए तो फिर मतलब कि राइट अपर लोब अगर उस तरफ पॉइंट कर पाए, राइट अपर लोब की तरफ, तो आपको एपिकल एंटीरियर और पोस्टीरियर ओपनिंग्स मिलेंगी वहाँ पर। सो प्रॉब्लम्स तो इसकी है, क्योंकि अभी हम लोग एक बार एक केस था, जो ये वाला केस दिखा रहे थे, उसमें हम लोग CABG का पेशेंट था, लेफ्ट मेन भी डिजीज़ था उसका, और हम लोग ह्यूमन भी स्ट्रगल कर रहे थे, प्लस डिफ़िकल्ट इंटूबेशन अनएक्सपेक्टेड निकल आया। तो इट वाज वो चैलेंज हो गया था, वो फिर हुआ भी नहीं ठीक तरह से। पर चलो मतलब इट टुक टाइम, इट टुक लाइक 40 मिनट्स हमको लग गया करने में, वो बार बार करते हैं। एयरवे ट्रॉमा हो सकता है, मेल पोजीशन हो सकती है, नॉट ऑप्टिमल फॉर पोस्ट ऑपरेटिव वेंटिलेशन के लिए ऑप्टिमल है ही नहीं, आपको सबसे पहले ट्यूब चेंज करनी पड़ेगी। दूसरी बात ये हुई कि फिर आप जब आपने ऑपरेशन कर लिया तो ये हुआ कि डबल लेवल ट्यूब बड़ी मुश्किल से डली थी हम लोगों से, तो नाउ उसमें से बूजी पास नहीं कर सकते आप, क्योंकि वो डिफिकल्ट इंट्यूबेशन है। तो हमको लग रहा था कि अब इसको निकालेंगे तो फिर एक सिंगल एक एंडोट्रेकियल ट्यूब तो आपको डालनी पड़ेगी ना पोस्ट ऑफ वेंटिलेशन के लिए, तो उसके लिए फिर एक स्ट्रगल करना पड़ा। तो वी लॉस्ट टाइम बिफोर इंडक्शन ऑल्सो, एंड वी लॉस्ट टाइम ड्यूरिंग, फिर एक्सटूबेट करके फिर हमको लैरिंगोस्कोपी करके फिर डालना पड़ा उसको। सो ये प्रॉब्लम्स हैं उसकी। ब्रोंकियल ब्लॉकर्स तो हमने पढ़ लिया है, और लास्ट में हम लोग सॉरी लास्ट में हम लोग ये पढ़ लेते हैं थोड़ा सा, सॉरी लास्ट स्लाइड ये वाली है कि डबल लिमिट ट्यूब के एडवांटेजेस क्या है और ब्रोंकियल ब्लॉकर्स के एडवांटेजेस क्या है और इसके डिसएडवांटेजेस क्या है। तो मोस्टली यही है कि एडवांटेजेस ये है कि लार्ज ल्यूमन है, फैसिलिटेट सक्शनिंग हो सकती है, एब्सोल्यूट सेपरेशन मिलेगा आपको, ठीक है। कन्वर्शन फ्रॉम 2 लंग टू 1 लंग वेंटिलेशन इज ईजी एंड रिलायबल। बट इसके एडवांटेजेस ये क्या है कि अगर ये आप एंडोट्रेकियल ट्यूब के थ्रू कर सकते हो, कफ डैमेज होने के चांसेस नहीं है। आपने देखा होगा कि वो डबल लिमिट आप डालते हो तो जब ब्रोंकियल टिप वोकल कॉर्ड से पास कर रहा होता है तो आप देखते हो कि मेरा जो ट्रैकियल कफ है ना वो मेरे दांत में लड़ रहा है, तो आपको ना वो नेगोशिएट करना पड़ता है। तो ये प्रॉब्लम ब्रोंकियल ब्लॉकर में नहीं आएगी आपको, ठीक है। एंड डिसएडवांटेजेस क्या है, डिफिकल्ट इन सेलेक्टिंग द प्रॉपर साइज ये है, और डैमेज टू द ट्रैकियल फर ये हो गया। इसके डिसएडवांटेज ये हैं कि सक्शनिंग के लिए मुश्किल है, और एक बार हो गया तो हो गया, उसके बाद कन्वर्शन फ्रॉम 1 to 2 लंग एंड देन फ्रॉम 1 लंग वेंटिलेशन इज प्रॉब्लमेटिक। कभी कभी प्रॉब्लम पड़ जाता है इसमें, क्योंकि इसका डिसलॉजमेंट ना बहुत जल्दी हो जाता है, तो वो हमको इंश्योर करना पड़ता है। तो दिस इज ऑल, थैंक्स अ लॉट, थैंक्स अ लॉट, यही है।
Thank you, sir. What a lucid presentation. I believe we all are more learned now. Though DLT is the norm, but as you have portrayed, bronchial blockers are, I believe, easier to insert, though we do not practice that much. So it was made more clear to us. Thank you, sir. I will invite any queries or questions from the audience. So, sir, they all are more learned. That was quite good for us. Thank you.
Thank you. Thanks a lot.
So, in the end, we have a case presentation, very interesting case of hemoptysis, which also is also a chronic smoker. Hemoptysis means kind of some emergency. Let us see how Dr. Das makes it less emergency, and how he manages the smoking for the benefit of the patient, and how he does the case in the end with a better or more optimal post-operative outcome. Over to Dr. Das.
Thank you, sir, for such a nice introduction.
Sorry, Dr. Das, sorry. We meet almost every now and then. Dr. Das is professor and has been head. Now the headship has gone to the senior member, Dr. Malvia. So Dr. Das has been very, very helpful whenever we needed his help during COVID time. He was in charge of the COVID hospital, COVID wing of his hospital. And I'm very thankful whenever I talk to him about shifting some patient or other. He was very, very kind to talk to. You know, he's very learned, he's very good, he's an asset for the specialty of anesthesiology. And you yourself will judge how good he is in the job that he's going to do. Over to you, Dr. Das.
Thank you, sir, for such a nice introduction. But that introduction brings expectation very high. And then it becomes very difficult to be on that. Anyway, sir, I thank organizing committee for inviting me, and I congratulate them also for organizing it successfully. What topic Dr. Manish has given me is a 66-year-old man with history of smoking and have hemoptysis, and this patient is posted for right upper lobe lobectomy. And he also said that what they want that to discuss about the what are the risk assessment, how to do risk assessment in a patient going for lung surgery like lobectomy or pneumonectomy, and a brief description about the one lung ventilation, and many a times one lung ventilation we suffer from hypoxia, so how to deal with that. And my presentation will be mainly focused on those things only. I won't be discussing about the COPD because COPD has been nicely discussed by Anshul Jain, and methods of how to do OL, one lung ventilation, has been discussed by Sanjay Dhiraj sir. So if we see what are the different surgery done in COPD patients, are lung volume reduction surgery, that can be bulectomy or that can be lobectomy. Bulla is actually a large air sac formed from hundreds of destroyed alveoli, and these air spaces become so large that they crowd out adjoining lung parenchyma and decrease the lung functions. So once we take out those bullas, lung functions improves. So we can see that LVRS is not a cure for COPD, but can improve exercise capacity and quality of life. It also allows remaining healthier portion to perform better and allows diaphragm, which we all know that in COPD is flattened. So now diaphragm returns to the normal shape and efficient inspiratory force can be achieved. Now, risk assessment in lobectomy surgery is very important and very dangerous in the sense that, you know, we are taking out portion of lung parenchyma in a patient with pre-existing lung disease, COPD, in expectation that improved lung function will occur after the surgery. So we must do a very good risk assessment, otherwise if post-surgery patients deteriorates, all onus will come to the surgery. So this is very important. The things which we have to do during pre-operative assessment is risk assessment and risk reduction. So risk assessment is done to identify patients who are at increased risk of respiratory morbidity and mortality, and risk reduction is to institute corrective measures and preventive measures to minimize the risk of respiratory morbidity and mortality. So who should be evaluated? If we see, the general answer is that all patients undergoing lung resection surgery, irrespective of age or extent, they should be evaluated. Now, there are different guidelines, international guidelines. One is from American College of Chest Physician, another from British Thoracic Society, and another from European Respiration Society. And they have given different guidelines. We will be seeing it. So the role of pulmonary function test, the aim is to determine the risk for respiratory complications and mortality based on the patient's pre-operative lung function, and what will be the estimated section lung function after the surgery. And for this, the two most important markers what we are doing, the lung function test, and they are FEV1 and DLCO. Now, there are terminologies like PPO, FEV1%. Now, this is percent predicted post-operative FEV1. Same way, PPO DLCO is percent predicted postoperative diffusing capacity for carbon monoxide, and PPO VO2 max is percentage predicted postoperative maximal or peak oxygen consumption. The PPO designation is added to indicate that the estimated parameter refers to the late postoperative period, that like 3 to 6 months after the surgical procedure, what will be the predicted value of these parameters. So if we see FEV1 and PPO FEV1, they are associated with increased respiratory morbidity and mortality rates. FEV1 is an independent predictor of respiratory morbidity, like if FEV1 is less than 30%, morbidity you can see that it is 43%, whereas if it is more than 60%, then morbidity rate is more than only about 12%. So there are different studies which are suggesting that FEV1 is a very good marker for assessment of the lung function post-surgery. Similarly, one study in ACCP has said that if FEV1 is more than 80% predicted or absolute value is more than 2 liter, then they are suitable for resection including pneumonectomy. Whereas if it is more than 1.5 liter absolute value is it, then it is suitable for lobectomy surgeries. Now absolute values versus percent predicted. So we all can see that different studies have said that in comparison to absolute values, the percent predicted is more important marker. Now coming to DLCO and PPO DLCO, reduced PPO DLCO is strongly associated with the risk of post-resection pulmonary complications, and percentage PPO DLCO is has higher correlation with postoperative death than percent PPO FEV1. So if we compare FEV1 with DLCO or predicted postoperative DLCO in percentage and predicted postoperative FEVO in percentage, probably PPO DLCO has been found in a lot of studies a better marker. So the recommendation are that all patients who are going for lung surgeries or lung resections, we should always do both FEV1 as well as DLCO, and after doing measurement of FEV1 and DLCO, we should calculate both predicted postoperative FEV1 and predicted postoperative DLCO. So if we see that American Chest Physicians Society have said that if PPO FEV1 and PPO DLCO is more than 60%, and another society, European Society, has said that if FEV1 and DLCO is 80%, then we don't need to do further test for lobectomy surgeries. But if it is less, then we will have to do further other test also. So how to calculate? Now we are talking about predicted postoperative FEV1 or predicted postoperative DLCO. So how to calculate it? We all know that we can calculate FEV1 and DLCO through pulmonary function test, but thereafter we need to use this formula. Predicted postoperative FEV1 is equal to preoperative FEV1 into 1 minus Y upon Z, where Y is the number of functional segments which we are going to remove, and Z is the number of total functional segments. Similarly, PPO DLCO is equal to preoperative DLCO value into 1 minus Y upon Z, and Y and Z is same in both the cases. Now another thing is, this I have discussed already. So we know that in right lung there are 10 segments, whereas in left lung there are 9 segments. So suppose we are doing upper lobectomy. So in upper lobe we have 3 segments. So the Y value in the previous measurement will be 3 and the Z value will be 19. So suppose we do the pulmonary function test, and this comes like this, that FEV1 is reference is 1.88, measured 1.26, post bronchodilator it is 1.27. So it is 67% of the reference predicted, and DLCO is predicted is 4.1 and the measured value is 3.0. So percentage it is 72%. So now we will see how to calculate PPO FEV1 or PPO DLCO and percentage PPO FEV1 and percentage PPO DLCO. So we can see that preoperative FEV1 is 1.27 Your marker is not working. Can you change the cell? नहीं है sir. So we can see in this that preoperative FEV1 is 1.27 into 1 minus 3 upon 19. So this comes around 1.07 liter absolute values. And if we calculate PPO FEV1 percentage, so that is predicted postoperative FEV1 divided by predicted FEV1 into 100. So predicted FEV1 in the previous slide we can see that it was 1.88, right? And the predicted postoperative value as we measured right now, it is 1.07. So PPO FEV1 comes to be around 57%. Now coming to measurement of DLCO. So we have measured in the same way, and DLCO absolute values came about 2.53, and when we measured predicted postoperative DLCO in percentage, it came out to be 62%. So one is 57% PPO FEV1 and PPO DLCO is 62%. So we can see that based on calculated PPO FEV1 and PPO DLCO percentage by anatomic method, our assessment is that probably this patient needs further assessment. Like we can order a perfusion scan in this patient. So now what is perfusion scan? We can do it by anatomic method. This is recommended only to estimate the lung function after lobectomy. So to estimate the PPO FEV1 and DLCO after pneumonectomy, a quantitative radionuclide perfusion scan is performed to measure the fraction of total perfusion for the resected lung. So either ventilation or perfusion scan can be used to predict PPO lung function, but more commonly perfusion scan is used. So we can see that perfusion method, we can calculate the predicted FEV1 or DLCO for pneumonectomy. So we will later on see the formula remains the same. PPO FEV1 is equal to preoperative FEV1 into 1 minus fraction of total perfusion for the resected lung. So if fraction of total perfusion for resected lung is 30%, so it will be 1 minus 30. So that way we can calculate PPO FEV1, and that comes probably more near to the functional values. So we will see in the next slide, this slide, that upper zone perfusion is 9.1%, middle zone is 25.3%, and lower zone is 12.6%. So in total, right lung has 47 and left lung is 53%. So if we calculate with perfusion method the PPO FEV1, preoperative FEV1 as we remember was 1.27, and the upper lobe's perfusion is 9.1%. So 1 minus 9.1 in percent. So if we will calculate 1 minus 0.91, it will come around 1.15 liter. Similarly, we can calculate it in percentage also, and it comes out to be 61.2%. So all these, similarly we have done PPO DLCO calculation in absolute value, it came around 2.73, and when we did it in percentage, it came out to be 66.6%. So we can see that probably this percent, ultimately we can see that through anatomic method when we calculated, PPO FEV1 was 57%, whereas PPO DLCO was 62%. But when we did with lobectomy perfusion method, it came out to be 61.2% and 66.6% FEV1 and DLCO respectively. So probably this patient has low risk for right upper lobectomy, but probably we will need further test if we are planning for pneumonectomy. Here I would like to emphasize one thing, that often what happens that we are calculating for lobectomy, but COPD it's okay, but sometimes lung surgery are being done for malignancy, and in that case what happens that once surgeon opens up, he may decide to further extend the his surgical resection. He may, if he sees that malignancy is extending into the mediastinum or extending beyond the fissure, then he may plan for pneumonectomy. So at that time you won't start calculating whether that patient is eligible for pneumonectomy or not. So all patients whom you are doing risk assessment for lobectomy, it is better to do assessment for pneumonectomy also and define it whether this patient can go for pneumonectomy or not at the time of PAC only. So the objective is to ascertain that after surgical resection of the lung, there will be sufficient pulmonary reserve to keep the patient comfortable and will not become a respiratory cripple. So one should always evaluate the patient to determine whether he can withstand a pneumonectomy, even if it is believed preoperatively that all that is needed is a lobectomy or a wedge resection. Now the other question is, what additional test, as we discussed, will we order for further assessment of risk for pneumonectomy in these patients if we are planning for this? Now these are the common tests which we do: a stair climb test, shuttle walk test, or cardiopulmonary examination test. So the exercise test, the aim of exercise tests are to assess the whole cardiopulmonary systemic oxygen delivery system and estimate the physiological reserve that may be available after the surgery. As we all know, the function of lung is to deliver oxygen to the different organs, and this function is not done alone by the lungs. The lung and heart both act together to meet the demand of oxygen delivery to the tissue level. So if there is any issue with cardiac side also, that can also hamper. So whenever we are assessing for these things, it is better to do the combined assessment of, that is, cardiopulmonary assessment. In lot of meta-analysis, it has been seen that doing combined cardio respiratory assessment is always a better thing. So common cardiopulmonary exercise testing is a sophisticated physiological testing technique that provides an objective evaluation of functional capacity of both the lungs as well as heart, and is known as a safe test procedure. Inability to perform a pre-op exercise test is an indication of limited aerobic capacity, and there are recommendations by previous and current guidelines as the next step in the preoperative risk assessment. Now, standardized CPET using VO2 max has been shown to predict post-operative complications, including perioperative and long-term morbidity. So we need to do this. Now, pointer. So we can see that ACCP has said that CP is indicated in when there is positive high-risk cardiac evaluation, or either FEV1 or DLCO is less than 30%, or single stair climb test is less than 22 meter, or single walk test, 6-minute walk test is less than 400 meter. The European Society has said that CPET is recommended when FEV1 or DLCO is less than 80%. So there are, if we are doing CPET and we find that VO2 max is more than 20 ml per kg per minute, then we can undergo the planned resection up to the pneumonectomy. But if it is between 10 to 20, that indicates an increased risk of perioperative death compared with higher values of VO2 max. And suppose if it comes below 10 ml per kg per minute, that means the patient has a very high risk of post-operative death and generally regarded as a contraindication to major anatomic resections. Now these are different tests: stair climbing test, shuttle walk test, and 6-minute walk test. I am not going into detail of these things, but what we can see that we have to do PPO FEV1 and PPO DLCO, which we commonly do. Is easy. If it is more than 60%, you don't need to do anything. You can go for the surgery. But if it comes between 30 to 60, then we have to do cardiopulmonary exercise test like a stair climb or shuttle walk. If that comes, staircase test comes below 22 meter, or 6-minute walk test is less than 400 meter, in that case you can go for cardiopulmonary exercise test. Or if during PAC you find that there is high risk cardiac evaluation, then you can straightway go to the cardiopulmonary evaluation test. So we can see we have already discussed the different values and the risk associated. So for pneumonectomy, PPO VO2 max is equal to preoperative VO2 max into 1 minus fraction of total perfusion for the lung to be resected. So this is the final guideline which says how to go for risk assessment. So if PPO FEV1 and PPO DLCO is, can I come to there? Collar mic here. So if it is more than 60%, you can categorize the patient as low risk and you can straightway go for the surgery. But if it is not more than 60% and it is between 30 to 60%, then you have to go for different tests as we discussed about stair climb test or 6-minute walk test. And if they are also less than 22 or less than 400 meter, in that case you will go for estimation of VO2 max and you can categorize the patient whether he has high risk, moderate risk or low risk. Now coming to, we have discussed how to categorize this. Now coming to one lung ventilation. So if you are planning for lung resection or lobectomy, as we discussed the different causes why we need to have one lung ventilation, surgical is easy is surgeon has easy if you have collapsed one lung, or it can be done, it is done when there is minimal invasive cardiac surgery, and even in lobectomy we have to do one lung ventilation. Now it becomes very difficult for the anesthesiologist, it is a challenge to do one lung ventilation. So what happens that during one lung ventilation, as Dr. Sanjay Dhiraj said, that somehow we are ventilating only one lung. So now the issue is that lung, only one lung is getting the ventilation, but perfusion is going to both the lungs. Now if perfusion will go to both the lungs, the lung which is not getting the air, not getting the ventilation, the blood will come back with all the CO2 it has come in. So there will be a left to right shunt in that lung, and your CO2 level will keep on increasing, right? So what happens actually during one lung ventilation? Is it so? Normally, how much is the pulmonary circulation? How much blood flows through the lungs? You can say? Anyone? What is the pulmonary blood flow in a minute? See, whatever is in the systemic circulation, exactly the similar amount is there in the pulmonary circulation also, as far as flow rate is concerned. Volume is less, but if we talk about the flow rate, it is similar in the pulmonary as well as systemic. So if your cardiac output is 5 liter, the 5 liter is also passing through the lungs every minute. So that 5 liter during one lung ventilation, half of that will go to one lung, half of that will go to the other lung, although it is not exactly half, it is 55 to 45%. But so one lung, suppose I have ventilating only left lung, as we have planned for right upper lobectomy. So what will happen? The left lung, which is receiving 45%, now that will not be oxygenated and CO2 will also not be removed. So that will lead to hypoxia as well as hypercarbia. But exactly it doesn't happen so, because there is some mechanism which helps. Like one thing is, whenever we are going for lobectomy, what is the position of the patient? Say it loudly. Lateral decubitus position. So what happens? There is some preponderance of circulation to the dependent lung, and dependent lung is the lung which is getting ventilated also. So that helps. So we will see this in these slides. So OLV provides protection of healthy lung, diversion of ventilation, and improve the exposure. So these are the regions. Now if we come to the pathophysiology in awake patient, we will see that ventilation, during spontaneous ventilation, the dependent lung is better ventilated than the non-dependent one. And on induction of GA and neuromuscular paralysis, both lungs move down on the pressure volume curve or compliance curve. And as far as perfusion is concerned, dependent lung gets better perfused, and blood flow to the non-dependent lung will be decreased by 10%. So if you see on this curve, you can see that the dependent lung will be getting more perfusion, but if we talk about the ventilation, you will see the pressure volume curve or compliance curve. The non-dependent lung is a bit higher on the compliance curve in comparison to dependent lung. So dependent lung has a tendency to get better ventilated. So this will happen when both the lungs is getting ventilated. But if you are ventilating only one lung for lobectomy, in that case all the ventilation will be coming to the dependent lung. So main physiological change in OLV is the redistribution of lung perfusion between the ventilated and blocked lung. So one is the major determinants of blood flow is, one is gravity. So the lung which is dependent is getting better perfused because of gravity. Another thing is amount of lung disease, as well as one more important thing is magnitude of hypoxic pulmonary vasoconstriction, right? So probably this is also one of the very important mechanism which is helping in achieving oxygenation and decarboxylation during one lung ventilation. So what happens that whatever blood is coming to the upper lung, non-dependent lung, which we are not ventilating, what happens that there is hypoxia. So in that capillaries there is hypoxia, and these hypoxia induces vasoconstriction. So what will happen? Vasoconstriction will pull the blood into the other lung. So although you are not clamping the pulmonary artery of that lung, but still because of two important factors, one is gravity, blood is getting pulled to the dependent lung, and another is the hypoxic pulmonary vasoconstriction. Most of the capillaries, arterioles are getting constricted, and so the blood is pulled to the dependent lung. So now if you will see that almost this difference in blood flow is about 20 to 22.5% perfusion, the blood amount goes to the non-dependent lung, and 77.5% of blood is coming to the dependent lung. And this is the reason how we achieve oxygenation when we are doing one lung ventilation. So in one lung ventilation, there is greater decrease in oxygenation than during two lung ventilation in lateral decubitus position due to obligatory right to left transpulmonary shunt. So what if both the lung is being ventilated, and that in that condition certainly you will have better oxygenation, but if we have obligatory only one lung getting ventilated, so there is the other lung which is not being ventilated, there will be a shunt, there will be right to left shunt. So there will be certainly a lower PA2 in comparison to total lung, both the lung being ventilated. So you can see that usually carbon dioxide elimination is not a problem in these OLV, because retention of CO2 by blood traversing the non-ventilated lung slightly exceeds the increased elimination of CO2 from blood which is traversing the ventilated lung, and PaCO2 will usually increase slowly, and difference between alveolar and arterial CO2 will decrease. We have already discussed about the hypoxic pulmonary vasoconstriction, which is a very important mechanism by which oxygenation is maintained during one lung ventilation. There is a picture which shows the different mechanism which is helping in. So you can see that the general view is that inhalation. Now another issue comes up, that inhalational agents which we are using during the anesthesia, we all know that that decreases the or abolishes the effect of hypoxic pulmonary vasoconstriction, but it has been found that it is probably dose dependent, and more commonly with halothane in comparison to isoflurane, which we commonly use. HPV is inhibited directly by volatile anesthetic agents, also by vasodilators and dobutamine. HPV is indirectly inhibited by PEEP. Here we have to remember that if we have applied PEEP, that also indirectly inhibits this. So what are the different predictions of desaturation during one lung ventilation? High percentage of ventilation or perfusion to the operative lung on preoperative ventilation perfusion scans, if we have seen. If there is poor PaO2 during both the lung ventilation, particularly in the lateral decubitus position intraoperatively. The right-sided thoracotomy, it is more commonly happening. Now coming to anesthesia for one lung ventilation. Generally we prefer general anesthesia for one lung ventilation, because we can control the ventilation of the patient as the need may be. although thoracic epidural or paravertebral blocks can be given for postoperative analgesia. Inhibition of HPV by volatile anesthetics is there, but it is dose dependent. So if we keep a MAC in the lower range, then this effect can be nullified. And 2, nitrous oxide should be avoided. And as far as ventilatory strategy is concerned, since we are ventilating only one lung, so we should use lower tidal volume in the range of 4 to 5 up to 6 ml of per kg ideal body weight of the patient. We should apply PEEP in the range of 5 to 10 centimeter of water. You can use both the mode, volume control or pressure control, but you have to be vigilant. If you are using volume control mode, you will have to keep an eye on the peak pressure the patient is having. Respiratory rate can be kept around 12 to 15 minutes per minute, but again, we may need to go beyond 15 up to 20. That you will be guided by the serial ABG of these patients and also EtCO2 of the patient. Now, intraoperative monitoring, you will have to do normal monitoring along with a frequent ABG monitoring in these patients, because invariably your CO2 might, the EtCO2 might be low, but when you will do ABG, you will see that probably PaCO2 is higher. Now, different complications which occur during one lung ventilation, most important is hypoxemia. There can be sudden severe hypotension, sudden change in ventilating pressures or volume. There can be arrhythmia, bronchospasm, massive hemorrhage, hypothermia. Now coming to hypoxemia, usually there is FRC reduction, which is important cause of hypoxemia, and FRC reduction is because of whenever you are giving anesthesia or patient is COPD, so there will be reduction in FRC. So how to optimize these things? We need to be vigilant of parameters. You have to look at whenever there is any fall in saturation, you will have to immediately act upon. You have to optimize the ventilatory setting of dependent lungs so that inspiratory pressure you can go up to 30 centimeter, and you should not try to go beyond 30 centimeter. If even that oxygenation is not maintained, then you can think about optimizing the PEEP. So PEEP to the ventilated lung will recruit the collapsed underventilated alveoli and improvement in atelectasis. So this will also help you. Application of CPAP to the non-ventilated lung. Now another lung which is not being ventilated, if you apply CPAP, sometimes you may need this, because in spite of all your maneuvers, increasing the FiO2 to 100, increasing the PEEP, and still you are not achieving the oxygenation. In that case, you can apply CPAP to non-ventilated lung. And sometimes you may resort back to both lung ventilation, because it happens that sometimes you are doing one lung ventilation and hypoxemia is not improving, your saturation is not improving. In those scenarios, you may need to ask the surgeons to wait for some time, and you can ventilate both the lungs with FiO2 100% for some time, and then again you can resort back to the one lung ventilation. And we have to remember that oxygen delivery is not only lung function but also cardiac function. So your cardiac output should also be maintained adequately. If there is severe desaturation, we can increase the FiO2 to 100%. We should check the position of fiber optics. Sometimes you may go, your tube may go to the one of the branches of the left bronchus or right bronchus, whichever you are ventilating. That can also be the cause. We should ensure optimum cardiac output, and we should decrease the inhalational agent MAC value. We can also apply recruitment maneuver when hypoxia occurs to ventilated lung, as well as apply PEEP. Sometimes apneic oxygen insufflation to the lung which is not being ventilated can also help you. Partial ventilation technique to non-ventilated lung, intermittent ventilation of that lung. Now these are the things which can help you. Sometimes we may ask the surgeon to mechanically restrict the blood flow to the non-ventilated lung, and that will also, since the blood is now completely bypassing the non-ventilated lung to the ventilated lung, that will also improve your saturation. So if all these doesn't help you in achieving oxygenation, you can also resort to that thing. And ultimately, if none of these helps you, then you may have to think about putting the patient onto the ECMO, and that is veno-venous ECMO. So to summarize, the pre-operative evaluation and assessment is very important for lung volume reduction surgery or for lobectomy or for pneumonectomy. We have to remember that along with FEV1 and DLCO, we also need to calculate predicted post-operative values of these FEV1 and DLCO for further evaluation. And we need to have basic understanding of the physiology of one lung ventilation for these kind of surgeries. Hypoxemia and hypercarbia can occur during one lung ventilation, and we need to be vigilant continuously for these two issues. And we need to identify these issues early and do corrective measures to avoid any catastrophe which can occur intraoperatively. Thank you.
Thank you, Professor Das, for presenting very lucidly within the given time, rather saving time, 5 minutes to us, being very conscious that we are running late. Still, because you save time, we will go to the audience. And before I go to audience, Dr. Das, how to maintain CPAP in the non-ventilated lung? Of course, we insufflate oxygen, 2 liter, 2.5 liter something. But what else is to be done to maintain a CPAP of, as you said, 1 to 2 centimeter?
For that, yes, sir. For that, we will have to differential lung ventilation. We will need one more ventilator for that, because
correct,
we have connected the one port to our anesthesia workstation. Suppose we are ventilating the left lung. Now we will have to attach the bronchial lumen with other ventilator and put the patient on CPAP mode.
Yeah, that makes it a little crowded, the space that we have. But that may be required.
That will make space crowded, but when oxygenation is not improving, it happens very commonly during one lung ventilation that your saturation is not going beyond 90, 91, and then you will have to think about other measures.
So, anybody, any question please from the audience? There should be many doubts, even though he has presented so well, but he has touched so many things. The risk assessment itself was quite lucid, quite interesting. Pre-operative optimization and risk assessment. Any comment from Dr. Dhiraj? No? Thank you so much. Thank you so much, Dr. Das. So just to summarize, you see the pre-operative optimization and risk assessment is very crucial for a satisfactory outcome, especially taking into consideration the chronic patients that they are. And indeed, Dr. Das has very lucidly presented everything as to how manage hypoxemia. So you please remember always as to how you manage hypoxemia. There will always be hypoxemia. There will always be hypoxemia unless you manage it well. And don't be panicky if you find saturation falling, something you have not done, you have forgotten, you do that. He has shown very clearly the oxygen insufflation, CPAP if required, other than ventilative strategy, that should be very well. More importantly, patients should have been optimized preoperatively to the extent that you knew that, and the risk assessment should have been done so that you know that this patient is to be subjected or not, or delayed until he becomes more optimal. So thank you everyone. Thank you so much. That ends the session. Yes, sir. Yeah,
thank you, sir, for such a detailed lecture. I would like to request Professor L.D. Mishra, sir, to kindly felicitate Dr. P.K. Das, sir. Next, I request I request Professor L.D. Mishra, sir, to kindly felicitate Dr. Vinod Srivastav, sir. I would like to request Professor Vishal Arora, sir, to kindly felicitate Dr. Sanjay Dhiraj, sir, for such a wonderful lecture. Thank you, sir. Thank you, sir. I would now like to request our respected head of the department, Professor G.P. Singh, sir, to kindly honor our respected chairperson, Professor L.D. Mishra, sir, for gracing us with his presence. I request Professor G.P. Singh, sir, to kindly offer a token of gratitude to our respected chairperson, Professor Vishal Arora, sir. Thank you, sir. Thank you, sir. Now coming to the end of this session, we'll have a quiz for which I would like to call upon Dr. Shashank.
So now quiz will be of 20 questions and we have 30 seconds for each question and you have to mark your name on that sheet. And there are 5 types of these quizzes to be arranged in 3 days. Okay. Lunch is ready. If faculty want to join on the lunch, they can proceed. So Shashank, now you can start quiz.
A very good afternoon to everyone. After such informative lectures, now it's time for some quiz. Let's begin with question number 1. You will be having 30 seconds for each question. Coming to question number 1. Next. What is most helpful to determine the need for intubation in emergency room? A. ABG, B. Clinical assessment, C. Lung auscultation, and D. Pulse oximetry alone. Next question. A decision to intubate a patient in ED should be based on which essential criteria? A. Failure to maintain or protect the airway. B. Failure of ventilation or oxygenation. C. Patient's anticipated clinical course and likelihood of deterioration. And D. All of the above. Question 3. What is the gold standard for confirmation of endotracheal tube placement? A. Aspiration technique. B. Chest and gastric auscultation. C. Chest X-ray. D. Fiber optic scope can be passed through the endotracheal tube to identify tracheal rings. Question number 4. You can predict relatively easy intubation in a patient who A. has a receding mandible, B. who has a short neck, C. who has no teeth, and D. who has prominent upper incisors.
Question number 5. You can safely manage the airway in a patient with suspected cervical spine injury by using A. Chin lift, B. Direct tongue depression, C. Head tilt, and D. Jaw thrust. Next question. Correct arrangement of flow meter in anesthesia workstation. These are the arrangements shown. Please mark the correct option. Next question. Which of the following is not a part of intermediate pressure system in anesthesia workstation? A. Auxiliary gas outlet, B. Oxygen failure device, C. Oxygen flush, and D. Vaporizer. Question number 8. Oxygen failure safety device in anesthesia workstation. A. Detects fall in oxygen pressure. B. Protects against hypoxic gas delivery. C. Both, and D. None. Which of the following is not a safety feature for preventing attachment of wrong cylinder to the yokes? A. Color coding of cylinder, B. Pin index system, C. DISS, and D. Symbol of the gas on yokes assembly. C is diameter index. Question number 10. McKenzie technique is used for A. Topicalization for airway anesthesia, B. Transtracheal block, C. Identification of vocal cords palsy, and D. None. Question 11. Color of oxygen cylinder is A. Black body with white shoulder, B. Gray body with black and white shoulder, C. Blue body with blue and white shoulder, and D. Gray. Next question. Cylinder pressure is same in which of the gases? A. Helium, B. Oxygen, C. Air, and D. All. Same in all of them. It was given by the faculty who prepared the PPT for the same. We haven't made any modification in them. Question number 13. Pin index of nitrous oxide is A. 15, B. 25, C. 35, and D. 16. Question number 14. Oxygen cylinder used during MRI is made of A. Molybdenum steel, B. Aluminium, C. Both A and B, and D. None of the above. Central pipeline pressure is 60 to 65 psi, B 50 to 55 psi, C 40 to 45 psi, and D 30 to 35 psi. Next, epiglottis is supplied by A. Trigeminal nerve, B. Glossopharyngeal nerve, C. Vagus nerve, and D. Both B and C. That is glossopharyngeal and vagus. Question 17. Size of working channel of a fiber optic bronchoscope of 2.2 mm ID is 0.2 mm A, B 0.4 mm, C 0.6 mm, and D none of the above. True about fiber optic bronchoscope except A. It works on the principle of total internal reflection. B. 2.5 mm internal diameter bronchoscope can be used for neonates. C. Sterilization can be done with ethylene oxide. And D. Smallest size do not have working channel. Nineteenth question. First to perform flexible fiber optic intubation. A. Dr. Smith. B. Archie Brain. C. Dr. Peter Murphy. And D. Robert Virtue. Last question of this session. Moffat's solution does not contain A. Cocaine, B. Adrenaline, C. Sodium bicarbonate, and D. lignocaine. Thank you so much. Now you can proceed for the lunch and be prepared for the evening session quiz.
As this patient, if this patient came to anesthesia PSC clinic, so we have to thoroughly evaluate his medical history. Any positive medical history you have to evaluate it and optimization as advised. These patients present with history of hoarseness, voice change to pitch, or aphonia, stridor. It could be inspiratory or expiratory. Or patient may present with dysphagia. So all necessary investigations has to be done, especially the chest X-ray, CT scan, MRI, etc., to correlate with the pathology of the lungs, this airway. A discussion with the surgeon is necessary for any potential airway difficulty with anesthesia and know the plan of the surgery, as the patient may present with the vocal cord mass, vocal cord polyp, or any kind of lesions in the vocal cord. So we have to discuss the plan of the surgeons, what they want to do. The patient might be for the this diagnostic laparoscopy or for the therapeutic purpose. So prior to anesthesia, the following should be identified as the airway assessment for ease of ventilation, valuation of the laryngeal inlets, and tracheal intubation. Direct or indirect laryngoscopy to assess the severity and the size of the lesions, and chest radiograph, CT, MRI for information about the lesions, especially the subglottic tracheal lesions that may hamper the ventilations. And we should also ask for the history of the patient, whether they have any postural change in their respiratory problems or their breathing patterns. If they have any problem related to, just as lying down, he have a dyspnea, or feeling orthopnea, or in sitting position is comfortable. So we have to take the such kind of history, especially from the patient, related to airway problems or any mass in the vocal cords. For the indication for the microlaryngoscopy, the patient may come for the diagnostic purpose or therapeutic purpose. For the diagnostic or therapeutic, it could be benign growths like vocal cord nodule, polyp, cyst or vocal cords, granuloma, vocal cord dysfunction, obstructing tumors, recurrent respiratory pulmonary, or any foreign body of the airway. So any patient coming to the PSC clinics or OPD or for anesthesia purpose taking the operation theatre, so we have to consider for what purpose the patient is came, and we have to individualize the patient and plan for anesthesia for the same kind of. So preoperative preparations, if the patient come, this kind of patient came to the PSC clinics, ask for the cessation of smokings. If the patient is a non-asthmatic or any related problems, continue to be taking the bronchodilators. If the patient having any prior tracheostomy, ask him to for steam ventilation, nebulization, and suctions. When the patient is planned for the pre-medications, so pre-medication ideally patient with airway disease or like vocal cord polyp or any obstructive lesions, sedation should be avoided outside the pre-operating room if there is any airway obstructions. Anticholinergics, glycopyrrolate IM can be given 30 minutes before as to decrease the secretions and avoid the tachycardia. Intraoperative monitorings, we have to monitor the heart rate and rhythms, NIBP, pulse oximetry, and capnography, and also the temperature monitorings. Anesthesia technique. Anesthesia technique for vocal cord nodules or any vocal cord lesions could be either by intubation technique or non-intubation technique. Intubation technique, when the lesion is in the vocal cord, like in this case, the patient has vocal cord polyp. Patient may take, and a surgeon may take little bit of time, may plan for this laser surgery or just by the cauterization of the vocal cord polyps or removal of the vocal cord polyps. So in this case, as we expect that their probability of bleeding is there, it may take time to take the procedures. So intubation can be preferred. But if the patient came from the foreign body removals, it could be vegetative or like hot metal objects. So in that case, you may not intubate the patient and go for the removal of the foreign body. So anesthesia techniques for airway disease, it could be intubation technique or non-intubation techniques. For intubation technique, we go for the proper evaluation and induction and intubations, depending on the lesions and what are the type of surgery we are proceedings. Non-intubation techniques are mostly just a type of intermittent apnea techniques, insufflation techniques, spontaneous ventilation and jet ventilation or transtracheal jet ventilations. Intermittent the anesthetic goals for the laryngeal endoscopy includes adequate muscle relaxation to provide the muscles relaxation for introduction of suspension laryngoscope and an immobile surgical field. Adequate oxygenation and ventilation during the surgical manipulation of the airway. Cardiovascular stability during the periods of rapidly varying surgical stimulations. And during the jet ventilation, it is crucial to monitor the chest wall motion and allow sufficient time for the exhalation to avoid trapping and barotrauma. Intubation technique. If we are proceeding for the intubation technique, just like the vocal for this vocal cord polyp, so all equipment for the difficult intubation purpose should be available. You have a bougie, fiber optic endoscope, and variable size of blades of the laryngoscope, straight blades, curved blades, depending on the for the pediatrics purpose usually we use the straight blades and adult purpose curved blades, variable size of tubes, bougie, and this all kind of difficult intubation card must be ready. Induction of anesthesia could depends upon the induction, IV induction with short acting muscle relaxants. For this case, the vocal cord polyp is there. If we are planning for this surgery, removal of the vocal this polyp, so we can go to the IV induction and this short acting muscle relaxant. Intermediate acting relaxant, bicarbonate bromide can be given if the patient has no respiratory distress or suspected obstructed lesions when the patient is lying down. So we can go for the intermediate acting muscle relaxant, or we can go for the succinylcholine, a short acting muscle relaxant, and once we are able to intubate, we can proceed with this NDMRs of intermediate technique. For other induction, IV induction plus inhalation anesthetics like sevoflurane can be proceeded if the procedure is for short times and just for diagnostic purpose, or patient having any related problems when it could be difficult to intubate the patient or give the after giving the relaxation. So intravenous induction with inhalation anesthetics with sevoflurane can be continuous for the spontaneous special purpose. Of intubation for this kind of vocal cord polyp or vocal cord any lesions which can be surgery, could be removal of the mass with or with laser surgery. So endotracheal tube could be simple laryngeal surgical tubes or laser ET tube. And maintenance of anesthesia with intermediate acting muscle relaxants and inhalational, or for spontaneous purpose if we are going the spontaneous respirations, so we can go to the intravenous IV anesthesia and inhalation agents. And IVA can be continued with the propofol, dexamethasone, fentanyls if we are planning for the spontaneous respirations. So if we are going for the microlaryngeal surgery, so microlaryngeal tube, we routinely use this smaller size of the tube or of the 5 or 6 size usually for the vocal cord polyps or vocal cord surgery. But these kind of tubes are relatively shorter in length. 5 mm ID tube is shorter for adult purpose. So a specialized tube called microlaryngeal tube or Malin-Cott's critical care tube, it is of the same length as adult, but as a relatively larger high volume low pressure cuff, and it's stiffer and less prone to compression than the conventional tracheal tube for of the same diameter. So most commonly the 5 mm ID tube is most commonly used for the microlaryngeal surgery. The advantage of intubation in endoscopy includes the protection against the airway aspiration, ability to administer anesthetics, controlled ventilation, and continuously monitoring the end tidal CO2. So these are the two types of tube we can use, microlaryngeal tube and these are two 5 mm size tube endotracheal tubes. One is the microlaryngeal tube, another is the 5 mm tube. So if you are using just simple PVC tube of 5 mm, so it could be shorter. So it will be it's prefer to use the microlaryngeal tube, which is relatively long tube, as long as adult tube. It has a more durability, less prone to kinkings, and cuff is high volume and low pressure. And especially in this tube, the cuff is away from this Murphy's eye, whereas in pediatrics tube you have the same use for this. Pediatric tube is for the pediatric purpose. So it has a low volume, high pressure cuff. So it's ideal to use microlaryngeal tube for the microlaryngeal surgery. So this is the same comparison, that the microlaryngeal tube in comparison to 5 mm size of pediatric tubes. One thing that keep in the mind, using an endotracheal tube of small size in adult is relatively high resistance to gas flow through this tube, meaning that the comparatively high airway pressure are required to deliver the desired tidal volumes. So if as we are using the 5 mm ID tubes, microlaryngeal tube for the microlaryngeal surgery, so there is a narrow diameter, so resistance will be high on ventilation. So at the proximal end of the endotracheal tube, there is a high resistance. So peak airway pressure will be so higher, while the peak airway pressure in the lung is not that much high. And airway pressure is significantly higher proximal to the tube, where it measures the alveoli. Similarly, gas flow is slow during expiration, meaning the lower inspiratory expiratory ratio are often necessary to allow the complete expiration of the gases. So if you are using this microlaryngeal tubes, the peak airway will show relatively higher, and inspiratory expiratory pressure timing we have to increase, so low inspiratory expiratory ratio. If we are using the laser tube for laser surgery, laser endotracheal tubes, so laser endotracheal, if we are proceeding for the laser surgery, so laser endotracheal tube is considered to be relatively safer. It is a stainless steel tube of adult size with narrow diameters. It comes in 4, 5 and 6 size, and most commonly used size is the 5 mm ID. So in the from 4.5 to 6 size, it comes in with cuff, and less than 4 mm ID, it's uncuffed. It is a stainless steel airtight flexible tubes, often a smooth surface and magical curve to minimize the trauma during intubation. The laser oral or nasal body tube is proven resistant to CO2 and KTP lasers. It reflects laser beams and defocus, reducing damage to surrounding healthy tissue. The double cuff designs to help the secure tracheal seal in case of upper cuff is struck by laser beams. This double cuff has to be inflated with normal saline. So if there is any leakage or any proximal cuff get damaged, so we will get it and there is lesser risk of fire. Sometimes some surgeons use methylene blue mixed with normal saline, so the early leakage can be detected. Early leakage means early damage to the cuff. So the microlaryngeal surgery, it comes for the vocal cord or for older age patients. In case of children, case 2 is there. When a 2-year-old child present with cough for 3 days, respiratory distress for 2 days with gradually increasing respiratory distress. The child was apparently asymptomatic 3 days back when he develops respiratory distress and gradually increasing. On examination, respiratory was 24, dyspnea present, decrease air entry on right side. The chest X-ray shows increase in translucency on the right side, so the suggestive of air entrapment. So provisional diagnosis was made foreign body right side of the bronchus, and blood investigations was considered the normal side. This is the chest X-ray of the baby. So for the microlaryngoscopy or for the foreign body inspiration, when we are going for the microlaryngoscopy for the vocal cord surgery, we are preferring the intubation techniques. So we are intubating with either the microlaryngeal tube, or if we are planning for the laser surgery, we are planning for the laryngeal tube with consideration in the comorbidity of the patient. But in this case, when the foreign body of bronchus is present, primary bronchus. So, in such a case, when this child comes, we are not going to intubate, we are going the intermittent apnea technique for this removal of the foreign body. Most of the time in our practice, we use this kind of techniques for foreign body, intermittent apnea technique. If there is vegetables foreign body, so it's not radio opaque and it may not be seen. So, diagnosis was made on the basis of clinical diagnosis. The plan was the endoscopic removal of foreign body under general anesthesia. So, for this child, pre-medication with IV cannula and anticholinergics can be given outside the body. Induction of anesthesia, as the induction of anesthesia for this child, it was 2 years old child. So, induction of anesthesia we can give by the induction anesthesia of this thiopentone sodium 5 milligrams, or you can go through the propofol and giving the, you can give the succinylcholines, or but you sometimes this vegetative foreign body air usually gets swollen and very difficult to take it out. So, it takes time repeatedly one by one. Once as you are going through the intermittent apnea technique, so most of the times you have to ventilate for a short time. Once the oxygenation is achieved, then you start ventilation and surgeon will go for the removal of the foreign body. So, it may take little bit of multiple times, and for foreign body removals, it's not very easy to put the tube and this go for the ventilation. So, intermittent apnea technique is commonly used. So, we can, after inducing the patient, we can go the intermediate acting muscle relaxants. So, after induction, microlaryngeal surgery removal of the foreign body with non-intubation intermediate technique and monitoring and maintenance of vital parameters. Even sometimes it takes 30 minutes, 40 minutes, or even 1 hour. So, these are vegetative body are not very easily to take it out. Sometimes they get brittle and it comes in piece and pieces. When I was doing an MD, so I know that one of my colleague was conducting the case and repeatedly given the squalene. The surgeon takes 4 hours, and finally the baby develops pulmonary edema. It was shifted to pediatrics ICU, but could not be saved. So, taking out the foreign bodies, especially the vegetative foreign body which are swollen and stuck to the bronchus, it's very difficult to take it out. And this kind of procedures can't be done by intubation techniques, because you have to take the foreign body little bit again and again, and their instrument may not go inside, as the trachea of the children is narrow. If you put the endotracheal tube, so it's very difficult to introduce the surgical equipments. This is another foreign body, metallics, with screw is in the left side of the bronchus, and there is a mild pneumonatic features on the left side. This kind of foreign body is actually easy to remove by putting this child under anesthesia, and it's easy to hold and take it out. But vegetative foreign body are quite difficult to remove. So, anesthesia technique is the same, but in case of pediatrics and foreign body, it's difficult to take it out by intubation. So, without intubation, it's quite difficult, because repeatedly we have to put the endoscope and intermittent ventilation. Nowadays, I think we have this endoscope where side port we can connect with anesthesia machines, and surgeon just put the thumb or glass light, so you can ventilate and simultaneously he is working. Previously, it was you have to take out your mask, and surgeon will put the endoscope again this remove the foreign body, and when the saturation started falling, you have again surgeon take out his endoscope, and you have to again put the mask on ventilation, and repeatedly this process was going on. And vegetative body taking, it quite takes time, that's why the complications are very high. This again is a 1.5-year-old child complete with respiratory distress, and chest X-ray shows there is an entrapment of the air on the left side. Surgical relatively there is hyperlucence X-ray on the left side, and techniques of the removal of the foreign body is intermittent apnea techniques. This is also a case of the foreign body on the right side of the lungs with pneumonitis and compensatory emphysema on the left side. Conclusion, different anesthesia techniques have their own advantage and disadvantage. Anesthesia must be customized for each patient. The choice of anesthesia for given procedure should be decided based on the extent of the airway disease of the patient, comorbidities in the patient, and available equipment and resources in the institutions. Thank you.
Thank you very much, Dr. Kushwaha. In fact, whatever he told, it should have been written in a golden letters. And when you are stuck inside OT, then you should have remembered him. Have you got any printed thing of these minor things which you have told? Any printed material so that you can give to them? Because these cases are very rare cases, rather once or twice in lifetime. But when you are stuck, then you really have to struggle. And if you remember all these points which he has told, probably you will save life.
Sir, vegetative foreign bodies are very common still.
Pardon?
Sir, vegetative foreign bodies are still very common in children.
In fact, most of the time, especially in army, I have worked alone. And when I am stuck, only one person, and there are 100 people around, you just don't know what to do. Here things are absolutely reverse. So, especially I'm talking about our students, when they will leave big institute and go to practice at remote areas, then these points are very important. Especially there is a very different atmosphere when you are practicing anesthesia, especially outside your.
Yes, sir.
Here you are protected. You are very, very protected.
Yes, sir. Here.
Outside when you go, then you remember कि प्रोफेसर जीपी सिंह ने हमको ये सिखाया था, प्रोफेसर कुशवाहा ने हमको ये सिखाया था, और याद करने की कोशिश करते हो.
Sir, before joining this institute as a faculty, even I have experience of foreign body removal, this same type vegetative. Child was almost gone, but luckily came back without arrest. Heart rate went to 12 and saturation was 12 and 15 because the same procedures, because the outside surgeon only rigid bronchoscope and he don't have any option to simultaneously ventilate without removing the tube.
In fact, here problem is probably you may not be asked in the exam also. For your MD examination, you may not be, nobody will remember. And when go out and practicing, at that time you can save many lives by all these things. Thank you very much. It was very interesting, very informative, especially those tubes. Very.
Thank you.
So, let us start our next. Dr. Babya.
Thank you so much, sir. With this, we have come to an end of this session. I now request Colonel Tripathi, sir, to kindly confer a token of gratitude to Professor B.V. Kushwaha, sir. I now request Professor Vinita Singh ma'am to facilitate Dr. Premraj Singh sir for as a token of appreciation for his wonderful lecture. I again request ma'am to kindly felicitate Dr. Sanjay Chaubey sir for his wonderful lecture. I would now request Professor Rajni Gupta ma'am to kindly honor both our esteemed chairpersons, Colonel Tripathi sir as well as Professor Vinita ma'am with a token of gratitude. I would again request Professor Rajni Gupta ma'am to kindly honor both our chairpersons for their valuable presence. I would now like to welcome the chairpersons of our last session for today. Our first chairperson is Dr. Armeen ma'am. Ma'am is an associate professor in the Department of Critical Care Medicine, KGMU. She is an extremely skilled critical care expert with an added interest in obstetric critical care. Our second chairperson for this session is Dr. Somnath sir. He is a professor in the Department of Anaesthesiology, Hind Institute of Medical Sciences, Barabanki. He is a renowned FCCS instructor with an interest in critical care and pain management. Over to you, sir and ma'am.
Our next speaker is Dr. Bhavya, and she's assistant professor in Department of Burn and Plastic Surgery. She's extremely talented and very hardworking. I know her as one of the most hardworking person around, and she'll be talking about post-burn contracture, neck for contracture release, right?
Thank you so much for that kind introduction, ma'am, and it means a lot coming from you. Good afternoon, everyone. My topic for today is anesthetic management of post-burn contracture neck. Now, there is a saying that an anesthetist uses 5% of his knowledge 95% of the time and 95% of his knowledge 5% of the time. So this is one of those cases where you will use 95% of your knowledge and skill. It is one of the most challenging cases for an anesthesiologist. So this is a 30-year-old female, a resident of Kanpur. She's a housewife by occupation, and she came to our OPD with a complaint of restricted mobility of the neck since 4 years. She had a history of accidental thermal burns to the face, neck, and chest 4 years back while cooking. No history of any loss of consciousness. No history of inhalational burns. Around 3 episodes of seizures. Her wounds healed well, and there was a little bit of scarring and contraction. Now her primary complaint is an inability to extend her neck and a mild disability to carry out her daily activities. Also, decreased mouth opening and outward turning of the lower lip with no significant past or personal history. Now, this patient is comfortable, and she has no pallor, icterus, clubbing cyanosis, or any complications. Her vitals and all systemic examinations are within normal limits. The airway examination I will concentrate on. Her mouth opening is around 2 to 3 fingers with an MPG of 4, no loose teeth indentation. Thyromental distance could not be measured. Neck movements, of course, the extension as well as the sideway movements are restricted. And there is limited flexion possible over the contracture band of the neck, but the tongue protrusion is possible. Her investigations are almost normal. In the left side DNS and right side nasal patency. So this is this is an easy case for you. Once I'm sure most of you, when you saw the picture, you said, "Arey, isko to kara lenge. Mouth opening hai, there's no problem." But what if you get this case? What are the problems you anticipate in this case? Can we please have some volunteers? Kya problem milegi? What's the primary problem in this patient? No extension, very good. So in both these patients, see, but you have the nasal patency. The nasal patency is present. Malapati is grade 3, but extension is restricted. So now I just would like to tell you, since you are an exam going batch, whenever you prepare a case, divide your course into 3 sections. Must know, good to know, and nice to know. So regarding this case, how will you divide this case into these 3 sections? What you must know is the common issues associated with anesthetic management, the key points examined during the pre-op assessment, how is the airway affected, how will you manage the airway, what are the important pharmacokinetic as well as the pharmacodynamic changes, what are the precautions you will take during induction, and of course the post-op management and the pain management. What is good to know? Yes, how will you position the patient, the various positions that you can try. How does the neck contracture make the airway challenging? What is the classification of neck contractures? What is the surgeon's role in this? Because this is a case where you need your surgeon as your ally. You have to work in this together. And of course, the role of tumescent local anesthesia. If your viva is going exceptionally well, you might be asked the classification of Bose-Bun contractures, but that is, we'll come to that later. So what are the common issues with this case? The first thing that the red light that should light in your mind is, problem kya milegi humko? Sabse pehli problem hogi difficult airway, which is why I've written it in a bolder print. There are grossly restricted neck movements. There is a possibility of restricted mouth opening and nasal passages. There is difficult laryngoscopy, difficult endotracheal intubation, and of course a very poor oral hygiene of the patient. Apart from that, and more importantly, and a bigger practical problem is, there is scarce venous access. You don't have places for monitoring. You don't have place for an IV line. You might encounter this. In our burn unit, we encounter this all the time. And the positioning of the patient is very difficult. All these patients, even though they are chronic patients, they are all worked up patients and they are posted in your elective OTs, they are likely to be anemic, malnourished, and also hypoproteinemic. So this is a very good case report I found, and I thought that, wait. So I've made a flow chart here. When you go for difficult endotracheal intubation, you can divide it into 4 parts, right? There will be limited oropharyngeal space. Iski wajah se kya hoga? That will limit your space for visualization on direct laryngoscopy, and you might also have a difficulty in introducing airways. Then there is a decreased pharyngeal space as well. So there is an inability to align the oral and the pharyngeal axes. Then there is a decreased submandibular compliance. So the tongue cannot be compressed properly. And because of this, although the larynx may not be anterior, but you might see an anterior larynx. Then of course, because of the scar contracture, there is decreased atlanto-occipital extension. And because of that, there is ineffective cricoid pressure. It's difficult to perform the OLM and the burp maneuvers because of this restricted neck movements. So what are your options here? Your options are that you can go for awake fiber optic intubation. You can go for an LMA, an intubating LMA. If you're very experienced, you can go for blind nasal intubation as well. You can go for retrograde intubation, or finally a tracheostomy. It all depends on your skill, experience and comfort level. And it also depends upon the burn or the scar area of the patient, the age and the weight of the patient, the presence of any concomitant diseases, skills and preference of the operating surgeon, and of course the patient's consent and what resources are available with you. If you have a difficult airway cart, what all resources do you have on that cart? Do you have an intubating LMA? Do you have a fiber optic bronchoscope? If there is a pediatric patient, do you have a pediatric scope? So all these things you will have to consider, the patient as well as the resources, and then you have to make a decision. So there are no guidelines. You will decide, you will think on your feet. This is an excellent case I found in IJA. It's actually a very interesting case. So what do you see here? Isme kya dikh raha hai? This patient had an acid burn at the age of 5 years old. She presented at the age of 15 years. She is ASA1, but she has a contracture band extending from the bilateral nasal alley involving the upper and lower lip, neck, trunk and abdomen, and it extends till the umbilicus. So because of this, there is a complete obliteration of the left nostril and partial obliteration of the right nostril, and just the lower lip mucosa is visible and the mouth opening is inaccessible. So now in this case, how will you proceed? Anyone? Release the contracture hand. That's what they did as well. So what they did was that they took a 4 millimeter endotracheal tube, right? First of all, they tried to release the contracture of the neck. On releasing the contracture of the neck, after giving a little ketamine or propofol, they found that the mouth opening is negligible. It's not even 1 centimeter. So the option of LMA is out. And the option of introducing a laryngoscope is also out. Moreover, her pharyngomaxillary angle, as you can see, is less than 90%. So you know कि अगर आप intubation करोगे भी, तो आपका Cormack Lehman grade 3 or 4 ही मिलेगा, right? And of course, so all these things, they completely preclude laryngoscopy. So what is your next step? The next step that they did was that they tried to recover the nostrils. How they recovered the nostril was that they performed a commissurotomy here under local anesthesia. They released the labial commissures. After releasing the labial commissures, they found the right nostril very slightly patent. They took a 4 millimeter endotracheal tube uncuffed, inserted it into the right nostril, connected it to the Mapleson circuit, and with a 1 Mac of halothane, they proceeded with oral fiber optic intubation. And for that, they used a plethora of airways. I'm going to describe the airways. So what I'm trying to tell you is that in this case, you are the decision maker, and you have to think on your feet. So what if the nostrils are not patent, right? This should always be in your mind. There could be associated microstomia, fibrosis of the bilateral nostrils, and avulsion of the nasal passages. So always remember the nasal route is very easy because the angle of curvature of the ET tube naturally approximates to the upper airway. But what happens in the oral route? It's technically more difficult. You must have experienced that. There is a difficulty in advancing a tube over an orally inserted fiberscope as the tube tends to move posterior to the glottis, such as onto the arytenoids cartilage or to the esophageal inlet. And as most of you know, the gag reflex is more troublesome. And in post-burn contractures, it's very difficult to give the blocks that we give, the superior laryngeal nerve blocks and the other blocks, because you don't get the landmark. So you might attempt a block, but it might not be very effective. So you need an alternate channel that creates a more anterior curvature. So there's no need to be flummoxed in such a case. What you should do is you have these airways at your disposal. There is a Berman's oropharyngeal airway, you have a Williams airway intubator, you have an Ovasapien fiber optic intubating airways. And the purpose of all these airways is that they help to keep the fiber optic bronchoscope in the midline. And they deliver its tip to the pharynx. They don't allow it to move posteriorly, and they also prevent the patient from biting the fiber optic bronchoscope and having a patent airway as well. So many purposes are served. So let me just summarize. What are the different ways of securing the airway in post-burn contracture cases? You can go for inhalational anesthesia with volatile agents. You can go for a simple surgical release of the contracture with either ketamine as the sole agent or give tumescent anesthesia. I'll explain tumescent later. Then you can go for intubation with the help of the special airways that I described earlier, or fiber optic bronchoscope, which is of course the gold standard in this case, or LMAs or intubating LMAs. If you are experienced, you can also go for video laryngoscope assisted intubation if the mouth opening allows that. And finally, if everything else fails, you can go for a surgical cricothyrotomy or a tracheostomy. So now I'm going to tell you some useful blocks. There are certain blocks which you can, suppose you don't want to go for inhalation anesthesia. You want your patient to be fully awake. So there are certain blocks that you can try to release all the contractures of the face, around the nose, around the mentum, etc. So there is an infraorbital nerve block which provides anesthesia of the upper lip and the skin. It is very, very simple. The infraorbital notch lies on a line connecting the supraorbital and the mental foramina and the pupil of the eye. And this nerve can be blocked by advancing a 25 gauge 3 centimeter needle laterally and superiorly towards the foramen. You don't actually have to enter the foramen. As soon as the needle is in the tip of the foramen, you can just inject 3 to 4 ml of 0.5% bupivacaine and that will serve your purpose. So this is how you do it. It's very simple. There are two approaches, the intraoral approach and the extraoral approach. Just locate the infraorbital foramen with your middle finger, lift the upper lip with the index finger and the thumb, insert your needle through the gum line and the second bicuspid as shown until the needle is palpated at the infraorbital foramen approximately 2 centimeters and give your drug. Extraorally, if you're very confident, you can insert your needle through the skin perpendicular or at a 45 degrees angle after palpating the foramen. Then if you have a contracture here around the mouth, you can give a mental block, a mental nerve block. The mental nerve exits the mental foramen and provides anesthesia to the lower lip and the chin. It lies in a vertical line connecting the pupil of the eye again with the foramen of the peripheral nerves. So you can palpate it in the mandible, take the 25 gauge needle, insert it inferomedially. Remember that was inserted superiorly and this is inserted inferomedially. And just take 2 to 4 ml of 0.5% bupivacaine, that much will be sufficient. So what are the pearls in airway management? What should you remember when you approach this case? The first aim is that you should have total control of the airway. At no point in your case should control of the airway be lost. Preserve spontaneous respiration till the trachea is intubated. Consider using a nasopharyngeal airway, oropharyngeal airway, LMA, wherever feasible. All these devices will improve your quality of anesthesia. Always fix ET tubes to the maxilla. Why am I saying that? Because if you fix them to the mandible, that can soak and soil them with blood and secretions from the operative field and can also interfere with the field of surgery. Any narcotics that you use, try to use them only after securing access to the trachea. You can use them in small doses, but as far as possible, try to go for monotherapy. Use one drug. Either use ketamine or use propofol or use Dexam or fentanyl, whatever you're comfortable with, but monotherapy. Use one drug. In patients with migraine and motion sickness, avoid narcotics, tramadol and metronidazole. So these were all the practical tips. Now from your exam point of view, in the history, you will ask about the duration of contractures, any history of convulsions, difficulty in breathing and swallowing, any history of motion sickness, any history of snoring, epistaxis or bleeding from the oral cavity. Very important history is history of tracheal stenosis. Has the patient been intubated earlier? पता चला आपने डाल तो दिया फाइब्रोस्कोप से और वो आगे ही नहीं गया because there is tracheal stenosis. So you must ask that is there a history of tracheal stenosis or inhalational injuries. There have been case reports where even 50 years later, the patient presented with tracheal stenosis. He was intubated at the age of 5 and at the age of 55, he was having recurrent asthma. And when an X-ray was done, it was found that the patient had tracheal stenosis. So you must take all these points in the history. Then any history of psychiatric problems, because you need a very cooperative patient for this procedure. Any history of acid peptic disease or reflux. Then you have to see the nature of the contracture. Is it soft, firm or hard? How long has it been? What is the extent of the contracture? Is the sternocleidomastoid involved? If it is not, then you can also give a block here. So you must always ask, where is the sternocleidomastoid involved? Then the mandible, can it be moved up and down? If the mandible is involved, then it's more of a difficult intubation. Are the nasal passages patient? Is the patient dyspneic? Can he lie down comfortably? Can he blow air through the mouth and the nose? And in preparation, what you must do, improve the oral hygiene, correct the anemia and hyperproteinemia, have H2 receptor antagonists and prokinetics ready, as well as antianemics, do an aggressive treatment of upper and lower respiratory tract infection, and very important, your equipment check, your difficult intubation card, and your resuscitative drugs. Now, when we come to the pre-medication part, avoid heavy sedation, preserve respiration. Drugs that depress respiration are better avoided till the airway is secured. Continue the H2 receptor blockers and antihemics. You can always consider pre-op nasal decongestants. They help you to put in a nasopharyngeal airway. You can use topical viscous anesthesia for the oral cavity also, and the pharynx before induction. And you can also consider the superior laryngeal nerve block if the hyoid and the upper margin of the thyroid are visible. Now about the drugs. What happens in burn patients? The plasma albumin is less. the acid glycoprotein is more. So because of this, the plasma protein binding of drugs like benzodiazepines is reduced and the volume of distribution is increased. So all the drugs that are at our disposal, let's just revise them quickly: thiopentone, etomidate, propofol, or inhalational agents. In burn patients are normally hypovolemic. Burn shock is a combination of all shocks. It can be hypovolemic shock, it can be distributive shock as well. But the patient you get here will not be a patient of shock, it will be a patient posted for elective surgery. But still remember that these agents are poorly tolerated in a hypovolemic patient, so your patient should be preloaded properly, well hydrated. Then diazepam has a prolonged effect, as I explained earlier, because the plasma protein binding is decreased. Ketamine is the star of the show here. It is a phenomenally useful drug in burn patients. And it has been seen that IM ketamine is more useful than IV ketamine in a dose of 2 to 5 because the analgesia lasts longer, the contractures will be released by then, there is less risk of respiratory depression, more stable hybodynamics, and the patient can be smoothly transitioned into an inhalational technique. Now there is one more point which you should remember here, that there is a rhabsin protein which is decreased, and this protein is responsible for keeping the receptors at end plate of the neuromuscular junction. So when this protein is decreased, there is proliferation of extrajunctional receptors away from the site of injury. This gives you a resistance to non-depolarizing muscle relaxants, especially in total burn surface area of more than 30%, although this takes 1 week to manifest and it continues till 18 months after the burn has healed. So this means that resistance means that you will require larger doses and they will have a shorter duration of action. On the other hand, these patients are very sensitive to depolarizing muscle relaxants. So there is excessive potassium release associated with succinylcholine. As you all know, normally 0.5 milliequivalent per liter is increased potassium, but in burn patients, there is an exponential increase. And this begins within 3 days after thermal injury. It may last up till 90 days or 6 months. So scoline is out. Scoline, your best friend in a difficult airway, you cannot use in this case. So what are the precautions you take in the post-op period? Extubate only when you are sure. Watch for airway obstruction. Observe the respiratory pattern of the patient. Use a nasopharyngeal or oral airway if needed. Continue the antiemetics post-op. Give good post-op analgesia and maintain body temperature and prevent shivering. For pain management, you use a multimodal approach. You have analgesics of different classes having different mechanism of action. So when you combine them, they will have a superior effect. You can start with plain paracetamol. Then you can move on to other NSAIDs, ketorolac, etoricoxib. Then you can go for the opioids, tramadol, fentanyl, and finally morphine and patient-controlled analgesia you can also give. The last point, which is a short note for you, is tumescent anesthesia. This was discovered by Dr. Jerry Skleen for liposuction patients. And the word tumescent means, literally it means swollen and firm. So what they did was they used an injection of large volumes of very dilute local anesthetics and epinephrine. And this provided profound anesthesia. But the maximum dose they used was 35 mg per kg. How do you prepare this? There is no hard and fast rule. Different people use different formulations. What you have to remember is that there is 2% lidocaine on your trolley and the concentration of lidocaine here is between 0.4 to 0.5%. So you have to dilute it 4 times. Adrenaline you have to use 1:100,000. Some people also use 500,000. You can use it in distilled water or normal saline. For PBC contractures, the usual volume is 70 to 200 ml, so you dilute it accordingly. And then soda bicarb and hyal uronidase is also used. The question that should arise in your mind, if you've really read pharmacology well, is despite the unusually large amount of lidocaine used with the tumescent technique, the systemic absorption is remarkably low. Why? Well, this is because the first part hepatic extraction ratio is 0.7%. Lidocaine is rapidly metabolized by the liver. At the same time, epinephrine increases the cardiac output and the hepatic blood flow, but the hepatic metabolism of lidocaine is accelerated. So there are two opposing mechanisms. But remember that the systemic absorption of subcutaneous lidocaine is a function of the blood perfusion rate of the local tissue, and it is absorbed only from the periphery of the tumescent tissue. So the relative avascularity of the fat and the fact that you're using epinephrine for vasoconstriction, this accounts for the slow lidocaine uptake into the systemic circulation. If you remember your local anesthetics, remember that the more dilutes the solution, the safer it is. The median lethal dose of subcutaneously lidocaine in mice increases with increased lidocaine dilution, and dilute solutions with epinephrine produce excellent cutaneous anesthesia, although for a shorter duration. So the larger the volume injected, the greater is its diffusion, and the more uniform is the resulting anesthesia. The last slide I'm showing you is when the examiner has asked you everything and there is nothing more to ask, and then he will ask you about the OLA's classification of post-burn contractures. This is actually a surgical question, but just for your interest, there are 4 types. There could be a mild anterior contracture where the patient can flex his neck and the patient can bring the jaws to the anatomical position in an erect position. So this is type 1. Then type 2 is the moderate type where the patient can flex the neck and bring the neck to the anatomical position while erect, but extension is a little difficult. And here you should anticipate difficult intubation. The third is the severe anterior mentosternal contracture where the neck is contracted in the anatomical position and the chin is restrained down in the anterior trunk. The patient cannot reach the anatomical position. Again, very difficult intubation. And a posteriorly located contracture, the band prevents full neck flexion and holds the neck in some degrees of extension. And here also, your intubation is very difficult. Thank you very much for your attention. I know this was a post-lunch lecture, and thank you for your participation.
Okay, thank you for an excellent lecture. Any questions?
So one question I'll ask you, how will you make a concentration of 0.5% lidocaine? Practical question. 2% से 0.5% अगर बनाना हो तो कैसे बनाओगे? Dilute it 4 times. Good. So suppose the surgeon is taking 20 cc's of lidocaine, 2%. तो उसको कितने में घोलेगा? Very good. You see, there was a case in ENT where the nursing staff had misprepared a solution of lidocaine and the patient had gone into arrhythmia. So as an anesthetist, this is also your job. Anything that is being given to your patient, you should know कि क्या दिया जा रहा है और कैसे दिया जा रहा है. Okay?
I would just like to add one point, and because we are more dealing with the emergency airways, emergency difficult airway. So in one of the guidelines, British guideline, I'm adding that to this. They showed in the literature, in the national audit, British national audit, they showed that if you are stuck in a difficult airway, and then you decide for fauna, that is front of neck access, most of the time they found that even if the access is there, so there will be some amount of brain injury. Even if you are able to, you are stuck with a difficult airway and you go for tracheostomy, you go for fauna, and you will be still damaging the brain. So that was the audit data. That was from the British audit. So what I would suggest that when you are stuck, and you know that you're going to land up into crisis, then they are suggesting double setup approach, in which you have a surgeon ready for tracheostomy at one side, and then you are inducing the patient. And if you fail there, then the surgeon immediately goes for a fauna. That is front of neck approach where you do a tracheostomy. So you don't have that much of time to call someone else and then do the tracheostomy and prepare it. So that becomes a very crisis kind of a situation. So I would suggest, I mean, that's an important learning point, that you go for double setup approach. I mean, you prepare from beforehand. You know that it is going to be difficult. Before induction, I have my tracheostomy ready. So that is a learning point. And thank you. It was very informative. Thanks a lot.
Thank you so much. The next speaker is Dr. Tanmay Tiwari. He is the Associate Professor, Department of Anesthesiology, KGMU. He is also a Secretary, ISA Lucknow branch, and he is a very dynamic personality. His area of interest is airway management, organ transplant anesthesia. Today, he will be delivered on a very important and very interesting topic, that is the oxygen therapy. Last 2.5 years from the COVID scenario, the oxygen therapy is very much important. And he is also make the oxygen saving strategy in the KGMU department. So this is a very good and very interesting topic. So please be attention all the PGs. Over to Dr. Tanmay.
Thank you, Dr. Somnath. Thank you for the nice introduction. So, post-lunch session, usually everybody is tired. So I request everybody to please stand up. Stand up. Raise your hands. Do some stretching. Do some stretching, take some oxygen, and then we'll go on the oxygen therapy. बैठ जाओ, please. So first of all, I would like to congratulate Dr. Manish Kumar Singh for all the efforts he has taken to organize this. And to all the students, welcome to KGMU. If you're a part of KGMU, you are already welcomed. If you're not, then you're graciously welcome to this institute. So as we all know, oxygen is pretty important to all of us. It is the basic of life. It is one of the most commonly administered drug which we have seen during the COVID times. The oxygen was in scarcity and people were actually dying for it. So our body is dependent upon energy and energy is dependent upon oxygen. So if you go with aerobic metabolism, you get 38 ATPs, while in anaerobic metabolism, you get 2 ATPs. So the simple essence is, if you don't get energy, you die. So if you don't get oxygen, you eventually die. So that is why the oxygen is very important. Very basic question, but usually residents do confuse in this question. So what is ventilation and what is oxygenation? So ventilation refers to the act of inspiration and expiration. It refers to the delivery system that presents oxygen-rich air to the lungs, while oxygenation is a process that involves the transport of oxygen across the barrier, which is the lung barrier, and it involves gas exchange. They both are independent physiological processes. While ventilation you can measure by seeing the clinical signs like chest rise or respiratory rate, the oxygenation is usually not so easily measured, but it can be measured by confusion, irritability, and the best and the simplest method of observing oxygenation is by using pulse oximeter. And post-COVID, every family is now having the access to pulse oximeter. So how do we get oxygen? Oxygen is free, of course. You just have to inspire, you get a lot of oxygen. So the percentage of oxygen in normal air is 21%. The normal atmospheric pressure is 760 millimeter of mercury. So the tendency of oxygen is that it transports from high concentration or high partial pressure of oxygen to low partial pressure of oxygen. So at the bottom you can see that in the atmosphere the partial pressure of oxygen is 160, while in the arterial blood it is only 98 to 100, while in the lungs it is 105 to 110. So we have the partial pressure of oxygen at the alveolar level, and we also have the partial pressure of oxygen at the arterial level. The normal difference is usually the normal alveolar to arterial gradient is usually less than 10 millimeter of mercury. If your alveolar arterial gradient is more than 10 millimeter of mercury, then there is some problem. So if you see an ABG values, if you find that the arterial concentration as well as the alveolar concentration shows difference of more than 10 millimeter of mercury, you should suspect some problem. And what is this process called as? The transport of oxygen from high pressure gradient to low pressure gradient. It is called as oxygen cascade. Okay? So when the process by which we get oxygen involves many systems. It involves the cardiac system, it involves the respiratory system, it involves the higher centers of brain, and also the peripheral nervous system. This is a very basic question, which is oxygen hemoglobin dissociation curve. We all must have studied during our first year MBBS physiology what are the causes of right shift of oxygen hemoglobin dissociation curve as well as the causes of left shift of the oxygen hemoglobin dissociation curve. When the dissociation curve shifts to the left, there is an increased oxygen affinity. While if it shifts to the right, there is a decreased oxygen affinity, and the hemoglobin tends to release more of oxygen. The left-sided shift is usually found at the levels of the alveoli because you want more of your blood to gain more of oxygen, while the right shift of the oxygen hemoglobin dissociation curve happens at the tissue level because you want more of the oxygen to be released by the hemoglobin to the level of the tissues. So we all know what are the causes of right shift of the hemoglobin dissociation curve to the right. Ankur, do you know them? Can you please enumerate? Low pH, that is acidosis. High temperature, very good. Increased 2,3-diphosphoglycerate and increased temperature. So what is the difference of fetal hemoglobin? Does it have a high oxygen affinity or a low oxygen affinity? High oxygen affinity. So your hemoglobin, fetal hemoglobin, has a tendency to shift towards the left side. And the left and the right side is actually determined by the P50 values. Can anybody tell what is P50? Anyone? What is P50 value? I'm not asking the value. I'm asking what is P50? What do you understand by P50? It is the partial pressure of oxygen at which hemoglobin is 50% saturated. So normally it is 27 millimeter of mercury. And when you find that if your oxygen affinity decreases, there is a increased pressure of oxygen is required to reach that P50 value. While if there is increased oxygen affinity, you have the P50 levels less than 27 millimeter of mercury. So this is a very common and tricky question and usually comes in MCQ setup. So how do you calculate the oxygen content of the blood? So this is very important. You should know what is oxygen content of the blood. So simply what you can do is the content inside the blood depends upon the oxygen which is dissolved in the hemoglobin as well as oxygen which is dissolved in the plasma. So 1.34 into the hemoglobin values in grams per deciliter into the saturation levels plus 0.003 into the partial pressure of oxygen at the arterial level. So if we even reduce that PaO2 values, the oxygen dissolved in plasma, it is very less. When you multiply, it is 0.003. So anything which you multiply will get values close to 0.3 only. 0.3 ml per 100 ml of blood, the dissolved oxygen. While the hemoglobin has a higher impact on the oxygen carrying capacity of the blood, that's why you ask your patients to build up hemoglobin during the perioperative visit, or you go for transfusion of blood during acute loss of the blood. So when you calculate by putting the values of hemoglobin at 15 gram per deciliter, each 100 ml of arterial blood carries around 20 ml of oxygen, while each 100 ml of venous blood carries around 15 ml of oxygen. So you can see that even your artery level, oxygen level is 20 ml, the body uses only 5 ml of oxygen. The rest 15 ml still goes out and it gets recirculated. So the global oxygen delivery, if you multiply the content of oxygen with the help of the cardiac output, you get the global oxygen delivery that is close to 1000 ml. And each minute the oxygen which is consumed by the body is close to approximately 250 ml. So in health, you see that you get only 20 to 30% of the oxygen which is delivered to the tissues is utilized during normal times when you're not going through fever, you're not going through sepsis, you're not exercising. So the max, which is called as oxygen extraction ratio. So this oxygen extraction ratio raises to a maximum level of 0.6 to 0.8 if you're an athlete, if you have been practicing well, if you have been doing yoga well, then you can increase your oxygen extraction levels to up to maximum of 0.6 to 0.7, not more than that. So this is the point which you need to remember. Normally, the oxygen extraction ratio is 0.2 to 0.3. So this is what is the impact when you actually see at the hemoglobin levels of 14. The formula of oxygen content is given. You see that the oxygen content is close to 20 ml in 100 ml of blood. when you have a low hemoglobin values of 7, the oxygen content reduces to around 50%, that is 10. And when you have a PO2 or a lung disease, you find that when your saturations are arterial oxygen pressures are less, that is 25, then also, so you can see there is a huge impact when you see a fall in hemoglobin values. So the hemoglobin comes in play in the picture when the oxygen content and the oxygen delivery to the tissues is required. Similarly, you can see that if you are using a hyperbaric chamber, what you are actually increasing is the partial pressures of oxygen, and the dissolved concentration of oxygen in plasma increases rather than the oxygen dissolved in the hemoglobin. So the hyperbaric oxygen therapy works on the concept of, it works on the 0.003 into the partial pressures of oxygen. So that is the concept of the hyperbaric oxygen therapy. So these are the few tables you can find in any book. What are the causes of increased VO2 and what are the causes of increased VO2? Nothing more to discuss. So what is oxygen therapy? So if you give oxygen to a person in more than 21% of the atmospheric values at pressures of atmospheric pressure or at pressures more than atmospheric pressure, that is called as oxygen therapy. Then there are two terms, hypoxia as well as hypoxemia. So what is the difference? Hypoxia refers to reduced oxygen levels at the level of the tissues or cells, while hypoxemia refers to the reduced oxygen concentration in the blood, and it is usually measured or set when the PO2 values are less than 60 mm of mercury, or your saturation values, which you measure with the help of the pulse oximeter, is less than 90%. Then we have the type 1 respiratory failure and the type 2 respiratory failure. So in which type 1 or type 2 respiratory failure the oxygenation is helpful, in which you require the oxygen therapy? So it is type 1, which is you find the PaO2 values less, but the PCO2s are usually in the normal range. In type 2 respiratory failure, what do you find? Along with the reduced PaO2 levels, you may also have increased PaCO2 values. So to get the impact on the PaCO2 values, you also require an additional effect of ventilating the lungs. So in that setup, you require the ventilatory management of the patient. Those patients, type 2 respiratory failure patients, will require oxygen as well as ventilation. Okay? So there are 4 types of hypoxia, very common. Most commonly, you help the hypoxic hypoxia. When there is actually reduced levels of oxygen, the oxygen therapy helps maximum in the hypoxic hypoxia. It helps least in which type of hypoxia, Ajit? Histotoxic hypoxia. If your tissues are under the effects of any poison or cyanide poisoning, even if you give oxygen, that oxygen won't help into creating energy and the cells will actually die. So this is just a slide to brief knowledge about hypoxia. So then there are patients on oxygen therapy, short-term oxygen therapy and long-term oxygen therapy. Short-term oxygen therapy usually during surgery, post-operative period, when you are having any MI infections, sepsis, while long-term oxygen therapy is usually on patients which have cardiopulmonary illness like COPD, bronchial asthma, obstructive sleep apnea. So just an enumerative slide. Coming on to the oxygen delivery practices, it is very important. So oxygen delivery systems are actually classified as low flow or variable performance devices and high flow or fixed performance devices. So what do you understand by low flow systems? So what I actually got is the low flow systems provide oxygen at flow rates that are lower than patient's inspiratory demands. So at a constant flow, the larger the tidal volume the patient consumes, the lower the FiO2. So the FiO2 keeps on varying depending upon the patient's inspiratory characteristics. While in contrast, the high flow systems usually provide with constant FiO2 and they deliver it by gas at flow rates that exceeds the patient's peak inspiratory demands, and it helps in maintaining the FiO2 values. So that is the brief concept, whether you define your system as low flow system or high flow system, it is better to say them as variable performance devices and fixed performance devices. So first delivery device, very commonly used, nasal cannula. The advantages you all know, it is very inexpensive. All people, even a healthcare worker who haven't used oxygen can use it. It does not interfere with talking and eating, so the patient is happy. If you are in home and you require oxygen therapy, then nasal cannulas are good. What are the disadvantages? It causes irritation, dryness. If you exceed the flows beyond 2 to 3 liters, it can lead to irritation. Displacement, you have placed it, but the patient has removed it, so even the patient won't be benefited by the oxygen therapy if it is not adequately placed. Simple face mask. It has a capacity of 100 to 300 ml capacity, provides a FiO2 of 0.3 to 0.5 at flows of 6 to 10 liters per minute. Advantages, quick and easy to set up. Disadvantages, the patient won't be able to eat or talk. It may be claustrophobic for some people. Putting a mask on their face seems them to be claustrophobic. So, but it is useful in patients who are strictly mouth breathers. So if there is a patient who is a mouth breather and you put a nasal cannula, there won't be any changes in the saturation or the PaO2 values of those patients. So if their patient is a mouth breather, you should go for a simple face mask. Then we have Venturi devices. So these are color-coded devices which function and have a dedicated FiO2 values on a dedicated flows. So you can, this is just a numerical chart. There is nothing to remember. You can just follow the, it is a device you can rotate and fix the flows and you can get the desired FiO2 values. It works on which principle, Sachindra? It's not Venturi's principle. It's Bernoulli's principle. Okay. So this is the principle. You give oxygen, some part of atmospheric air goes inside and provides the desired FiO2. Then there are the non and partial rebreathing masks. So these are the masks which have an extended bag attached to them, plastic bag, which you fill it with 1 to 2 liters of oxygen. They are called non-rebreathing as well as partial rebreathing. So the name already suggests if there is a valve which prevents the expiration flows to go inside that bag, then that is a non-rebreathing valve. If there is a valve that allows certain portion of expiratory things to go inside the bag, that is a partial rebreathing bag. Benefits are you can increase the FiO2's values up to 0.8 depending your bag is full and you increase the flows up to 10 to 12 liters per minute. Remember, all your devices have a fixed FiO2 and they need to be worked with the desired flow rates. So this is one very important thing. Your devices are designed to work at particular flow rates and at particular FiO2s. So you being an anesthetist should always know what are the FiO2 and what are the flows. Most of the people actually don't know and they don't want to know because they think it is very easy and oxygen kaise bhi hai, kaise bhi laga do, oxygen to deni hai, kaise ka karna hai. And then there is a fancy device called HFNC. Everybody post-COVID is master in HFNC. So the benefit of HFNC is it provides high flows of humidified oxygen. So there is an air oxygen blender, then you have a temperature, and you can increase the FiO2 values to 0.8 to 1. The disadvantages is it uses huge amount of oxygen. Maximum flows up to 60 liters per minute to 100 liters per minute of oxygen is used, and that may lead to devastating your oxygen reserves and it may be quite costly for the hospital setup. So this is one fancy thing. It is used for perioperative oxygenation. If you suspect any patient which is going to fall during any procedure of your anesthesia, then it is a very good device. It is also good for weaning the patients out from invasive or non-invasive ventilators. Coming on to the general estimation rule, even if you don't remember what are the FiO2s and what flows you should use, this is a simple formula that you can calculate a rough estimate of FiO2, how to calculate. So 0.21 is the atmospheric, just need to plus into 0.03 into the oxygen flows of liters per minute. This is for the low flow devices, not for the fixed flow. Fixed flows have actually the fixed FiO2 values. Okay? So this is simple thing. Nasal cannula don't use flows beyond 4 liters per minute. Venturi mask works on Venturi, even I have mentioned it as Venturi principle. So it is Bernoulli's theory. Okay? So non-rebreathing mask, you can give 80 to 100%. High flow nasal cannula, I've already mentioned these. Then there is non-invasive ventilation, which includes the CPAP and the BiPAP. Can anyone tell what is CPAP and what is BiPAP? BiPAP is actually CPAP only. In CPAP, you have the same pressure values. You try to give oxygen at higher pressure than the atmospheric pressure, and the pressure remains same during both the inspiratory as well as the expiratory phase, while in BiPAP, you have different levels of pressures during inspiration and expiration. That is the only difference between BiPAP and CPAP. A word about what is medical use oxygen, which I think everybody being an anesthetist should know from now onwards post-COVID. So what is medical oxygen? You get oxygen basically by three sources. One is by air, liquid medical oxygen, that is air liquefaction process. Then we have the oxygen generator plants which work on the pressure swing absorption technology. And then there are homemade oxygen concentrators, which are a type of mini oxygen generation plants. So oxygen is a regulated commodity which must provide at least 82% of pure, free from any contamination, and usually produced from an oil-free compressor. While an industrial grade oxygen is the same level of oxygen, but it is produced from not an oil-free compressor. So there can be impurities and there can be associated oil in that oxygen. How do you maintain the oxygen supplies of your hospital? They are usually maintained with the help of liquid medical oxygen, which is called LMO, cylinders, oxygen generator plant, or oxygen concentrators. Cylinders are most commonly used. There are multiple types of cylinder, multiple labeling. You must have the lecture yesterday or tomorrow or today morning only, depending upon the cylinders, the yoke assembly and all these things. I'm not going in details of those. You require a strong supply chain. This is how a cylinder manifold works, and your oxygen is supplied to the hospitals. Then you should always remember, oxygen supports combustion. So you should, whenever you are using a cylinder, it is actually a bomb. You should always use it with certain precautions. Cylinders should always be in upright. They should never be rolled on the ground. There should not be any there should not be any flame source or heat source when you are using cylinders. Cylinders have high pressures of oxygen. So they should be opened only by trained staff. If you are going to open it suddenly, there will be a gush of oxygen, and that can be a high pressure, and that can lead to accidents and even death to some people if it is not adequately trained. Then liquid medical oxygen, it is oxygen which is stored at minus 183 degrees Celsius. 1 liter of liquid oxygen is equivalent to 860 liters of gaseous oxygen at normal temperature of 15 degree at 1 atmosphere. And full 10,000 liters capacity cylinder vessel is equivalent to around 1200 jumbo cylinders. But as I said, the oxygen supports combustion. Whenever you require an LMO for a hospital, you required an approval from the Petroleum and the Explosive Department of the country, that is PESO. Then oxygen generator plants. मोदी जी ने पूरे भारत में खूब सारे ऑक्सीजन जनरेटर प्लांट लगवाए कोविड के बाद, ठीक है. So that works on the pressure swing absorption technology. They supply with purity of 90 to 96%. Only drawback is that they require electricity to function, and they produce a lot of noise. What they do is they take the atmospheric oxygen, concentrate the concentration from 21% to 90%, and there is a zeolite absorber, and they give that to the hospital supplies. So this is the concept, how it works. You have a compressor, you have a filtration, and then you supply the oxygen. Not much in details. Then the other thing which you should know is what is the high pressure oxygen source and what are the low pressure oxygen source. So high pressure oxygen source are capable of delivering oxygens at pressures of more than 50 psi or 4 bars. High pressure oxygen is required for most of the ventilators, which are your invasive ventilators, your workstations. They usually work on high flow pressures, high pressure oxygen sources. While low pressure oxygen sources, these include oxygen which are delivered from the peripheral flow meter, which is attached to the wall, or the portable oxygen concentrators. Then oxygen concentrators, they are a part of mini PSA plants. They work on the same principle of the oxygen generator plant. They are also electricity driven and they produce a lot of noise. So if you are managing your patients in wards, 2 or 3 patients are on oxygen concentrators, then your monitoring may be hampered because of the extreme noises of the oxygen concentrators. Then no drug is without any side effect. Even oxygen is not without any side effect. And there should be some good clinical practices which you should apply when you are giving oxygen to your patients. So the unnecessary use of oxygen causes claustrophobia, it causes dehydration of mucosa, it causes hoarseness of voice, and in some patients negatively affects patients' mobilization, food and fluid intake, and communication. So this is a recent article of 2018. And you should always try and attempt to save oxygen. So good clinical practice is always required. Whenever you prescribe oxygen, whenever you ask your healthcare workers, supporting staff to give oxygen to a patient, give them a good guideline how to give, which device to use, which flows to use. Just don't randomly assign them to give oxygen. Oxygen लगा दो. Oxygen लगाने के साथ flows भी बताइए, कौन सी device use करनी है वो भी बताइए. हर patient अलग होता है, तो हो नहीं सकता कि आपके patient same हो. हर पेशेंट की ऑक्सीजन रिक्वायरमेंट भी सेम होती है और किसी पेशेंट को ऑक्सीजन लगाएं तो पल्स ऑक्सीमीटर से उसकी वैल्यूज जरूर मेजर करें. दैट इज वेरी इंपॉर्टेंट. एंड इफ देयर आर एनी लीकेजेस यू शुड ऑलवेज ट्राई टू रेक्टिफाई देम. थैंक यू एंड दैट इज ऑल अबाउट माय टॉक. थैंक यू.
Thank you, Dr. Tanmay. It's a very nice and very elaborated talk on oxygen therapy. Any questions? Audience? PG, any questions?
If you have any question, you can write my email. That was on the first slide. You can ask there, I can answer them.
And that is there is a one comment also. Don't try to maintain the saturation from 98 to 100%. Even though 94, 95% saturation is also a good, because the below 90% saturation, the oxygen dissociation curve going to this sides, and there may be a chances of low partial pressure of oxygen. So the saturation of 94, 95% is very good enough for any kind of patient. Okay, if you build up the hemoglobin, especially in the patients of known case of coronary artery disease, especially you have to build up the hemoglobin at least to 10 gram. Then even though in these patients also that saturation is 94 to 95% SpO2 is good enough. Any questions? Okay, next.
Our next speaker is Dr. Vipin Singh. He's one of the pillar of critical care medicine in KGMU, and he spent most of the time working with sick patients. He's associate professor in Department of Anaesthesiology, and his area of interest is obstetric critical care and anesthesia.
A very good evening, everyone. Talk of the town is COVID-19, and my discussion topic is management of severe pneumonia and ARDS, COVID-related only. So you are dealing with the COVID-19 for the last 2 years, but I am sure you are still confused regarding treatment, when to start and when to stop your medications, because virus is changing very rapidly and its targets are changing. So I am sure you are still very confused regarding treatment of COVID-19. So outline of my talk is what is the pathogenesis of COVID-19 and what are the stages of COVID-19 pneumonia and clinical spectrum and what are the various therapeutic options and therapeutic management according to the severity of COVID-19 and oxygenation and ventilation in case of ARDS. So basically COVID-19 virus is a primary disease of lung. It initially starts with the involvement of lung, because SARS-CoV-2 virus has affinity to the ACE2 receptors. And ACE2 receptors are found on type 2 pneumocytes. These are type 2 pneumocytes. And ACE2 receptors are found on these type 2 pneumocytes. And these SARS-CoV-2 virus get attached to these ACE2 receptors. ACE2 receptors are also found in GI tract too. So sometimes you get diarrhea-like symptoms. So after attaching to the type 2 pneumocytes ACE2 receptors, it damages the alveoli. And in the same time, it activates the dendritic cells, macrophages, mesenchymal cells. So with the activation of these cells, it activates the acute phase reactants. There will be release of acute phase reactants, and these acute phase reactants leads to multiple organ damage. So this is the pathogenesis of COVID-19. You can see the evolution of COVID-19. First stage is early infection, second one is pulmonary phase, and third one is hyperinflammatory phase. You can see here the after the median incubation period of 5 to 6 days, you will get mild symptoms or early infection. After the 5 to 7 days of early infection, you will land up in pulmonary phase. That is the stage 2. And after 10 or 2 weeks, there will be hyperinflammation phase. So you can see here the replication starts here and stops here around 2 weeks. 10 to 2 weeks, there will be end of replication phase. While the inflammatory stage starts after 4 to 5 days of early infection. So this pulmonary phase is amalgamation of replication phase and inflammatory reaction. So in case of pulmonary involvement, you have to start both antiviral drugs and anti-inflammatory drugs. So this is the evolution of COVID-19 pneumonia. So you can find various symptoms in COVID-19. Patient could be asymptomatic or could have a mild illness like fever, cough, sore throat, malaise, headache, muscle pain, nausea, vomiting, diarrhea, loss of taste and smell. But he or she will not have shortness of breath, dyspnea or abnormal chest imaging in mild illness. While in case of moderate illness, there will be involvement of lower respiratory tract. But on imaging, you can find pneumonia, but saturation still will be more than 94% on room air. While in case of severe illness, saturation goes down to less than 94% on room air. PF ratio will be less than 300 and respiratory rate will be more than 30 breaths per minute, and on CT or X-ray there will be more than 50% involvement of lung. While in case of critical illness, there will be a complete failure of respiratory system. Patient may be in septic shock or in multiple organ dysfunction syndrome. So these are the symptoms you may find in COVID-19. These are the treatment options like antiviral, monoclonal antibodies, immunomodulators, and antithrombotic therapy. So this is the antiviral drugs: remdesivir, SCQ, azithromycin, interferon, ivermectin, lopinavir, ritonavir. These are basically antiviral drugs you started using in phase 1 of COVID-19. But after trials, many studies, it has been seen that only remdesivir is effective. Still, it is not going to reduce mortality rate, but it enhances the recovery time. So among these antiviral drugs, only remdesivir is found to be effective. Second one is monoclonal antibodies. What are the indications of monoclonal antibodies? Basically, studies have shown that if patient is immunocompromised and you think that patient may land up in severe disease in future, so in that case you can use monoclonal antibodies as a pre-exposure prophylaxis or post-exposure prophylaxis. While in the initial stage we were using convalescent plasma and IVIG. Basically, after a placid trial, it has been went off that this is not effective. IVIG basically pediatricians are using in case of multi-system inflammatory syndrome in children, but not effective in adult cases. These are the immunomodulators that are basically most effective, and it reduces the mortality rate. So among these immunomodulators, only we are using corticosteroids, IL-6 inhibitors, and JAK inhibitors. And recovery trial shows that corticosteroid are basically reduces the mortality rate, 28-day mortality rate, and most effective in case of patients who are mechanically ventilated. And antithrombotic therapy, basically there are multiple options like unfractionated heparin, low molecular weight heparin, antiplatelets, and oral anticoagulants. But preference is given to the low molecular weight heparin due to its bioavailability and lesser side effect and lesser need of monitoring. And these supplements we were using in first wave, vitamin C, vitamin D, and vitamin zinc. But these supplements are not found to be effective in case of SARS-CoV infection. So these are the therapeutic management of hospitalized adults based on the disease severity. If patient is hospitalized and not on supplemental oxygen, then you can start remdesivir, but they are against use of dexamethasone. Dexamethasone must be started if there is requirement of oxygen, especially mechanically ventilated patients. So if patient is hospitalized and requires supplemental oxygen, you should start with remdesivir and dexamethasone, or dexamethasone plus remdesivir, or dexamethasone alone. Remdesivir basically effective only in case of if patient is symptomatic within less than 10 days. After 10 days, you will not found replication phase. That's why it is recommended to start remdesivir within 10 days only. If patient requires high oxygen therapy like high flow nasal oxygen or on mechanical ventilation or NIV, you should start dexamethasone plus remdesivir. You can use other immunomodulators like IL-6 inhibitors and JAK inhibitors if you think that patient is rapidly deteriorating and there is profound inflammation. So you can add these IL-6 or JAK inhibitors along with corticosteroids. So you can start dexamethasone plus remdesivir plus JAK inhibitors or IL-6 inhibitors, not both. In case of mechanical ventilation or ECMO, dexamethasone plus minus IL-6 inhibitors or JAK inhibitors are indicated. There is no role of remdesivir. So if patient is going to be hypoxemic or on mechanical ventilation. Goal of oxygenation is to maintain saturation between 92 to 96%. And if you find that patient is going to be respiratory failure, you have multiple options like high flow nasal oxygen, NIV, intubation and mechanical ventilation or ECMO. But if there is no indication of intubation, you can choose between high flow nasal oxygen plus NIV or NIV. But it is found to be use high flow nasal oxygen as compared to NIV. Means HFNO is showing better result as compared to NIV. In case of mechanically ventilated patients, you have to use low tidal volume. It is almost universal to use low tidal volume and to keep P plate less than 30 centimeter of H2O, and there should be conservative, preference should be conservative fluid strategy. And till now, studies show there is no benefit of inhaled nitric oxide. So they are still against inhaled nitric oxide. In case of severe ARDS, there is preference of high PEEP over low PEEP. But if you see there is low lung compliance, then only high PEEP will be effective. And if there is PF ratio is less than 150, then you should use prone ventilation 12 to 16 hours per day. Plus, to synchronize the mechanical ventilation, you have to use intermittent or continuous dose of muscle relaxant. So this is the treatment strategy in case of severe ARDS. Rest supportive treatments are according to 2021 surviving sepsis guidelines. So this is the total of my topic. I want to ask some questions like how much steroid you are using in case of COVID-19. You are treating COVID-19 for last 2 years, but I think you are still confused when to use steroid, in what dose, when to stop remdesivir. So what dose you should use in case of dexamethasone? डेक्सामेथासोन का कितना mg यूज करते हो, या फिर मेथाइल प्रेडनिसोलोन यूज करते हो, या फिर प्रेडनिसोन यूज करते हो, या हाइड्रोकॉर्ट यूज करते हो? 2 साल से, पिछले 2 साल से ट्रीटमेंट कर रहे हो सब लोग कोविड-19 का, अभी भी आपको आइडिया नहीं है कि डेक्सामेथासोन कितना देना है. अगर डेक्सामेथासोन नहीं दे रहे हो, रेमडेसिविर के साथ मेथाइल प्रेड देना है, डेक्सामेथासोन नहीं देना, क्या स्ट्रेटजी है, क्यों नहीं देना है? या रेमडेसिविर आप कहते हो कि एलएफटी डिरेंज हो रहा है या फिर आरएफटी डिरेंज हो रहा है, तो कितने एलएफटी और कितने आरएफटी पे आपको बंद करना है? मुझे पता है कि किसी को नहीं पता है. अभी पिछले 2 साल से सब ट्रीटमेंट कर रहे हैं और किसी को डोज नहीं पता है. कोई मेथाइल प्रेड ओरल दे रहा है, कोई 16 mg बीडी दे रहा है, कोई 32 mg बीडी दे रहा है. डेक्सामेथासोन 6 mg आईवी, ओडी, बीडी, बहुत एक्सपेरिमेंट हो रहा है अभी भी, है ना. रेमडेसिविर, अचानक से रेमडेसिविर के साथ डेक्सामेथासोन नहीं देना है, मेथाइल प्रेड देना है, तो क्या रीजन है इसके पीछे? कि जस्ट सर ने बोल दिया तो ऐसे करना है. रेमडेसिविर से अगर एलएफटी डिरेंज हो रहा है तो कितने एलएफटी डिरेंज होने पे आपको स्टॉप करना है? या फिर आरएफटी डिरेंज हो रहा है तो आरएफटी कितना डिरेंज होगा तो स्टॉप करना है रेमडेसिविर? कोई आइडिया नहीं ना. 2 साल से यही ट्रीट कर रहे हो. डेक्सामेथासोन 6 mg आईवी, ओडी और ओरल, ठीक है. ओरल या आईवी, ओडी देना है. और 6 mg का रिप्लेसमेंट अगर देख रहे हो प्रेडनिसोलोन देना है, प्रेडनिसोन या मेथाइल प्रेड देना है, तो प्रेडनिसोन 40 mg देना है, मेथाइल प्रेड 32 mg देना है, हाइड्रोकॉर्ड 160 mg देना है। ठीक, रेमडेसिविर से एलएफटी डिरेंज हो रहा है तो कितना डिरेंजमेंट के बाद स्टॉप करना है? एएलटी एसटी कितना डिरेंज होगा तो स्टॉप करना है? 10 टाइम्स ऑफ अपर लिमिट ऑफ नॉर्मल। ठीक है, आरएफटी कितना डिरेंज होगा तो स्टॉप करना है? ईजीएफआर लेस देन 30 ml पर मिनट है तो स्टॉप करना है। उसमें भी अभी कंफ्यूजन है। ठीक है, तो ये सारी चीजें क्लियर कर लो। थैंक यू।
Thank you, Dr. Vipin, for clearing some gray areas in management of COVID ARDS. Any questions from the audience? Thank you. Thank you.
Thank you, Dr. Vipin. And there is a one comment. If you are doing the ventilation for the COVID pneumonia, especially ARDS patients, so the ARDS patients में जब आप वेंटिलेटरी स्ट्रेटेजी देखते हैं तो क्या टारगेट्स आपके होते हैं? कोई एनीवन? क्या टारगेट्स आप रखते हैं कि पेशेंट को वेंटिलेट करना होता है तो हमारे पास क्या टारगेट्स होते हैं? कोई बता पाएगा? किसी भी पेशेंट जो कोविड निमोनिया स्पेशली या ARDS पेशेंट्स को आप वेंटिलेट करते हैं तो क्या टारगेट्स हम अचीव करने के लिए हम करते हैं कि हाँ इस पेशेंट को वेंटिलेट करना है तो ये टारगेट एटलीस्ट हमारा होना चाहिए? आप मॉनिटर्स देखते हैं, मॉनिटर्स में देखते हैं या वेंटिलेटर्स की स्क्रीन पे देखते हैं कि हाँ ये टारगेट हमने अचीव कर लिया, अब हमारा पेशेंट एडिक्वेटली वेंटिलेट हो रहा है। तो सबसे पहले जो है सैचुरेशन जो आप SpO2 वैल्यू देखते हैं एटलीस्ट 92 to 94%, पी प्लेटू जैसे डॉक्टर विपिन ने बताया लेस देन 30 होना चाहिए, और एक ड्राइविंग प्रेशर जो नया आया है वो लेस देन 15 होना चाहिए, और आपका जो PO2 वैल्यू है 55 से 80 एंड PCO2 वैल्यू है 35 to 40 के बीच में होना चाहिए। ये हमारे टारगेट्स होते हैं जिसको हमें अचीव करना होता है, और ये टारगेट यदि अचीव नहीं हो पा रहे हैं तभी हम वेंटिलेटरी स्ट्रेटेजी को चेंज करते हैं। तो मैकेनिकल वेंटिलेशन इज ए आर्ट। जो पेशेंट्स, जब कोई भी पेशेंट जो है उसका जो सिनेरियो जब सीवियरिटी की तरफ जाता है तो उसमें जब पेशेंट्स deteriorate होता है, it not because of the ARDS, not because of the pneumonia, it is because of the ventilator induced lung injury, जिसको विल्ली कहते हैं। यदि आपका वेंटिलेटरी स्ट्रेटेजी प्रॉपर नहीं होगा, आपने एडिक्वेट टाइडल वॉल्यूम जैसे बताया डॉक्टर विपिन ने 6 ml पर केजी नहीं दिया, मोर देन 6 ml पर केजी दे दिया, चांसेस ऑफ बैरोट्रॉमा, चांसेस ऑफ बायोट्रॉमा, चांसेस ऑफ वॉल्यूट्रॉमा होने के चांसेस हैं, जिसकी वजह से पेशेंट को वेंटिलेटर इंड्यूस लंग इंजरी होगी और पेशेंट्स मोर एंड मोर वेंटिलेटरी डेज स्पेंड करेगा और चांसेस और डिटेरियोरेशन मोर हो जाएंगे। तो ये हमें पता होना चाहिए कि हमें उसकी आर्ट आनी चाहिए किस तरह से हम ऐसे पेशेंट्स को मैकेनिकली वेंटिलेट करना है। ओके, थैंक यू। एंड आवर नेक्स्ट स्पीकर इज डॉक्टर तपस सिंह। ही इज असिस्टेंट प्रोफेसर डिपार्टमेंट ऑफ एनेस्थीसियोलॉजी SGPGI Lucknow. Area of interest of Dr. Tapas is solid organ transplant anesthesia, ultrasound guided compartment block and regional anesthesia. And he will be delivered on the talk on the anesthesia implication in CKD patients. Hand over to Dr. Tapas.
Thank you, sir, ma'am. Good evening, everyone. I have approx 15-minute talk and I have some 20-ish slides. So, सभी थक गए, मैं भी थक गया हूँ, पर थोड़ा packed session होगा, please perk up. बहुत सारी चीज़ें, I am a lazy PowerPoint presenter, बहुत सारी चीज़ें मैं लिखता नहीं हूँ अपनी slides में, तो प्लीज़ कीप अप, सुन लीजिएगा, बिकॉज CKD इज़ अ टॉपिक जिसमें बहुत सारी इट्स अ टॉपिक विच इज़ नेबुलस, देयर आर लॉट ऑफ कंसेप्ट्स, तो हो सकता है बहुत सारी चीज़ मैं आपको बोल दूँ जो आपके एग्जाम में आपके काम में आ जाएं, या यू विल फाइंड इट यूजफुल व्हाइल यू विल बी गिविंग योर लॉन्ग केस प्रेजेंटेशंस एंड ऑल. सो first things first, whenever you approach a CKD case, if you are going to present a CKD case, there are two tables which will always haunt you for the rest of your life. They do haunt me, right? One is this table, the stages of CKD. What is CKD? Whenever GFR falls less than 90 ml. And trust me, it looks simple, but you will bungle up in your staging of CKD. So please make sure that your CKD grading is always on the point. And on a related topic, when do we start a transplant workup for a patient? When the ESRD, the GFR falls less than 30 ml. And when the transplant is indicated, when GFR falls less than 20 ml. One more table, which if you're going to work in intensive care, if you're going in post-operative, managing your post-operative patients, this table will also always chase you all your life. That is the staging of AKI. If I were you, I will always stick to the latest criteria, that is the KDIGO criteria. If you look at the KDIGO criteria, it's pretty simple. And if there is one more criteria, which is this definition of AKI is offered by the International Club of Ascites. Now, if in the KDIGO criteria, if you remove the urine output and if you remove the 7 days, that is here, my laser is not working very well. No issues, no issues. I hope the cursor can be seen here. No problem. So, yeah, thank you, it's working. So instead of this 7 days, if you make it 3 months, you will get your International Club Ascites AKI definition. Otherwise, if you remember this KDIGO criteria of AKI, you are always, it's easy to remember and you can remember it well. And this is something which you have to do it yourself. The one point you should always remember is that even a serum creatinine rise of 0.3 milligram per deciliter within 48 hours is considered as AKI. So what you usually in ICU, you might dismiss off as variation of your normal lab, the patient is actually stage 1 AKI. Right, what happens in CKD pathophysiology? If you're going to write a long note, if you're going to present a case, you will get questions on pathophysiology. Since time is less, we will just go quickly through it. Fluid imbalance, the kidney is one organ which is responsible for taking care of your pH, taking care of the water excretion, the water regulation. So fluid imbalance and dyselectrolemia will be there. Metabolic acidosis, kidney also regulates the pH. So metabolic acidosis will be there. Uncontrolled hypertension will be there due to uncontrolled activation of the RAS system. As and when the GFR falls, there is tubuloglomerular feedback, and this activates the JG cells to cause a renin release. And this renin release causes the RAS axis activation, and this eventually leads to uncontrolled hypertension. Due to all CKD patients have elevated inflammatory markers, they also have tendency for hypertriglyceridemia, and due to the factor that these patients always have hypertension and left ventricular hypertrophy, so these patients might be prone for developing ischemic heart diseases. And due to uremic there will be bleeding tendencies, plus there might be bone marrow suppression due to superimposed infections. So due to platelet dysfunctions and bone marrow suppression, there will be bleeding tendency in these patients. Anemia, it's a no-brainer. There is nutritional cause, and the most important cause is lack of erythropoietin release from the kidney. So anemia will be there. Most of the CKD patients which you will encounter, they usually are adapted for anemia. 6 to 7 gram per liter hemoglobin is fine for them. They have almost fairly good enough functional capacity at that hemoglobin, which is too less for us, it's okay for them. And autonomic neuropathy, this is something which you should always elicit in your history. Uremia causes neuropathy, so the patient might be having pre-existing neurological sensory weakness in the periphery of your limbs, which should be documented in your pre-op cases because it is important from medical legal point of view. And autonomic neuropathy can mask whenever a body is subjected to stress, the cardiovascular system will not cope up due to autonomic neuropathy. So make sure you ask questions like whether the patient might not tell you, but if you ask him pointedly, patient might give you a history of syncope that he passed out in while he went to his washroom. So that was nothing but autonomic neuropathy. And if the examiner is very much interested, there are 5 tests actually for autonomic neuropathy. 3 for systolic, 2 for diastolic. If I were you, I would remember them if I can. Right, and CKD has also a great play on endocrine system. Due to CKD itself, there is peripheral insulin. Diabetes causes CKD, and CKD also causes peripheral insulin resistance. So one can cause the other. And due to which there will be abnormal glucose tolerance, and there might be requirement for exogenous insulin. Sometimes what happens, patient comes for surgery or CKD, and during his routine workup, it is discovered that patient is also hyperglycemic, and eventually he is a diabetic. Due to poor phosphate excretion and poor vitamin D metabolism, there is always secondary hyperparathyroidism. The phosphate doesn't get excreted well, the phosphate level keeps rising, there is release of parathormone. Due to release of parathormone, there will be increased recruitment of calcium from the bones, which will lead to weakening of bones, and there will be pathological fractures. So if patient has history of easy fractures, this again is a medical legal point, because while during transporting or during shifting the patient in post-op period, patient might develop fractures. We have already covered this point, that is reduced erythropoietin production causes anemia. So what points you will note when you take a CKD history? You will look for the cause of CKD. If the cause is of chronic interstitial nephritis, that is usually the patient suffers from some kind of vasculitis. So these inflammatory markers will be raised. There is a small possibility that he might be suffering from other autoimmune diseases. What is the duration of disease? Longer the duration of the disease, more certain you can be that uremia is causing symptoms in other organ systems also. His cardiac system might be compromised. He might be having neuropathies. If the patient is on regular treatment, you are more or less likely to find an optimized patient. Most of the time, patient gets discovers a CKD. It happens in Indian population, especially in population who tend to misuse the NSAIDs. Patients come to hospital, and first time he discovers that patient has an elevated creatinine. This kind of patient might surprise you in your post-op, in your intra-op and post-op period. What is the urine output? A CKD patient who is having a urine output is somewhat easier to handle than a ESRD patient. At least your fluid overload is one of your lesser concerns. And what is the dialysis requirement? One question you should always ask your patient: what is the frequency of dialysis, and what happened to them when they missed a dialysis? Most of the time, the patient will tell you, sir, I usually get my dialysis done in 3 days, twice weekly. And one day I was having this social commitment and I didn't get a dialysis. I got breathless after 2 days. So it kind of gives you an idea how fragile the patient is, how less his body can cope with your own intervention or the surgical intervention. During examination, pre and post dialysis will actually tell you how much amount of fluid has been removed. Sometimes it's happened, many times you will find a dialyzed patient who has been posted for surgery. Due to the assessment of nephrologist, what they will do, suppose they will remove 2 liters of ultrafiltrate. You will induce this patient, he will immediately crash on table. If you, sometimes you will find the patient is under-dialyzed because only 700 ml of ultrafiltrate was removed. So you should always check the pre and post-weight dialysis. Anything greater than 2 kg loss is significant. Signs of fluid overload and dehydration, you will look. If there is an AV site, please make sure during an examination to document it. Do tell the local examination, and in your intra-op notes, please mention that you took care of the AV fistula site and function. Because somehow in the post-op period and this may due to hypotension or due to any physical damage, suppose many times people do not know, they will put a BP cuff over this side and it will cause blockade of AV fistula. Then we will all land up in trouble, because then questions will be asked. Obviously, you look at the blood pressure, pulse, heart sounds, pericardial rub. Why? Because patient might have pericardial effusion. This pericardial effusion can get infected and it can turn into pericarditis. You will look for crepitations for superimposed infections, or more commonly fluid overload. Fine crepitations you will hear. Neurological, uremia might cause neuropathy and in severe cases encephalopathy. Investigations, obviously you will have your renal function test. If you're going for a major surgery, it makes with major blood loss, you will be benefited from functional coagulation tests like TEG or platelet function assays. I have personally in my life, I have never got it done, but TEG is something which is accessible nowadays. If you have access to it, it will tell you a story. ABG is also important because in ABG you will, especially if your patient is already on taking soda bicarb tablets, because then you need to look at the base excess, how fragile is he metabolically. In pre-op orders, when you finally give clearance to the patient and you give pre-op orders, all of your ASA NPO guidelines are for normal patients. Please make sure this, due to gastroparesis, due to uremia, which causes gastroparesis, and autonomic neuropathy, these patients will have delayed gastric emptying. So please make sure that you have a conventional 8 to 10 hours NPO guideline, at least for solid fluids. Patient will be on 2 or 3 antihypertensives. Most of the antihypertensives are controlled in the perioperative period. But if you are asked to be careful about one drug, I will call it alpha blockers, especially short-acting alpha blockers, which are not, these retard formulations are there. Usually many of the patients you will find, they're taking retard formulations. That is, like Prazosin will be active for 24 hours. If Prazosin he is taking for TDS, you can always ask them to skip that morning dose. In major surgeries, what we have noticed that it causes profound hypotension not responding to noradrenaline. Antipruritic drugs, it doesn't happen here. We somehow tolerate, our patients tolerate pruritus, but if you see in Western literature, many times due to pruritus they're on naltrexone. Now, naltrexone we all know is a opioid antagonist. So your intra-op and peri-operative pain management becomes challenging. So please make sure that you document this. Again, soda bicarb tablets. If a patient is soda bicarb, the common brand name is Nodosis. If the patient is taking soda bicarb tablets, that is because nephrologist seems that he is metabolically fragile. So this patient will be more challenging compared to a normal patient. If a patient tells you history of that water restriction has been told for him, this patient has tendency to go into fluid overload, so we need to be careful in this patient. What pre-medications you will perform, you will advise, I'm sorry. In benzodiazepines, remember OLTM, oxazepam, lorazepam, temazepam, and midazolam, obviously. So these do not have secondary active metabolites. These are short-acting, you will prescribe those. I like to go with lorazepam and alprazolam. And if the patient is already not on pantoprazole, I will definitely go with ranitidine, morning and, night and morning dose. If somebody questions you on this, because ranitidine has got better acid suppression, on first dose acid suppression is greater than pantoprazole. Pantoprazole usually will take 2 to 3 doses for maximal acid suppression. So if the patient is not on pantoprazole, prescribe him Rantac. And one more fun fact is that even these pantoprazole and all the PPIs have been implicated in causing CKD, and their CKD is reversible. So if the patient is already not on PPI, maybe his nephrologist has forbidden him and he is maybe on taking ranitidine, then please prescribe Rantac. Again, on pre-op re-evaluations, the patient is dialysis dependent. Please note the timing. When was the last dialysis done? Suppose if patient is getting dialysis done every twice a week and you are getting him operated on the 3rd day, that is 2 days have already elapsed, be careful about the fluid overload. Usually dialysis which are done before surgery are heparin free. Please make a note of it. Even if it's not heparin free, if 6 hours have elapsed, we are safe, good to go. Please document the ultrafiltrate and weight change. It will tell you how much leeway you have regarding the fluid management. If you want, you can get your electrolytes and coagulation profile repeated to detect residual anticoagulation and the electrolytes. Plus, never give your electrolyte samples just within 4 to 5 hours after dialysis, because a lot of fluid shifts it will be taking in during that point. At that point of time, it is usual to have hypokalemic results. Dialysis-related complications. Any point of time, patient may develop cerebral edema, which is commonly known as dialysis disequilibrium syndrome. And this cerebral edema will be manifested as headache, personality changes, and in severe cases, patient will suffer from seizure itself. Always look for what is the site of dialysis. You should elicit in history. Now the patient might be dialyzed from the fistula, but previously he might be having a permacath in his IGV. Now this IGV might be completely blocked. So if you are planning a major surgery, please scan it before, plan your invasive lines beforehand. It always helps before going for surgery to know your surgery. The more disruptive the surgery is, the more there is chance for fluid shifts, the more problem you are going to face and more careful we need to be. if there is risk for kidney injury. If the patient is already on ESRD, that doesn't mean that patient still can't develop furthermore kidney damage. There's always a possibility of acute and chronic developing. So even for ESRD patients, you need to follow the same bundle, which is the KDIGO bundle. Please make sure this KDIGO bundle is for AKI. Never tell it that this KDIGO bundle is for CKD. KDIGO bundle is for AKI. But the concept remains same for all kidney cases. What you will do, this is all common sense. If you have ever seen a nephrology consultation, this is all they will write. Avoid nephrotoxic drugs. This is verbatim for them. They will, even in sleep, they will write this same consultation. Avoid nephrotoxic drug, ensure volume status, perfusion pressure, consider functional hemodynamic monitoring, avoid hyperglycemia, monitor serum creatinine and urine output. Regarding functional hemodynamic monitoring, this has been recently added in 2018. By functional hemodynamic monitoring, they mean the dynamic indices of preload or your invasive arterial lines. So if the clinical situation demands, you can go for functional hemodynamic monitoring. What almost all induction agents are safe to use, the current induction agents we use commonly. The large volume of distribution, patient might be, they might, due to the fluid retention, there will be a large volume of distribution. So the dose of induction agents will be greater. Due to the uremia-induced autonomic dysfunction, or as I previously said, the patient might be too dry post-dialysis, there might be precipitous fall in BP during induction. So we need to go for a slow titrated induction. What needs to be titrated? Eye opening or verbal response, depending on whatever you are using, thiopentone or propofol. Opioids, you don't use morphine and pethidine because they accumulate in renal failure. Fentanyl, sufentanil are safe, good to go. Muscle relaxants, better use atracurium and cisatracurium. Even with steroidal muscle relaxants, you get approx 60 to 40% of excretion from liver. They're also okay. If you don't have these or in a dire scenario, you can use that also. But I would not encourage infusion or repeated doses of steroidal muscle relaxants. Succinylcholine, again, we can use, but be cautious about hyperkalemia. Renal failure patients might have pseudocholinesterase deficiency. In our population, it is rarely seen, but this is something which you all should know. Reversal is excreted by renal failure, but in doses which we use, it doesn't matter. All inhalational agents are safe. There are some concerns regarding sevoflurane and compound A, but these are all animal studies, and now they have all been disproven. NSAIDs you cannot use even in ESRD patients because you cannot think that kidney is already gone, let me use NSAIDs. Because as I said earlier, acute and chronic is always there. So you'll use paracetamol with weak opioids. Most commonly used is tramadol. Tramadol in a normal patient, maximum daily dose is 400 milligram. In CKD patients, it's 200 milligram. And this is the most vexing question of all, what IV fluids are meant to be used. Right now, I'll just simplify it. These papers you can ignore. Avoid colloids, especially starches. No matter what evidence is emerging, right now all regulatory authorities are equivocal on this, that avoid colloids and starches. If colloid at all has to be used, it is 5% albumin. Please use 5% albumin. And if you are using crystalloids, it is sensible to prefer balanced salt solutions. Why we prefer balanced salt solutions? Because high chloride containing solutions like sodium chloride tend to, it's a lot of physiology in it, but they cause renal vasoconstriction due to, like I mentioned before, the macula densa causes efferent arteriole constriction. So due to this efferent arteriole constriction, GFRs again drop. So low sodium chloride containing solutions should be used. That is, balanced salt solutions should be preferred. The consensus is, if you can use end goal directed fluid therapy, please use it. If you are not using end goal directed fluid therapy or any marker for it like PPP or SVV, if you're using classical fluid therapy, try to achieve a equivocal or slightly negative fluid balance. If your patient is of ESRD, please make sure that at least his fluid balance doesn't go higher than the ultrafiltrate which was removed in the last dialysis. More importantly, most of the common cases you will face in your daily life will be mild and moderate CKD patients. In these patients, it is very vital that in name of fluid restriction, you do not cause hypovolemia, because hypovolemia can again cause AKI. So there is no standard protocol. Regarding balanced salt solutions, earlier there used to be concerns like hyperkalemia. This has been disproved because they preserve renal functions better. So there is no rise in hyperkalemia. So there's no increase in the incidence of hyperkalemia at the concentrations, that is 4 milliliter per liter of fluids which are being used. What are the transfusion triggers? This is one question you will again face many times when you are giving your viva, because the usual transfusion trigger 7, 8, whatever you read, or for cardiac patients 10, is most of the ESRD patients you will find is you will start with a hemoglobin of 6. So you are already below the transfusion trigger. So there was this paper, I could not find any new update to this paper, which was published in BMC Nephrology. And this was for critical care patients, CKD patients, and critical care. But I believe they hold valid for patients who are undergoing surgery also. So if it's a non-hemorrhage, if it is not a scenario of massive hemorrhage or massive transfusion protocols are not activated, if it's non-hemorrhaging situation, then there is no trigger. You will transfuse blood only if the patient becomes symptomatic. If the patient starts to get breathless, there's too much tachycardia, if the patient develops chest pain, or if the patient is under anesthesia and you start seeing ECG symptoms, then you will start transfusion. So there is no trigger. You cannot say that below 5, I will start transfusion without looking at the patient clinically. For platelet, the limits remain the same, 10,000, 50,000. If you're planning a surgery, 50,000. If prophylactic infusions are recommended at 10,000. Even with normal platelet numbers, if you are encountering bleeding, especially capillary bleed, that is capillary the patient is oozing diffusely, then in these cases you might suspect uremia-induced platelet dysfunction, and a desmopressin dose of 0.3 mics per kg given over in infusion over 20 minutes. I've never used it. It's not available in my institute, but it is what you guys should keep in mind. FFPs are recommended if there are clinical signs of bleeding. And obviously, you will keep in mind the volume overload. This slide is not related to your CKD patients, but these are definitions for massive transfusion protocol. Because how do you define massive transfusion? Please don't click photos. You can. I'll give you the PPT itself. Somebody will share it with you. So these are the definitions, because I believe if you keep on asking these, some might ask you regarding what is the definition of massive transfusion. Intraoperative concerns, I have been honing and repeatedly saying this: electrolyte and fluid imbalance, blood loss, and delayed extubation. Delayed extubation can be due to pulmonary edema, due to delayed metabolism of drugs. Pulmonary edema again is a complication. Post-op analgesia, because now for every patient in your exam you have to say one magic word, that is multimodal analgesia, right? And in multimodal analgesia, you do not have NSAIDs. When you don't have NSAIDs, you will turn to epidural, regional anesthetics. Neuraxial anesthetics might be tricky in CKD patients, especially with platelet numbers dipping and you having concerns about the platelet function. Then you can look to truncal blocks. And ma'am will be following, is a better teacher than me regarding truncal blocks. Thank you. Any questions?
Thank you, Dr. Tapas. It was a very nice and a very good talk for CKD patient anesthesia management. Any questions? If then you can.
I would just like to add one point, and that is, you do have a look at what do you say about the cardiac function, because many of these patients will be hypertensive and they will be having diastolic dysfunction. So do have a look at the echo, because then they become very volume sensitive. So that is one, like we learn from our experience, then that they can go into flash pulmonary edema. That's what we have seen in our post-operative patients, and that leads to delayed. So good control of blood pressure, and just know that I would like your comments also on this.
Ma'am, actually 2018 or 17-ish, ACC have given newer guidelines. If a CKD patient is going for non-transplant surgery, you follow the same protocol. Superficial surgery, emergency surgery, go ahead with the risk reduction. Superficial surgery, history is fine, no issues, you go ahead with normal as you treat a normal patient. If the patient is going for transplant, ma'am, then you need to get an echo done. And if that echo, within 1 year, if the patient is getting posted for transplant, and there has been no functional change in the status of the patient, then till 1 year that echo is valid. You need not repeat that echocardiography. And if at all, obviously, if you feel the functional status has changed, patient has developed new onset crepitations, new onset weakness, new onset breathlessness, you will obviously get it investigated. And otherwise, for a CKD patient going for non-CKD for a normal surgery, the protocol remains the same. What you have, I'm sure somebody must be tackling this topic, perioperative management of these cardiac patients going for non-cardiac surgery. So that same flow chart will remain same for the CKD patients also, ma'am. Right. Thank you.
Our next speaker is Dr. Rakhi. She's Associate Professor in Department of Anaesthesiology, Hind Medical College, and her area of interest is pain and palliative care.
Thank you, ma'am, for the kind introduction. Okay. So the last topic of today is truncal blocks. Truncal blocks, mine is somewhat a big presentation, but I'll try to put it in time. So the truncal blocks are relatively newer blocks for analgesia purposes. They have come into play in the regional anesthesia in the last 1 to 2 decades only. They're very useful as for analgesia purposes, especially when the central neuraxis cannot be taken. For knowing about the truncal blocks, we need to know the planes where the anesthesia will be delivered. So the facial planes is a soft collagen containing loose and dense fibrous connective tissue that permeates through the body. So we have the skin, the adipose tissue, the superficial fascia, deep adipose tissue, and the deep fascia. The 3 facial connective layers are superficial, deep, and the muscle-related layers. For our concern, the deep fascia is the most important layer which we need to focus upon. The deep fascia is composed of multiple layers and represent the target for interfacial plane blocks. Why? Because it is a membrane which extends throughout the whole body and is kept until basal tension by numerous muscular attachments. It is devoid of fat and forms sheaths of the nerves and vessels and envelopes various organs. For our purpose, in the truncal blocks, we'll be also dealing with the intermuscular planes where we'll be delivering our analgesic agents. These all are the truncal blocks which I'll be teaching today. Coming on to the pectoralis block, the pectoralis PEC 1 and the PEC 2. Pectoralis blocks are required for analgesia purposes from the anterolateral chest wall surgeries. For that, we need to know the innervation of the anterior chest wall. The innervation includes the 4 branches from the brachial plexus, that is the lateral pectoral nerve, medial pectoral nerve, which give innervation to the pectoralis major and minor, the long thoracic nerve to the serratus anterior, thoracodorsal nerve, which gives innervation to the latissimus dorsi. The lateral and anterior cutaneous branches of the thoracic intercostal from T2 to T6 also give innervation to the whole of the anterolateral chest wall. Pectoralis major is a big muscle coming from clavicle, sternum, costal cartilages and inserting onto the humerus. Pectoralis minor is a small muscle, 3 sleeves from 3rd, 4th and 5th rib and go and attach to the coracoid process of the scapula. So the lateral pectoral and the medial pectoral run in the plane between them and innervate these 2 muscles. Indications for PECS block are, if you have to do a lumpectomy or a superficial surgery of the involving the pectoralis major muscle, or breast expanders or prostheses need to be placed, then the PEC 1 block will be sufficing. PEC 1 is a placement of local anesthetic between the pectoralis major and minor, and that takes care of the medial and the lateral pectoral nerves. For breast surgeries with axillary node dissection, all the other nerves mentioned need to be blocked. And so the local will need to percolate all these nerves also. Where do we give them? This is a cross-section view you're seeing from above the patient. This is anterior, this is the humeral side, this is the medial side. You place your probe in the anterior chest wall. Between the pectoralis major and minor, if you give 10 ml of local anesthetic, long-acting local anesthetic is given for post-operative analgesic purposes. Then medial and lateral pectoral nerves will be blocked, And if you give the, along with this block, if you give 20 ml of local anesthetic in this plane between the minor and the serratus anterior, then that is the PEC 2 block. This plus this. It is an ultrasonographic block. You cannot give it landmark guided. In this, what we do is that patient is in supine position, the arm is abducted. You place your probe in the just inferior to the clavicle at the medial to the coracoid process in a sagittal fashion, in a vertical fashion like this, and then tilt the lower port of the probe in laterocaudal direction, so that you will be visualizing the axillary artery and the vein. Above that, these are the two muscles, pec major and the pec minor. The pectoral branch of the thoracodorsal artery, thoracoacromial artery, is also visualized. And this gives a fairly good chance that you are in the right plane. Why? Because the lateral pectoral nerve is in proximity to this artery. So the pec 1 is given. You slide your probe down and bring it to the level of the third rib. Bring it to the level of the third rib and deposit 10 ml of local anesthetic in this plane. For pectoralis, PEC 2 block, along with PEC 1 block, you slide your probe downwards towards the fourth intercostal space, and then you'll see that another muscle has come up, which is this is the pec major, this is pec minor, and this is the serratus anterior muscle above the fourth rib. So what you do is you bring your needle from medial to lateral side and deposit 20 ml of local anesthetic in this plane, and then withdraw the needle at the level of third rib. Almost the needle will come, and then you deposit 10 ml of local anesthetic here. That will take care of all these nerves which have been told for anterior chest wall innervation. This is the way in which the needle comes and you deposit your drug. This is another diagram in which I just want to emphasize that the PEC 2 block can be given between the pec minor and the serratus, as well as in obese patients in which you think that the ribs are deep enough and you will lose the needle pathway in going from inline position. You can go out of line, hit the rib, and even deposit the drug here. It has been seen in studies that the analgesia is equal. Like if you give in this plane or in this plane, the analgesia is equal. For knowing other blocks, we need to know much more about the innervation of the thoracic wall. You see that the spinal nerves are coming out from the foramen. They give a dorsal sensory and a ventral motor branch. At the thoracic level, this motor branch goes to the through the intercostal spaces. Between the posterior axillary and the mid-axillary line, it gives out the lateral cutaneous branch, which again divides into anterior and posterior branches. At the lumbar level, this is at the abdominal level. What is this plane? The plane is between the transversus abdominis and the internal oblique muscles. That is the transversus abdominis plane. The nerves come out in this fashion only. At the thoracic level, this anterior branch continues and gives innervation to the anterior chest, medial to the midclavicular line, and at the abdominal level, this branch continues, pierces the rectus abdominis between the transversus abdominis and the rectus abdominis, and gives innervation medial to the linea semilunaris. Coming on to serratus anterior plane block, the indications are management of pain in the context of rib fractures. It is a block for the anterolateral chest wall surgeries, and it is a very good block. It gives dense analgesia for those purposes because it consistently blocks the lateral cutaneous nerve of the branch of the intercostal nerve. For thoracoscopic surgeries, thoracotomy incisions, anterolateral chest wall, breast surgeries, and post-mastectomy pain syndromes. So the serratus anterior arises from various slips, 8 to 9 slips from the costal, from the ribs, and goes and inserts to the scapula. Here we can see this is the scapula, this is the rib, this is the humerus, this is anterior, posterior, medial, lateral. And if we deposit any drug, any local anesthetic between the serratus anterior and the latissimus dorsi, if you're able to dissect this plane, then you can achieve the analgesia of all those nerves which I have told. Okay, I think so missed it. The nerves which are present in this plane are the anterior primary rami of the T2 to T9 nerves, the lateral cutaneous branch of the same branches, the longissimus thoracis, the thoracodorsal nerve, and the intercostobrachial nerve. So from T2 to T9, all the lateral cutaneous are blocked. The nerve to the serratus is blocked. The nerve to the latissimus dorsi is also blocked. What you need to do is, it is an axillary block. You need to place your probe above the 5th rib in the axillary plane, and you can place it like this or like this. And this is the site of entry at the 5th intercostal space or the 5th rib above in the mid-axillary line. Your needle needs to go. Where it needs to go? It needs to go between the latissimus dorsi. This is the visualized portion. Latissimus dorsi is there, serratus anterior is there. A 5 to 10 centimeter needle is taken, and local anesthetic is deposited between this plane. Around 20 to 30 ml of local anesthetic needs to be given. It is a big facial plane. So this is the cutaneous distribution of serratus anterior plane block. There are many studies which have been done regarding this, and you can go through them. Coming on to a very important block, that is the transversus abdominis plane block. This is a block for the analgesia purposes of the abdominal surgeries. So we need to know about the muscles. The most superficial muscle is the external oblique, then the internal oblique, then comes the transversus abdominis, and then there is the rectus abdominis. These all form an epineurosis and merge at the linea semilunaris, whereas the transversus abdominis goes inside till the costal cartilages also. So as already told, the spinal nerve comes and lies between the plane, between the transversus abdominis and the inferior oblique muscle. Here again, the lateral branch comes out, and the anterior branch goes, cutaneous branch goes through the rectus to innervate the line medial to the linea semilunaris. So we can see that if any block is given posterior to the mid-axillary line, right, this will not take care of the lateral cutaneous branch. So in a classic posterior tap or a lateral tap, we are not able to achieve the lateral cutaneous branch of the, for a classic lateral tap or a subcostal tap, you are not able to achieve anesthesia of the lateral cutaneous branch. But in the posterior tap, we can achieve it. So this is the innervation of the abdominal wall. The lateral cutaneous branches from T6 to T11 come like this. The rectus anterior cutaneous branches here, and all these need to be blocked. A tap block classically given at the lateral border had been consistently shown to give analgesia purpose infraumbilically only. Now why does that happen? In a cadaveric study, it was seen that the T9 to T12 nerves do enter the tap plane at this level, but the T6 to T8 nerves do not enter the tap plane at this level. They enter somewhat here. This was shown in a cadaveric study. This is the linea alba. This is the mid-axillary line. This is the subcostal margin. You can see that the T9 to T12 are entering before this, but the T6 to T8 are entering after this. So any block given here will only take care of the infraumbilical surgeries, not the supraumbilical. For them, you need to block the nerves around the rectus sheath also. You need to give the rectus sheath block also. So you can see consistent block of the T10 to L1 nerves. So indications for tap block are any surgery involving the lower abdominal wall, bowel surgery, cesarean section, appendicectomy. Tap blocks can be combined with rectus sheath for upper umbilical surgeries. It can also be as a diagnostic workup of chronic abdominal pain. And then the rectus sheath block, as already told, for supraumbilical surgeries, incisional hernia repair. All these are indications for rectus sheath block. So, okay, tap block is a loss of resistance block. Okay, so apart from ultrasound, you can also give it by a blunt needle. So in an OT, what is available? A toy needle. You can give it by that. That is a blunt needle. Or otherwise, you can convert your normal hypodermic 1.5-inch needle of a 10 ml syringe into a blunt tip. How you can do it? By taking a bowel, the sterile bowel which we get for preparation of the patient. You can take a empty bowel and tap it on it. And keep on tapping till it becomes blunt. Okay, so then that blunt needle will be good enough for going through those facial pops. Okay, so tap block is a facial plane block, and landmark guided classically was at the triangle of Petit. It is difficult to palpate, difficult to know the landmarks, so an easy method has been devised, and consistently we do it at this level. It is a midpoint between the subcostal plane and the iliac crest. Midpoint is taken, and in the mid-axillary line, we go with the double plop technique. Forget about the ultrasound in this picture. I just want to show the place of the needle entry. Okay, So the subcostal and the iliac crest, midpoint in the mid-axillary line is the point of entry. How do you do it? You, first of all, you put your needle inside. It is such a lot of force that the needle tends to go inside the muscles. What you do is, you bring it back. That is called the cushion effect. You bring your needle back again to the skin, and then you start feeling for the pops. The first pop comes between the external oblique and the internal oblique, and the second pops comes between the internal oblique and the transversus abdominis. Here you have to give around 20 to 25 ml of local anesthetic for unilateral, one-sided block. Okay. Ultrasonographic procedures are so many. The subcostal approach, lateral approach, posterior, oblique subcostal. In a subcostal approach, this is the cranial end, this is the caudal end. You place your probe in the subcostal plane, right from, start scanning from rectus abdominis, laterally. This is the picture you get. As soon as you see the transversus abdominis muscle, you bring your needle from medial to lateral side, deposit around 20 ml of local anesthetic in this plane. So this is a subcostal tap. Lateral tap again is in the mid-axillary to anterior axillary line, the probe is placed. From anterior to posterior you come. You see these three muscles, external oblique, internal oblique, transversus abdominis, deposit around 20 ml of local anesthetic here. That is the lateral tap. You can see, you can identify in the ultrasound that the internal oblique muscle is the thickest muscle. So that is a point of identification. For posterior tap, you bring your probe more posterior till the transversus abdominis converts into an epineurosis and the QL, the quadratus lumborum, can be seen. Deposition of LA here will be consistent with the blockage of the lateral cutaneous nerve of the abdomen also. So this is the only block where the lateral cutaneous can also be blocked along with the anterior. So this is a chart showing that the subcostal takes care of the T6 to T9 anterior cutaneous branches. Lateral tap takes care of T10 to T12 anterior cutaneous branches again. The posterior takes care of anterior as well as lateral from T9 to T12. There is another new block, that is this oblique subcostal, by which you can anesthetize with one single prick and a long needle, 15 to 20 centimeter needle. You can anesthetize from T6 to L1 all the anterior cutaneous nerves. So that is this oblique subcostal. You introduce your needle from here, hydrodissect it from the rectus area till the iliac crest, obliquely, shifting the probe downwards, and hydrodissect it around, in the literature it is mentioned, right, around 50 to 60 ml of local anesthetic needs to be deposited for hydrodissecting this plane. Even catheters can be threaded for postoperative analgesia purpose. Coming on to the rectus sheath block, concentrate on the middle picture. Anterior rectus sheath is formed by the epineurosis of these two muscles, and the posterior is formed by the epineurosis of this. In a blind technique, it is again a facial plane block. Pop technique can be utilized. You need to palpate between the xiphy-sternum and umbilicus, and the midpoint is taken. 3 centimeter lateral to it is the point of entry for rectus sheath block. In this, a single pop is taken. You enter at 3 centimeter. The first pop will be felt of the anterior rectus sheath, and then you need to go and reside your needle on the posterior rectus sheath. A bounce will be felt, and you need to deposit 10 to 15 ml of local anesthetic in this plane. An ultrasonographic picture of the same will be at the same level. From medial to lateral you go, and this muscle will be identified, rectus sheath muscle. This is the posterior rectus sheath. Then you deposit your local anesthetic here. Okay, so after telling this, I'll just want to know that what are you seeing? There's just two pictures which I want you to tell. This is the rectus abdominis. This is the transversus abdominis. The needle is between them. So what is this? So we have just told that any LA deposited between the rectus and the transversus will be a tap block, right? So it is a subcostal tap. What is this? This is the rectus, and this is the posterior rectus sheath. It is a rectus sheath block because it is between the two layers. Okay, so coming on to ilioinguinal iliohypogastric nerve. This is the L1 nerve, which divides into ilioinguinal and iliohypogastric nerves. And it crosses from the posterior psoas, lateral border of the psoas major, comes anteriorly, lies consistently in the transversus abdominis plane in the posterior side. But at the level of ASIS, the iliohypogastric nerve divides into lateral branch and the medial branch. Medial innervates the suprapubic area. The lateral, the ilioinguinal nerve comes here and pierces this fascia and may lie in between the external oblique and the internal oblique also in some cases. So in a classic, it is also a facial plane block. POP technique can be utilized. You have to go 2 centimeter medial and 2 centimeter above or below the ASIS, and then by a single POP, you will deposit 5 to 10 ml of local anesthetic here. Then by another POP between the IO and the TAM, we will deposit 5 to 10 ml of local again here. That will take care of the IL and the IH nerves. In an ultrasonographic procedure, what you do is you place your probe at this level, from between the ASIS and the umbilicus. You place your probe like this. From medial to lateral, you need to go. And this is the plane. This is the external oblique, internal oblique, transversus abdominis. These nerves might be seen in this plane. Along with that, there is also an artery. So you need to take care that aspiration is always a rule in regional anesthesia. So aspirate and go from medial to lateral and deposit LA in this plane. So there is, in studies, it has also been shown that these two nerves lie consistently in the transversus abdominis plane posterior to the ASIS. So they have also done a 5 centimeter kiphalid and 5 centimeter posterior approach to the IL and IH block, that they have seen that consistently the nerves are blocked. So that can be another approach. Of course, the indications are inguinal herniorrhaphy, occulopexy, bilateral blocks for Fallenstein incision, and for endovascular abdominal aneurysm repair. So the last two blocks, the quadratus lumborum and the erectus spinae. So what is a quadratus lumborum muscle? It is a muscle arising from the iliac crest and going by 4 slips to the L4, 3, 2, 1 transverse process and to the 12th rib. In front of this lies the psoas major, and behind this lies the erectus spinae and the latissimus dorsi. Lateral to it are the aponeurosis of the abdominal wall muscles, which are merging with the QL. So any drug which is deposited around the QL is the quadratus lumborum block. So what is the funda of the quadratus lumborum block achieving analgesia? It achieves very good analgesia. It is a very newer block and it achieves very good analgesia of the whole of the abdominal wall. How it happens? Because there is a fascia of the transversalis, fascia is existing like this, above the QL and the psoas major, which is in continuation with the endothoracic fascia. So it is said that the drug which you give here will go to the, may go to the paravertebral space and achieve somatic as well as visceral analgesia of the whole of the dermatomes. So in a single shot, if you want to give a analgesia from T7 to T11, to L1, then this plane block is a very good block if you're able to achieve the analgesia, achieve the plane. So this is the ultrasonographic picture. It is an USG block. You place, if you have to give a left-sided, you place the patient in the right lateral position, place the probe in the below the subcostal area at the level of L3, and then this probe is placed like this. This is the kind of picture you will see, the transverse process here, ESP here, QL here, and the psoas major here. So it was shown that the shamrock sign you need to know because it is something latest. The shamrock is the a leaf, and this picture resembles a shamrock. So this was shown. So it is a busy slide. You just need to know that 3 approaches to QL, the QL1, QL2, and 3. QL1 is between the transversus abdominis aponeurosis and the QL. QL2 is between the QL and the latissimus dorsi. And the anterior approach, that is the QL3, is between the, it is a transmuscular approach between the QL and the psoas major. It has been seen that the anterior approach consistently, the drug goes to the paravertebral space, and it is much more effective than the other approaches. You can see the dye spread from the QL going towards the paravertebral space here. It is again a busy slide. You can see the dye between the QL and the psoas major, between the QL and the transversus abdominis, and again between the QL and the psoas major. So last block of today, the erectus spinae block. It is a very good block. It is a very important block. A superficial block, even in patients of anticoagulation, you can go for it, and achieves a very good amount of analgesia of the provided surgery. It is a muscle complex formed by spinalis longissimus thoracic and iliocostalis muscle, which runs vertically right from iliac crest till the cervical level. In the thoracic area, you can see these are the 3 muscles. When you place your probe here, it is a block between the erectus spinae and the transverse process of the vertebra. If you place your probe here, you will find that trapezius is the first muscle, rhomboides is the second, and then comes the erectus spinae. Below the T5, only the trapezius and the erector spinae will be visualized. In the abdominal area, again, the latissimus dorsi will be visualized. So the funda here is to put the needle at the level between the erector spinae and the transverse process of the vertebra, and the local will seep. It is a large volume block. The local will seep through the costotransverse spaces in the thoracic level anteriorly, and exert its effect on the ventral and dorsal lamina of the spinal nerve, may diffuse anteriorly to the paravertebral space through the costotransverse and the intertransverse complex, and may diffuse to the epidural space also, and laterally to the intercostal space. Thus it provides both the visceral and the somatic analgesia. It is said in cadaveric studies that around 3.4 ml of injected volume is needed per dermatome to be blocked. So if given at the thoracic level, it has been seen that thoracic space is much more defined than the lumbar space. So if you give 20 ml of local anesthetic at T5 transverse process, it goes 4 level above and 4 level below. If you give the same amount at the lumbar level, it will only go 2 level above and 2 level below. So that is the difference in between the thoracic and the lumbar levels. It is not a pop technique. It is simple. You need to go a needle. You need to palpate your spinous processes. So forget about the ultrasound. See that you need to palpate the spinous processes. The most prominent is the C7. Then you go down, and as you palpate the spinous processes, you will have the transverse process 2.5 to 3 centimeter lateral to it. Okay. So in the thoracic space, what happens is that here is the vertebral body. Here is the transverse process. See, please kindly look at me. Here is the vertebral body. This is the transverse process, but the spinous process is like this. So if you're palpating a T5 spinous process here, the transverse process will not lie at the same level. Okay. So what you need to do is, you need to take the transverse process at a level above it. So palpate the T5 here, but give the local anesthetic beside the T4 spinous process. You need to hit the transverse process beside the T4 spinous process. Okay. At the lumbar level, the transverse process corresponds to the spinous process. So that is the only difference. So you go, you hit at the thoracic level, it is around 2 to 4 centimeter depth, and at the lumbar level, it is around more depth, like 4 to 5 centimeter, the TP can be palpated. So 3 centimeter lateral, vertical down, hit the TP, and just withdraw it 1 millimeter, give your 20 ml of local anesthetic. That will suffice, that will spread in a vertical fashion. In your initial days of study and practicing, what you can do is, after giving it the block, you can place an ultrasound probe there and see the spread of the local anesthetic going till how many dermatomes it goes. Okay. In an ultrasonographic technique, you place your probe here. You can calculate the ribs by the ultrasound itself. The ribs appear rounded. Okay. And as soon as you bring the probe medially, the transverse process starts appearing, and that appears squarish. So this is a squarish picture, which is the transverse process, and ribs are rounded. So you see the trapezius, rhomboidus, erector spinae. Your needle needs to go from kyphoid or caudal portion, hit this, and LA will be dissecting. The last picture, the LA will be dissecting this plane. So you can see needle is coming, hitting the transverse process of T5, and LA is being spread like this. So this is the distribution of the block. Again, a wide variety of procedures, anterior, posterior, lateral, thoracic, abdominal areas, management of acute and chronic pain syndromes, all can be covered in erector spinae plane block. So this is a chart which shows that maximally in thoracic area, the T5 should be taken, TP should be taken, transverse process, abdominal areas T7 to T9, and in lumbar areas, for lumbar surgeries, even from T10 to L2, 3, the block can be given. For hip surgeries, of course, L3 will be taken. Many studies on this done, and okay, so these are my references. And sorry, I have not been able to show my videos because my presentation was very long. So you can go through, we have a YouTube channel for the Department of Anesthesia, HIMSS BBK. We have given a PNS and landmark guided regional anesthesia blocks. All the video presentations are there. You can go through that. Thank you. Any questions?
Thank you, Doctor, for such an elaborate and detailed discussion. And are there any questions?
It's long evening.
Thank you, Dr. Aki. It's a very nicely and elaborating this talk, and it covers all the truncal blocks within a 30 minutes. It's not an easy job to cover all the block in a 30 minutes with ultrasound guided. So hats off to you, Dr. Aki, for that. And especially there's an emerging block like quadratus lumborum and the rectus spinae block, because these are also a block to cover the visceral as well as the somatic pains. All the other blocks like TAP blocks, rectus sheath blocks, they cover only the somatic pains. So this is a very important blocks you can learn from in your institutes through the ultrasound guided. Any questions? Okay. Thank you, Dr. Aki.
Thank you.
So in the last speaker in the session,
Thank you so much, sir. This brings us to the end of our last session. I request Dr. Somnath, sir, to kindly facilitate Dr. Aki, ma'am, with a token of appreciation for a wonderful lecture. Thank you, ma'am. I again request sir to kindly felicitate Dr. Vipin sir with a token of appreciation. I now request Amreen ma'am to kindly felicitate Dr. Tanmay Tiwari sir for his wonderful and precise talk. I again request ma'am to kindly confer Dr. Bhavya ma'am with a token of appreciation for her talk today. Lastly, I request Professor Dinesh Singh sir to kindly honor our esteemed chairpersons, Dr. Armeen ma'am and Somnath sir, with a memento for sparing us the valuable time. With this, we have come to an end of today. To all the sessions of today. We just have a quiz to quickly recapitulate whatever we have studied after lunch. So for that, I invite Shashank sir to the stage.
Before this, please all of you come to the stage and have a group photograph. Consultants and students, please.
Good evening, everyone. It's been a hectic day full of informative sessions. So to end this session, today's day, we have our quiz, session 2. So first question is, an effective hand sanitizer contains at least this percentage of alcohol to kill the coronavirus and other germs. A 30%, B 45%, C 60% and D 80%. जल्दी जाना है तो जल्दी भरो ठीक नेक्स्ट क्वेश्चन cardinal symptoms of respiratory system are all except first chest pain, B hemoptysis, C hoarseness of voice and D cough. Next question, which of the following cannot be measured by spirometry? A. Tidal volume and inspiratory capacity. B. Residual volume and functional residual capacity. C. Expiratory reserve volume and residual volume. D. Tidal volume and functional residual capacity. Question 4. If a patient can blow out a match in a bedside PFT, this means he or she have A. Maximum breathing capacity greater than 60 liters per minute and FEV1 greater than 1.6 liter. B. MBC greater than 40 liter per minute and FEV1 greater than 1.6 liter. C. MBC greater than 90 liter per minute and FEV1 greater than 1.2 liter. And D. MBC greater than 60 liter per minute and FEV1 greater than 1.2 liters. Question 5. Reversibility criteria for making a diagnosis of bronchial asthma. In spirometry test, the post-bronchodilator therapy, FEV1 must have improvement of A. More than 12% and 250 ml. B. More than 15% and 250 ml. C. More than 12% and 200 ml. D. More than 15% and 200 ml. Next question. How long is the average incubation period for Wuhan coronavirus? A. 12 to 24 hours. B. 5 to 6 days. C. 3 to 4 weeks. And D. 1 month. कुछ भी मत भरते रहना. Next question. Difficulty with cricothyrotomy can be anticipated with all of the following except A. Prior neck surgery, B. Hematoma, tumor or abscess on the neck, C. Scarring from radiation on the neck, and D. Class 3 or Class 4 Malapati grading. Question 8. One of the following is a primary risk factor for difficult mask ventilation. A. Inability to bring mandibular incisors anterior to the maxillary incisors. B. Thyromental distance less than 3 finger breadths. C. High arched palate. And D. Limited mouth opening. Question 9. All of these are important points in history taking for airway assessment except A. Surgery or burns or trauma or tumor in and around the airway. B. Long-standing diabetes mellitus. C, history of blood transfusion, and D, history of radiation therapy to the neck. Next question. What is the single best predictor of difficult laryngoscopy and intubation? A, mouth opening. B, sternomental distance. C, Malapati Grading 3 or more. And D, Thyromental distance. Next question. Radiographic predictor of difficult airway is A, occiput C1 spinous process distance less than 5 millimeter. B, ratio of effective mandibular length to its posterior depth less than 3.6. C, increase in posterior mandible depth greater than 2.5 centimeter. And D, all of the above. Question number 12. Food consumption in healthy subjects undergoing elective surgery increases the risk of pulmonary aspiration by all except A, increasing residual gastric volume, B, decreasing gastric pH, C, increasing gastric emptying, and D, decreasing esophageal sphincter tone. Next question. Advantages of reduced duration of fasting are all except A, increase in residual gastric volume and reduction in gastric pH. B, safety and improved patient well-being. C, prevention of hypoglycemia. And D, improved patient compliance. Clear fluids include all except A, water, B, fruit juices without pulp, C, clear tea and black coffee, and D, carbonated water. Question number 15. Exclusions of 146 regime of fasting includes all except A, renal failure, B, enteropathies, problems with digestion and absorption, C, healthy infant, and D, esophageal strictures or those booked for esophageal dilatation. Most effective treatment in severe COVID-19. A, remdesivir, B, dexamethasone, C, baricitinib, and D, tocilizumab. Seventeenth question. In subcostal tap, deposition of LA is between A, rectus abdominis muscle and posterior rectus sheath, B, rectus abdominis muscle and transverse abdominis, and C, any of the above, D, none of the above. Question number 18. USG probe position in PEC 1, PEC 2 and serratus anterior plane block are at level of A, third, fourth and fifth rib, B, second, third and fourth rib, C, any of the above, and D, none of the above. Question number 19. True for tab block. A, local anesthesia anesthetic deposited between external oblique and internal oblique. B, 10 ml of LA is sufficient for unilateral abdominal block. C, lateral tab blocks both lateral and anterior cutaneous branches of intercostal nerves. And D, none of the above. Last question for this evening. Visceral analgesia may be achieved with A. Anterior quadratus lumborum, posterior tab but not erectus spinae. B. Anterior quadratus lumborum, posterior tab, erectus spinae. C. Anterior quadratus lumborum, erectus spinae but not posterior tab. D. Posterior tab, erectus spinae but not anterior quadratus lumborum. This marks the end of today's hectic session. We'll meet you tomorrow at 8 o'clock, same place, and with much more energy.
Try to come at 7:30. 7:30 breakfast will be ready. So by 8 पेट वेट भर के अपना फिर स्टार्ट कर देंगे तो फिर लेट हो जाता है ना चलो ठीक है